Good morning, everybody. Welcome again for this the second day. This is the main conference day, and we start sharp at 8. I welcome Dr. Anjali, Dr. Narendra, and Dr. Rajendra to be the moderators. We start with the plenary sessions, and just like yesterday, I wish that everything would be in time. Please do not exceed the duration, and please enjoy the plenaries. Thank you very much. Over to the moderators.
Thank you. Good morning. Welcome to this session. I'm sure people will be coming in. We have an excellent panel today, and the organizers have been very kind today that we do have a few minutes at the end of the session for questions before the live workshop starts. So please think about the questions, and I'm very happy that I have two excellent co-chairpersons. And without further ado, I think we could get started with the first presentation. It says, Shifting Goalposts in Regional Anesthesia. And we have one of the main organizers, Dr. Gopal. So he doesn't need much introduction. Besides, it's all there. So welcome. Please go ahead, sir.
Respected chairpersons, members of the organizing committee, and dear delegates, a very good morning to all of you and welcome to this session. I hope we all have a wonderful conference and carry back pleasant memories from Pune. Over the next 20 minutes, I'll be speaking on shifting goalposts in regional anesthesia. I must disclose that I have received valuable inputs from Professor Vincent Chan in my literature search for this presentation. Unlike its more illustrious cousin, general anesthesia, the beginnings of regional anesthesia did not have a single eureka moment. Rather, the history of regional anesthesia was colorful and tumultuous and filled with daring self-experimentation by charismatic personalities. By the turn of the last century, the clinical and economic benefits of regional anesthesia were readily recognized, and comparisons began between RA and GA with regard to morbidity and mortality, and there were no clear-cut answers at that point of time. The brunt of adverse effects of poorly treated or untreated acute postoperative pain are borne by the cardiovascular system, and in respect of thoracic and abdominal surgeries, also by the respiratory system. Adverse effects also affect the gastrointestinal tract, endocrine, renal, hematological, and metabolic systems, whereas the psychological aftermath delays return to normal social preoperative function. As per the consensus guidelines of the ASRA and the American Pain Society, central to the concept of a multimodal analgesic regime is either a neuraxial or a peripheral nerve block. Though ultrasound as a guidance modality has been around for more than 2 decades, by 2010, it was being hailed as the unanimous gold standard for regional anesthesia, and that the search for the elusive Holy Grail had ended. Thanks to advances in ultrasound technology, today's images are not nearly as pixelated and present more information per unit area for the benefit of the viewer. And thanks to advances and an increased understanding of microarchitecture of nerves and surrounding tissues, we are enabled to be more selective with needle placement and deposition of injectate with respect to a neural structure. Increased awareness of local anesthetic systemic toxicity owes itself largely to intensive campaigns by ASRA and like-minded bodies across the globe. Today, instances of LAST, however rare, are suspected, diagnosed, and treated with lipolipid, thereby limiting the cardiac-related morbidity or mortality that can be attributed to a local anesthetic. Ultrasound-guided regional anesthesia engineered a paradigm shift from the deposition of local anesthetic in the vicinity of a nerve or plexus after visualizing the neural structure to deposition of large volumes of local anesthetic into interfacial tissue planes without actually having to visualize any neural structures. Today, we have a profusion of blocks to perform, and this generates a tremendous zeal amongst regional anesthesia enthusiasts to perform these blocks. And many a time, these blocks vary by the tiniest of margins or a thin interfacial layer, and these are often accompanied by a suitably clever acronym such as MTP or BRILMA or the SPANK. These three landmark papers in the year 2007 set off the trend in favor of interfacial plane blocks worldwide. And between 2011 and 2013, this man introduced chest wall blocks as a newer concept for analgesia following thoracic surgeries. And this paper in 2016 by Ferrero and colleagues literally caught the world of regional anesthesia by fire like no other paper in the recent past. And today, with just regard to the chest wall alone, we have a mind-boggling array of blocks to choose from. So we need to ask this question, are we having one block too many? And despite the fact that we have a basic understanding of the mechanism of action of most interfacial plane blocks, that of a paraspinal block such as erector spinae plane block is still in the realm of conjecture. And with the notable exception of a few, like the quadratus lumborum block, most of these blocks provide cutaneous analgesia alone, which means that they are not a standalone option for provision of surgical anesthesia. Rafael Blanco is here, and he will be giving his update later on during this session. One of the major limitations of peripheral nerve blocks, as we all know, is the finite duration of action of these blocks. And dealing with the aftermath of rebound pain is a challenge that remains to be addressed. The modes that we have to prolong the action of a block would be perineural adjuncts, liposomal local anesthetics, and perineural catheters. Virtually every single drug has been tried as a perineural adjunct, but amongst a huge list, it is only dexmedetomidine, dexamethasone, and buprenorphine that hold any promise going forward. And of all the drugs that are available, it is only adrenaline or epinephrine that has an FDA approval to be used as a perineural adjunct. We do know that liposomal local anesthetic drug formulations are structured in such a manner so as to gradually release the local anesthetic over an extended period of time, and with regard to liposomal bupivacaine, this is typically 72 hours. Very recently, a liposomal formulation of bupivacaine and meloxicam, which is a non-steroidal anti-inflammatory drug, obtained FDA approval for wound infiltration and intra-articular injections. Meloxicam, being a non-steroidal anti-inflammatory drug, is probably going to make things different when injecting in the surroundings of infected tissue. We also know that we have an array of perineural catheters that we can choose from. we typically use catheters through needles, either stimulating or non-stimulating, and today we also have catheters that go over the needle. But patronage of perineural catheters is limited because it requires additional technical expertise. There is the cost of catheter, pump, and running the infusions. There are complications with respect to insertion and maintenance. And we also know that when we place an interfascial plane catheter, a programmed intermittent bolus is called for to maintain the quality of analgesia. This is a fairly controversial topic, regional anesthesia and long-term consequences. So we just look at the long-term outcomes which regional anesthesia may affect. Now, acute pain, as we all know, is secondary to a noxious stimulus that is applied on the surgical field, beginning with the skin and allied structures. Acute pain responds to tissue damage. It is protective, adaptive, and self-limiting, and its evolutionary nature is to prevent behaviors that may impede or impair normal tissue recovery. Therefore, persistent post-surgical pain is something that persists beyond the normal duration of healing, which is typically not more than 8 weeks. And any analgesic regime that we may choose or design for the patient must be able to anticipate, prevent, and modify the nociceptive barrage, thereby limiting the pathological central sensitization. As I said just a while ago, pain during surgery is the result of a nociceptive input from the primary surgical site. This alters the synaptic strength, and therefore the signal transmission from the primary order neuron to the secondary order neuron is altered. And this pathological change can be blocked by local anesthetics by a variety of actions. One could be anti-inflammatory action. The second could be the prevention of ectopic firings of neurons, limiting cytokine expression, and also neutrophil priming. Can anesthetic technique influence cancer outcomes? The possibility of a causal link between your perioperative anesthetic technique and metastasis at a later stage following a curative surgery for cancer dates back to the publication of these two articles by Donald Buggy and colleagues in 2006 and 2008. Though this has generated tremendous interest, today we also have fellowships in oncoanesthesia, of which regional anesthesia is a central component. I must say that at this point of time, we do not have enough ironclad evidence to promote or recommend a particular anesthesia technique for curative surgeries of patients with cancers. So we look to answers from prospective RCTs, such as the volatile anesthesia and perioperative outcomes related to cancer, the VAPOR-C trial, which is a large multi-country, multi-center trial, which tends to compare sevoflurane versus Tiva with propofol, the beneficial effects of intravenous lignocaine in patients coming in for colorectal and lung cancer surgeries. GA Cares is another prospective RCT that is ongoing in the state of New York in patients who are coming in for 8 different cancer surgeries. And this trial typically compares Tiva with propofol and volatile inhalational anesthesia. So once these 2 prospective RCTs are completed, we will have certain answers which may lead to the recommendation of a particular perioperative anesthesia technique. We'll just look at a few new modalities in the offing. When patient-controlled analgesia came into being, it shifted the mode of analgesia from a scheduled mode to a requested mode, thereby making it patient autonomous. The patient had a role to play in choosing his or her analgesic at the time he or she wanted. If, for example, an artificial intelligence algorithm based on feedback from certain parameters can be built into existing PCA pumps, then the focus of providing analgesia will further shift from provision of salvage analgesia to that of preventive analgesia. And this can limit central sensitization further going forward. This is a work in progress. Hopefully, we will have it with us in the near future. And this was a recent publication in this month's RAPM by Bansui and colleagues. And this speaks about the role of neuromodulation in acute pain settings. As per the International Neuromodulation Society, neuromodulation is defined as the alteration of neural activity by the targeted delivery of a stimulus, either electrical or chemical, to specific neurological sites in the body. Typically, it is chronic pain settings which utilize electrical stimulation for provision of relief from chronic pain. But if we were to have a catheter for regional anesthesia, wherein in the first few days after surgery, we can provide a chemical stimulus by infusion of local anesthetics, and then move on to the provision of an electrical stimulus thereafter, intuitively speaking, the patient will have the best of both worlds. At this point of time, such catheters are frightfully expensive, and in time, we will probably have catheters that we can use for all our patients. And finally, we look at the challenge going forward. We need to ask ourselves this question: is regional anesthesia at a crossroads today? There seems to be an ever-widening gulf between regional anesthesia enthusiasts and general anesthesia enthusiasts, and the latter believe that the field of regional anesthesia is too complex and too intimidating. There are so many blocks that they need to keep track of and need to keep pace with. Therefore, at this point of time, there needs to be a change of perception from one of novelty to one of core acceptance. The broader question that we need to ask ourselves today is not whether we need more blocks, but how best to deal with the blocks that we already have. The basic blocks package, it aims at improving outcomes, efficiency, and acceptance while reducing disparity as far as the patients who will be receiving these blocks by a variety of anesthetists are concerned, is targeted at general anesthesia enthusiasts. And we must ensure, as regional anesthesia enthusiasts, that every single anesthetist can perform the blocks that form part of the basic blocks package. And we regional anesthesia enthusiasts can have a plan B, plan C, and plan D also. But then ensuring that everybody has a plan A is of paramount importance. And these are the core components to increasing patient access to regional anesthesia. So we select high-value nerve blocks. We ensure that there is widespread competence amongst our community. And then we ensure that we create certain protocols whereby the pathway is implemented in all patients. Different surgeries, as we know, have different pain trajectories. Yet, no two patients respond in a similar manner to pain, despite the pain generator and the surgery being the same in two different patients. Therefore, we anesthetists, for each patient, must design the right intervention at the right time for the right duration. And personalized pain management will depend on patient factors, surgical factors, the resources that we have at hand while making an attempt to stick or adhere to ERA's principles. And finally, in conclusion, as regional anesthesia forays beyond the provision of acute pain relief alone into newer and newer domains, we must endeavor to distance ourselves from a complexity bias. Too many blocks for the few is not the dictum. The dictum should be a few blocks for the many, so that regional anesthesia becomes a core component of perioperative care for all patients coming in for all surgeries by all anesthetists. I thank you for your attention. I look forward to your august presence and robust participation next August in Hyderabad. Thank you, sir. Thank you.
Hello. Thank you very much, Dr. Gopal. It was on the dot, actually. We still got, one more minute, but we're going to carry on with the next speaker. So I'm going to call upon Dr. George Fegi. He's basically the anatomist, and he's going to talk on brachial flexures, going into very much into detail. So, Dr. George, please.
Thank you very much, Mr. Chairman. The audience, it's now the third time talking about the brachial plexus, so I hope it's not getting bored again. Anyway, I just want to give you some more information, a little bit about anything what might happen over there, and also a little bit an input concerning the technique, maybe a little bit changing, adapting to get a better and efficient block. Well, so that's why it's called additional brachial plexus anatomy. You already heard the anatomy yesterday. So, let's start. Originally, I'm from Austria, so it's quite a challenge to work in Germany. For Austria, Germany is not the big brother. We are focusing on our German neighbors a little bit with stress, especially concerning soccer or football, because they are better. They are world champion, we are not. We are just champions in analyzing everything. But anyway, I'm working over there. So see, Germany is quite large. So I'm working in the middle part, Midwest, which is called Nordrhein-Westfalen, an area which you can go to now because coal mines are closed. And it's getting green, so it's somewhere around in the middle of it. It's Witten. Witten is a very small city, about 100,000 inhabitants, which is, compared to the other cities over there, quite small. And it's a private university, unfortunately. But anyway, this is my way, working place. I live in Graz, so a little bit far away, about 1,000 kilometers, but not that bad. This is the main building. I say, oh, beautiful. Yeah, that's the main building. Unfortunately, the anatomy is in a factory hall. So, wow, very charming. But you will see some images. We're brand new concerning the infrastructure, so that's not bad. Let's go now to my topic, brachial plexus. You see the different areas again, concerning the most important, or let's say the most important two areas are the interscalene gap and the supraclavicular region. Because you perform so many blocks over there, especially concerning shoulder surgery, and I just want to give you an input concerning also nerves you should take care of, and also bring you up a little bit the anatomy over there, the special anatomy, why it's causing problem and so on. Then, of course, you get the infraclavicular region we talked about yesterday, and also the axillary fossa. I want to give you a little bit the topographic anatomy now, more precisely, and a little bit longer, and what happens over there, and why you should also take care of some other nerves, which you regularly, if you perform the axillary block, not reach at or with the existing techniques. So, you see now several arrows. The green arrow is the way how you get to the interscalene block. The red arrow is the area where you perform the supraclavicular blocks. Infraclavicularly, of course, you can go laterally, vertically, whatever. You see the cords already being formed. And then in the axillary fossa, the green arrow is really at the area where you see the latissimus dorsi in the back. So this would be the area where you perform the axillary block. And you can see this dissection with an abducted arm. Well, that's fine. It gives you an impression how the nerves are running, but they do not really present the reality at all. Because there's much more. There's not only nerves about that. There's much more about the tissue which is surrounding, covering. So this is something what you have to take into consideration when you perform blocks, and which might give you some stress because your local anesthetic is not running that way you want to have. So let's focus now a little bit on the interscalene gap. The interscalene gap is over here visible with an elevated shoulder, or let's say a little bit moved up. So you see the also caudal part of it with the artery and the brachial plexus exiting dorsal to it. And this is a very important topography. The plexus is always dorsal, and that's caused by the embryology. Anyway, there are different, let's say, morphological structures which can separate artery from the brachial plexus. You know them. They are described since more than 150 years. It can be a muscular structure like the scalenus minimus muscle, or ligamentous fibers, which are the costopleurovertebral ligament, as an example. So there are different structures which can really separate your structures from each other. And don't be nervous, don't be afraid of it. Well, they are frequent. Yeah? So the interscalene gap, it's really a gap. It's not a space. It's filled up, unfortunately, too. And one important thing is the prevertebral fascia, which is covering the entire structures. The prevertebral fascia is a very thick fascia, especially when you know you're performing the classic technique, the electrostimulation guidance. You have a second resistance in the deep, which is the click of your prevertebral fascia. That was the old way, prior ultrasound guidance. And this fascia, as you can see over here, is really enveloping the deep muscular structures, but also the phrenic nerve. So he's part of the fascia. He's a little bit close to the fascia, but if you remove the fascia, you can slightly work with your scalpel, and he stays on the anterior scalene muscle when he's crossing to the medial area. This fascia is important because if you go underneath, and you have to go underneath to reach the brachial plexus, forms a space or limits a space which continues in different directions. And if you use high volumes, and they used to use high volumes, if you remember Vinny with his 40 ml at the very beginning, you have to think about what are doing 40 ml in such a space. Well, they are searching for a place, and they will spread. Sometimes not as you like to. Okay, let's go now to the prevertebral fascia. You see the prevertebral fascia in the next slide, slightly elevated. And then if we elevate a little bit more, you see with the phrenic nerve on it. It's in the space. So if you have an injection to the brachial plexus, it might reach also your phrenic nerve in this area, more caudal, more medial, or more cranial, depending on the volume and on the spread of the volume. a cross-section with the prevertebral fascia, this dense connective tissue layer, at level of C7. As you can see, this is the transverse process, the posterior tubercle. Anterior tubercle is just a slight bulge, nothing more. Regularly not that well visible, but sometimes clearly visible because being a neck rib. But you see, the brachial plexus, in between with muscular bridges, in between anterior and middle scalene muscle. If we enlarge it, you see the close relationship at that level to the phrenic nerve. And just yesterday, when we saw the image of Netta, one of the most wonderful drawings and used atlases, you had the phrenic nerve just anterior to the anterior scalene muscle, far away from the brachial plexus. This is at level of C7. Watch out the distance. This is less than half a centimeter. So sometimes the drawings do not give the correct impression and the correct topography. And if you insert now a needle and put the volume in between the superior trunk and C7, where you regularly are with your needle, with the medial direction, guess what? I'm sorry. Sometimes this is the reality too. And you will see even more. What is also important, the continuation of a space. The continuation of the space means if you stay underneath the prevertebral fascia, you always have to have a risk to go medially into the vertebral canal because it's the same space. The epidural space is a continuation into the prevertebral space underneath the prevertebral fascia. So if you inject a high volume, higher than 5 milliliters, you get a risk to get medially. That's for sure. You can go medially inside of the vertebral canal. You can go medially ventrally into another triangle, which is not quite nice because that's a really frequent highway. Like that. This is the scalenovertebral triangle. If you want to go there, okay. What's in there? Just something like the stellate ganglion, vertebral artery, phrenic nerve, recurrent laryngeal nerve, vagus, some other arteries, some more veins, some more sympathetic fibers. Oh, great. But that explains a little bit more, does it? So if you go, you get this spread, maybe, with high volumes, or ventrally, same space, doesn't matter. So medially, to get medially with your volume is not dangerous, but it will cause some side effects. Something new? Oh no, not at all. You know the literature. It is mentioned, but sometimes not really regarded. Also this one. It's a quite interesting, let's say, interpretation, because actofascial and so on. So the brachial plexus sheet, which is a little bit something like a myth. From my point of view, also after the dissections, it doesn't exist. So you do not see it in ultrasound as an example. You do not see also some fascial structures in most of the drawings. By the way, there is an important error in this image, not only because the clavicle looks like a fibula or whatever. The brachial plexus is ventral to the artery. Nice. So sometimes you get incorrect information due to whatever, lacking knowledge or what the drawer or the designer has no anatomical knowledge, and also the reviewer didn't look like properly, like over here. Wonderful image, isn't it? Wonderful drawing. I would love it. The problem is this is not the first rib, this is more a second rib. The second is you got too many nerves reaching the brachial plexus. The phrenic nerve is running in a course, doesn't exist at all, and the brachial plexus sheet does not exist either. So you get so many errors in one image, but you're following it. This is one taken out of one of the regional anesthetic textbooks. Something like that. Nice drawing, but lacking any fascias. Fascias which are so important, as you already saw. This is really not taking reality. By the way, injection of 20 milliliters following Winnie's technique, 20 ml, not 40, 20, reaching the aortic arch in very many cases. So you see, the prevertebral fascia is a very dense wall, limiting your space and also prohibiting sometimes a very good spread. So as a consequence for this area, anything what is larger than 5 milliliter, you really should consider if you really want to inject. You get an unwelcome spread. You have to be aware of any, let's say, variations over there. And one of the other structures over here in the supraclavicular region, as an example, is the so-called corner pocket, causing you some deep troubles because you do not get to the inferior trunk. Why? Is there any morphological structure? Answer, oh yes, unfortunately. As you can see it over here, enlargement, supraclavicular region with the omohyoid muscle, prevertebral fascia underneath, and then we go deeper, you see the brachial plexus, just side to the subclavian artery, suprascapular nerve already arise. And if we go even deeper, some arteries passing by, like the deep dorsal scapular artery, quite frequent. So if you go into the supraclavicular region and you find something which is pulsating and it's not the subclavian artery, that's just the dorsal scapular artery. Very frequently, about 30%, passing through your brachial plexus. And what about the corner pocket? This is now just prior removing or elevating the prevertebral fascia. This is the prevertebral fascia elevated with the superior trunk, middle trunk, and over there you see the fascia. This fascia is really covering the entire inferior trunk. And that explains if you just stay at the superior trunk, you might not reach the inferior trunk due to this fascia. Do you see it in ultrasound? Oh yes. And that's explaining why you have to go through this fascia to get the inferior trunk too. That's visible. You just have to take a look on that and know what you're looking for. Okay? At the very first moments, we also just took a look and say, yeah, that's the inferior trunk. We didn't see this white line. We didn't recognize, oh, that's the fascia. Later on, after years, because of you. You said, hey, I got a problem with the inferior trunk. I have no why. So we had to take a look on that. So next thing, why going medially with your needle? Why having a medial directed needle? No idea. That's why we had a publication about the lateral directed needle following the parallel topography of the brachial plexus with a lateral directed spread. This was an injection of 20 ml, and the nerve, the phrenic nerve, is spared. Nowadays, we perform it with ultrasound and reduce the volume a little bit. We are now at a volume of 2.2 milliliters for shoulder surgery, 2 ml for the brachial plexus, and the 0.2 for some others. Because now we have to think about, is it safe for shoulder blocks? No. Because there are some other nerves missing, and these are the supraclavicular nerves from the cervical plexus. So you have to think about them too. And these are the 0.2 ml, because we perform an additional block of the supraclavicular nerve trunk when he has pierced the prevertebral fascia and then dividing into the different nerve fibers. Visible in ultrasound? Yes, absolutely. I can show it to you if you like to. I already did yesterday to some. Okay, so you see the supraclavicular nerves, quite in close relation, but superficial to the prevertebral fascia. So easy to identify and easy to block at that time. What about the others, supraclavicular regions and interscalene gap? To sum up a little bit, I give you 4 goes. Yeah? First, go lateral with your needle. Think about it. Then, go lower with your volume. If you're precise with a needle, volume can be reduced. The volume is already used by my colleagues since years. It's running pretty well. Yeah? Go into the pocket if you need to. So really pierce the fascia, and especially think about the supraclavicular nerve. So go superficial. 4 goes. And then you really get into no troubles anymore. Okay, axillary fossa, just a short overview. What do you not reach? There's intercostal brachial, medial cutaneous, and the axillary nerve. And the reason is quite easy. You get also 2 fascias over there. So you get the superficial and the deep axillary fascia with the deep axillary space and the subfascial axillary space. This would be the regular place for injection. So you know this. Redundant. And over here you have now the area of the deep axillary space with all the fascias, and the cross-section with the nerve fibers surrounding the artery. And this is the most important thing. Got 11 seconds. You see the fascia elevated, but even inside you have fascial tunnels, which means they are separating the nerves from each other. And this you have to take into consideration when you perform the blocks. It is a very important thing, because then you have to take the sniper technique. And if you want to have the intercostal brachial, you have to go into another space, which is the subfascial axillary space. Is it visible? Yes, indeed, it is. Okay? So you see, you have to take the sniper method. 1 for each. Okay? That's it. Okay, from my point of view, I just want to conclude now, give you some impressions, short ones. This is now our workshops, masterclass, where we dissect also with the proof, you see, with the cadavers which are flexible, quite nice, almost lifelike indeed. Also you can see some guys you already know, like Paul Kessler. So Ezra is also representative. And anyway, you see, we are not at the limits. We are not at the end. Still a long way to go, sometimes a little bit, hard, difficult. But anyway, we will grow and we will get better. Thank you.
Thank you, Dr. Figel. That was, again, a very illuminating and thought-provoking talk. And we'll come to the questions at the end. And now I'd like to invite Dr. Philip Lerck to give his talk on insights into the neuromechanisms of action of local anesthetics. And he's a very well-renowned anesthetist, a regional anesthetist. Welcome, Dr. Lerck.
Thank you so much for those most kind words, for the kind introduction. A heartfelt Dunjuvat to the organizers for inviting me here. It's a pleasure and privilege to be here. I look forward to 2 days of interacting with and learning from such a wonderful group of colleagues. I am especially grateful for having been given this topic to talk about, because local anesthetics, they're at the core of everything we do, and they're a little bit of a passion of mine. I would like to update you on some things we learned in the years past about new insights into the structure of the voltage-gated sodium channel as our primary target, about the local mechanisms of action, there are 5 of them at least that we know, and a little short glimpse into the future. The disclaimer is that this is a very brief talk, and there is a master class in the afternoon. I apologize for the shameless plug, which is an hour and a half, and where I prepared some topics that we might go into more detail in that I can only touch on briefly here in this lecture. I have no commercial conflicts of interest. All my funding was from public sources, other than a very, very keen interest in the local anesthetics. They are just so fascinating. But we can't talk about them without considering first the primary target, the voltage-gated sodium channel. A transmembrane protein, you see here the extracellular side, intracellular side, the alpha subunit, the beta subunits, the alpha subunit being the main component and the beta subunit being a modulatory section. What is fascinating, just similar to general anesthesia, is that we actually only began to know what this exactly looks like about 15 years ago. Until then, we were injecting local anesthetics with great success for about 100 years. We now know the molecular structure of this channel, and when we look at the voltage-gated sodium channel, it has an alpha and a beta subunit. We stick with the alpha subunit because it's the most important one. This is where everything happens. It has 4 domains you see here, how they group together to form this channel that allows the access of sodium ions into the cell. And they are named domain 1 to 4 in Roman numerals. Each of those domains has 6 segments, S1 to 6, and you see these connecting loops. What do these elements do? The S1 to S4 segments are the sensor segments, so they sense the membrane potential in adjacent regions, and when the membrane potential changes sufficiently, they'll tell the sodium channel to go, 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 and initiate the action potential. And sections S5 and 6 in these connecting loops, they form the pore, they actually make it happen. How does it look like when it folds 3-dimensionally and is inserted into the membrane? This is crystallographic images that are just about 10 years old from bacteria voltage-gated sodium channels. Side view, lateral view on the left side, top view on the right side. On the left side, you can appreciate the extracellular space, how this funnels in, and then you have the central channel for the sodium fluxes. On the lateral, on the right picture, you have a top view where you see D1, 2, 3, 4, forming this alpha subunit that makes everything happen. Let's stay with this for a little bit longer. We look at it from the lateral side now. This is a lateral view, as if we were in the lipid bilayer looking at the sodium channel. We can differentiate within this channel several important sites that are very vital to what we do, to the local anesthetic deposition and its effects on the sodium channel. You see the outer pore. It's also referred to as site 1. This is where a compound such as tetrodotoxin bind. And they change the dynamics of the voltage-gated sodium channel by basically putting a plug into it. Then you have the central cavity, which is harboring the local anesthetic binding sites. This changes the dynamics of the channel by inducing a conformational change, largely reflected in the inner pore and the activation gate down here. And what you also see here is that there is lateral fenestrations in the sodium channel. These lateral fenestrations are contiguous with the lipid membrane bilayer, so they are an access route for drugs compounds. It is believed that, for example, benzocaine, a very lipophilic local anesthetic, mainly gains access to this local anesthetic binding site this way. And it would not be complete to discuss this without mentioning that there are a multitude of binding sites for drugs and toxins on the voltage-gated sodium channel that can modulate how it behaves. We know of at least 8 of these binding sites that are very well described and localized and analyzed, and that have been shown to be of relevance by knockouts and by other techniques in the molecular biology realm. They include spider, scorpion, and other toxins. And site number 8 is where our local anesthetics bind. And it's interesting to note that this is not a perfect fit for the local anesthetic molecules. Other molecules, such as anticonvulsants, antiarrhythmics, and antidepressants, can also bind here. As a matter of fact, if you put tricyclic antidepressants on a nerve, it'll take a little while for them to work, but they will provide a very long-lasting block. Okay, so how does this work now? How does the local anesthetic get to its receptors? And this is the mechanism number 1 I want to discuss with you, the classical mechanism of local anesthetics. You know that they act like weak bases, that they are formulated as hydrochloric salts. So depending on the pH of the surrounding tissues and the pKa value of the drug, they exist in an equilibrium between the uncharged and the charged version. And only the uncharged version, the free base, can traverse across a concentration gradient into the cellular membrane, into the cytoplasmic space, conjugating with a hydrogen ion and then reaching the local anesthetic binding site from the cytoplasmic site. Interestingly, this concept was coined about 40 years ago by this lovely gentleman, Professor Strickert, who just retired last year. And I would like to give a big shout out to him because he devoted 40 years of his life to elucidating the dynamics of the voltage-gated sodium channel and its importance for regional anesthesia, acute and chronic pain medicine. And he did a series of very thoughtful experiments without even knowing precisely how the receptor works, where the binding site is, to demonstrate this concept, and it still holds true today. What Dr. Strickert's always reminded everyone in every lecture is that the binding of the local anesthetic to the binding site is extremely complex. First, we need to consider what part of the local anesthetic binds the receptor. And a very interesting experiment was undertaken by Martin Löwer in Liverpool. He basically took lidocaine and began to chop little parts away from it. And what he was looking for was the smallest local anesthetic molecule in the world. Basically, the smallest unit that would still give us sodium channel blockade. And this is it, 2,6-dimethylphenol. This is the smallest local anesthetic. Very brief acting, very weak, but this is, so to say, the smallest unit of local anesthetic. So the aromatic part binds to the local anesthetic binding site, and the positively charged amide group protrudes into the channel's lumen. But the binding of local anesthetics is more complex. We often imagine local anesthetics to bind to the receptor in a very one size here, one size there, like a key to a lock. Then you turn it and you turn off the channel. But it's not that easy. So we often say that local anesthetics give a block for 4 to 6 hours, but it doesn't mean the local anesthetic stays at the receptor for 4 to 6 hours. It just means that for 4 to 6 hours, there is a pool of a sufficient number of local anesthetic molecules in the vicinity of the local anesthetic binding site and of the sodium channels to allow for a continuous association and dissociation game, a continuous fluid, three-dimensional complex process, which is more like a competitive antagonism against incoming nerve impulses rather than a true full block. So that the binding site for local anesthetics is actually a three-dimensional pocket. In our three-dimensional drugs, they snuggle into it, every local anesthetic a little differently, everyone with little different residues, and sometimes it takes more than 1 or 2 residues, as is also the case with the toxins, to achieve the full blockade. I wanted to use a metaphor to explain this one more time. And when I arrived here, I arrived in Mumbai yesterday morning, and in rush hour we drove into the city, so I thought a traffic metaphor would be perfect. A conventional view of local anesthetics is that we give them and we just interrupt nerve impulse propagation. And that's like a car driving into a wall. The street is the nerve, the car is the nerve impulse, the action potential, and the wall is the local anesthetic. And we say, here and no more. The car crashes, it stops, and the impulse is gone. But this is not the way it works. I would propose that it's much more like a puddle. So the street is the nerve, the jeep is the action potential, and the puddle is what we try to create with the local anesthetic. Meaning if there is an equilibrium between the strength of the impulse and the deepness of the puddle, or the density of the block. If the block is not super high concentrated and super highly concentrated in both dose and concentration and volume, then a very strong impulse may still get through. And we see this in clinical practice. For example, you have a patient that has a tibial plateau fracture, give him a nerve block. You deliberately use a lower concentration than in the pumps of 0.1 to 5% for continuous infiltration. And we know and we somehow anticipate that if it's the usual postoperative pain, low-level pain, that should be covered by 0.1 to 5%. But if the patient develops compartment syndrome and gets a very intense pain, that pain will likely break through a 0.1 to 5% bupivacaine solution and nevertheless create a very strong painful impulse. And the reason again is because it's not a wall that we build up, it's a puddle we create. And it's a very dynamic process, more a competitive antagonism between the impulse and the local anesthetic binding. And the time constant, how long does the local anesthetic actually bind to the sodium channel before it dissociates again is a fraction of a second. Okay, now let's assume the local anesthetic has successfully bound to the receptor. What does it actually do? What are the 5 mechanisms of action? The first mechanism of action is an immediate conformational change in the voltage sensing segment and the activation gate, precluding any further activation of the sodium channel. This is the main function. The other 4 are supplementary. Another minor effect, we talked about the positive charge protruding into the pore, acting as a repellent against the positively charged sodium channel, traversation of sodium ions. And then there is a third, and this is, I think, an important point, a third mechanism. What happens to the base form? And this touches on a very important concept. Everything we do in regional anesthesia is a concentration gradient. From the moment we inject the local anesthetic until a local anesthetic molecule, one of them binds to this local anesthetic binding site. Everything is a big concentration gradient. And we inject supranormal, highly overdoing it, volumes and concentrations of local anesthetics because we need the concentration gradient to get across all the barriers, fascias, planes, and across all the little things. Imagine even here, equilibrium, only a part of it goes through the membrane. Again, a concentration gradient, only a part of this is conjugated and blocks. So we lose local anesthetics all the time in every little step along the way. So that means there is a lot of the uncharged form here in the local anesthetic B layer, just as a matter of this concentration gradient. And there is new research just a couple of years old. The blue one is the conjugated form, H+. The green one is the free base, and you see that the free base is the one that can traverse, conjugate, and act at the local anesthetic receptor. But you see that the free base, so the uncharged form, can also enter into the channel via these lateral fenestrations and contribute to sodium channel block. The fourth mechanism is that the local anesthetics are embedded in the membrane itself. And when molecules as large as local anesthetics get embedded in the cell membrane, they change its properties. They change the membrane fluidity and its dynamics, meaning they get embedded and they suddenly modulate how the channel can move and can open. They can bind to the beta subunit and amplify the blocking effects. So there is a big new concept about membrane fluidity changes by local anesthetics that they may actually contribute a lot to the effects we see. And the mechanism number 5, again, we come back to this concentration gradient. So you see here, just as one example, we inject 1% lidocaine next to a nerve. That's 40 millimolar concentration. And by the time we are at the sodium channel, we are down to about an estimated 1 millimolar. So we've diluted to about 1 or 2% of the original concentration by the time we get to the sodium channel. And all the rest is a big concentration gradient, just physically trying to get the local anesthetic across all those barriers to diffuse in. And that's great because 1 millimolar is all we need to block the sodium channel. If you isolate the sodium channel, in electrophysiology, you put 1 millimolar lidocaine on it, it's enough, it's done. But we inject 40 millimolar because we lose local anesthetic all along the way, such that if we go to the big blocks, the big high volume blocks like 40 cc of 0.5 bupivacaine, you can be sure that more than 90%, maybe more than 95% of those local anesthetic molecules we inject, they never see a sodium channel. They're just there for the concentration gradient. But what happens to them is that they are taken up into the systemic circulation and to adjacent tissues, and they have, because local anesthetics are such generic drugs and not very specific drugs, they have the potential to interact with lots of other structures, such as ion channels that are related evolutionarily, calcium, potassium, NMDA receptors, and G protein coupled receptors. The latter are very important because they are at the core of why we would consider giving local anesthetics intravenously and why this concept of systemic local anesthetics has become such a big focus of the last 20 years. G protein coupled receptors, you see here, are one of the main pathways in perioperative systemic inflammatory response. They are involved in pain, neurogenic inflammation, and related syndromes such as itch. And importantly, their inhibited concentration is not 1 millimolar or 1,000 micromolar as is for the sodium channel, but it's 50 to 100 micromolar, so way, way lower. And at those concentrations, lidocaine or other local anesthetics, but lidocaine is the safe one, have a strong anti-inflammatory but not immunosuppressive effect. And that is the rationale for all we say about the systemic effects of local anesthetics. I would like to close off this first part of the talk by saying, if we look at local anesthetic mechanisms of action, we first need to consider the structure of the ion channel, and we learned a lot about its architecture, about the binding sites of toxins, how we can use them maybe to amplify our local anesthetics. We gained insight about the dynamics, about the mechanisms of action of these local anesthetics, but first they need to bind. And we saw that the binding is a complex, three-dimensional and fluid process, a constant interaction of association and dissociation with a time constant of a fraction of a second. The aromatic ring of the local anesthetic binds to the local anesthetic binding site and elicits at least 5 mechanisms of action. The first one is the conformational change in the local anesthetic target, the voltage-gated sodium channel. The second one is the positive charge protruding into the lumen. The third is the free base diffusing towards the receptor through the lateral fenestration. The fourth one is membrane fluidity, and the fifth one is systemic action of local anesthetics, more relevant the higher the concentration and the volume you inject. Local anesthetics are anti-inflammatory when given systemically. We're still figuring out best indications and best practices after initial large enthusiasm, something we can discuss at today's masterclass. So just one more slide about what lies in the future. Dr. Gopal in his fascinating talk already alluded to a little bit of the future. We have current options to tailor our block to what the patient needs. We need to know, as Dr. Gopal said, what the pain trajectory for the surgery is, what the period of time is we want to cover, and then adapt our local anesthetics. The problem is that the more we want to extend our local anesthetic duration of action, we do this primarily by adding adjuvants or by increasing the dose we administer, because the initial peak concentration in the nerve determines how long the block will last. So if we cut down on local anesthetics in an attempt to limit side effects, we will also cut down on local anesthetic duration. But we still do reasonably okay. So we can adapt to several hours, but there is a limit to what we can reach. We can reach differential blockade, but not because the drugs are so perfect, it's because we manage to titrate them well. And so what lies in the future to hopefully make our drugs more powerful? Dr. Gopal already mentioned the combination with non-steroidal agents as one method to increase the potency of our local anesthetic drugs and maybe to balance out a little bit the effects. A second one is to couple it with toxins. There was a series of articles about bupivacaine being combined with neosaxitoxin, and that's actually been bought by a pharmaceutical company, Grünenthal. We'll see whether they make a medication of it, but that concept has also been proven. We heard a lot about slow-release formulations. Exparel was heralded as the 72-hour local anesthetic. Recent evidence would say that we should take that assertion with a grain of salt. Another avenue is to block nociceptive fibers specifically. That means to channel local anesthetic into fibers using proteins that are only expressed on pain fibers. And the third is to develop antibodies or peptides that block specific pain-related channels. But these are very expensive modalities that are likely only available for chronic pain patients and not to every patient that comes into our operating rooms. My take-home messages are, I try to introduce you to some new insights into the structure of the voltage-gated sodium channel. We are now aware of its architecture, of the complex binding sites residing on the sodium channel. We talked about the complex binding that takes place, which could also explain a little bit about local anesthetic resistance cases. The mechanism of action, we said, is fivefold. Conformational change, positive charge, uncharged form diffusing through the lateral fenestrations, membrane fluidity, and systemic action. And what lies in the future? We can mix drugs, we can slow-release formulate drugs, and we can also in the future attempt to go after the fibers that actually cause the pain, specifically targeting nociceptors while leaving other sensory fibers and motor fibers alone. It's an exciting time to be in regional anesthesia. We heard the techniques are improving, the blocks are improving, our techniques are more widely adopted, and I hope the drugs will keep up to give us new local anesthetics, new formulations, so we can also get better in the pharmacological sense, taking care of our patients. Thank you very much for your kind attention.
Thank you, Philip. Excellent talk. Philip with two P's. We miss you in Europe. He left for USA. We used to work together in the Prospect Group. Excellent talk, particularly for the future. As you say, this is exciting times. And I was impressed with this. Now we know 5 mechanisms, but also that in the future, maybe we could block the pain-related channels. That I find very fascinating. Another fascinating fact is I see so many ladies here. In many countries, I travel to many countries, and countries like Turkey, some other countries too, but I noticed that there are more females than males. And that's not a topic today, but it's very fascinating. So the next speaker, and also we've been given a few minutes extra for questions, so think about questions. We have excellent speakers today. Doesn't happen every day. Take the chance to ask some questions. And also, I'd like to introduce the next speaker, Rafael Blanco. I don't see him. There he is. Oh, he's online. Oh, okay, I didn't know that. Hi, Rafael. He's done some great pioneering work, and also there's a huge amount of discussion about these facial plane blocks, a lot of confusion about it. So Rafael, tell us what to do now with all those multiple blocks. Thank you. Yeah. You have to unmute yourself. And of course, you can't hear me.
Can you hear me now?
Yeah, we do.
Yeah,
Go
yeah.
ahead, please.
Thanks for sending me the order, guys. Okay, thank you. Can you hear my screen?
Yes, everything is fine. Please go ahead.
Well, thank you very much. I'm really sorry not to be there. There were some technicalities and issues. I will try to be very brief in this lecture, just so you can continue there and enjoy an amazing time in India. So these updates and faster plane blocks are going to be, I would say, I'm trying to be just summarizing things rather than trying to give a master lecture on updates. In this very short talk, my objectives will be very simple. Number one, to do a slight revision of what's up to date up to 2023. Some updated anatomy that I found it very relevant and it works in line with the way I'm thinking right now about facial plane blocks and the mechanisms. A very personal clinical impression. You know, people that know me well, you know I'm very controversial most of the time, but I'm always trying to reach to the important things. And finally, to give you some conclusions. So, to cut it short, there's no consensus about the mechanism of action. There are different views about these blocks are working, but it is very difficult right now to power one mechanism or one explanation against another one. If I put you in here, what the term idiopathic means, and you need to go back hundreds of years into your books, it is a term that's often used to describe a disease, right? But with no identified cause. It may be a diagnosis of exclusion, and this is very important. However, where a specific minimal investigation needs to be performed to define idiopathic is not always clear. So what does it mean? It means that the mechanism of facial plane blocks, there are many multiple theories, but a main core theory still need to be really presented in a more convincing way. We always try to do our way of that things, but there are other views about this. So what do we know about them? Hello? Yes? Yes? Okay. Can you see my screen? Ah, only the first slide, so it's not moving. I think that's a great idea. Okay, let's have a look. Okay. Got it?
Yeah.
Got my screen?
Yeah, that's better.
Okay. Okay, now let me go into my... Yeah, because sorry, don't look into my desktop. It's a little bit messy, okay? As always. So let me just go into, see here.
It's easier to introduce a new block.
Yes, I agree. Can you see now? Yeah, I'm gonna do that. Can you see now? That's it. Okay. Okay, good. I don't want to go through this here because it's 4 minutes already. You heard about there's no consensus. You heard about idiopathic term and what is the meaning of it. Let's start from here. So, about fascial plane blocks and mechanisms. It uses different planes. It is not very clear what is the right plane to be. And honestly, I don't think we're going to get into that ever. So, and this is because once we start putting local aesthetic into these fascial blocks, there's a variable, that is that the distribution can't be controlled. We cannot really control the way the conducts on the fascial planes. So therefore, what it means, we tend to use volume to try to overcome all these variations. This is kind of trick that fascial plane blocks use. It's based on volume to allow a wider distribution and therefore target more nerves. That in a way, it's a very complicated thing to do. So also the action zone for a fascial plane block is really different. Again, we know nothing about what is the exact place where we have to target, to obtain a clinical effect. And I really want to make a point on clinical effect, because at the end of the day, it is very, very fine to theorize about things, but the major outcome, the final goal, is to be clinically successful, because otherwise we end up nowhere. We know that the absorption differs depending on the plane you're using. We know this for a very long time. And we know that there are many different points of needling. And also we know that now with the ultrasound era, we have multiple, if not millions, different views of where to put the needle. So conclusion to fascial plane block mechanism. We know that no matter where you put it, somehow the fascial plane blocks are all working. So what's going on? It's going on that we still don't know how we can really convince someone that the theory I'm planning is really the right one. Look at this cross-section from my colleagues from Reims University. This is an hemithorax at the level of the axilla here. And now just by looking at this, when you're trying to be precise, missile target injections, it is very obvious that you're never going to make it. So these kind of spaces are crossed by a huge amount of nerves in every direction, in a 3D image, in every angle. So trying to get to a biplanar point to understand that, or convince one that a block is going to be effective, is never going to happen. These are complicated planes. That means that let's say, target needles cannot work. Show me or think about this image and tell me which is the nerve I have to block. You don't know. I don't know. So what do? We need to expand, and we need to try to obtain the maximum distribution of local anesthetic. A bit in line to what Philippe just said, that for me it was an amazing lecture. that really goes in line with what I'm thinking. So, fossil plane blocks are the logical answer to complex spaces. They are partially effective. It is the volume, not so much the tip of your needle, for what you've seen. Do not forget the molecular microscopic level. These nerves, many of the nerves that we consider motor nerves, that in fact mixed nerves. What I mean by that, they have been found up to 60% of sensory fibers in those nerves. What are those fibers doing there? Perhaps we were underestimated for decades the importance of motor nerves. This is why in the hemithorax, trying to design a block that's clinically effective, and it's clinically the gold standard to apply by everyone, is basically ignoring how important the brachial plexus is in this area, or with a different plexus in other areas. So what it means is that thinking that just an intercostal block is the answer, it will never be enough. Look at this cross-section from my colleague Hessan El-Sehawi from Cleveland Clinic, Ohio. On the top two squares, you see what is called an ESP block. The top two, left and right. The bottom two, left and right, is a QLB block. Now, if you start looking to detail, you can see in both of them very, very good distribution of dye into this specimen. And you can dissect in one direction and another one, but you can see that they're fairly effective in terms of distribution, all of them. I don't want to go too much into what these two prosections are meaning, but I just want you to step back, stay calm, and start thinking in a very basic way. What I mean by that those blocks are distributing well, and those blocks are staining, you can say, more fainty or less fainting, and the nerve, let's say the spinal nerves. So they are effective. So what is the point of trying to convince anyone of a block against another one when your first gross impression, the first impression, is always right? It tells you they are effective. Now look at this graphic corresponding to that, and I want you to think about this and the mechanism. In blue, you have the distribution from T2 to L5 of ESP blocks, with some circles here that it tells you that they have found in the paravertebral space the spread of dye, okay? In red, you got the lateral QLB block, and in green, you got the posterior QL block. Now, graphics are very important, and they require a fair amount of time to understand them. In the blue, you will see a very massive distribution in the ESP plane from T2 all the way to L5 in one specimen on the right, yeah? And fair distribution again up and down, cranial and caudal, in another 5 more specimens. But if you look at the circles here, 1, 2, and 3, you can see that only in 50% of those, they obtain 2 or 1 segments faint dye blue into it. So if you step back and you look at that graphic representation, you will say that the main reason for a block like this to work must be related to the stand of the block in terms of the plane rather than other factors. Look at the QL. On the QL, the spread is less, but the effect into the spinals is the same. Practically the same, 33%. This is in the lateral. And when you go to the posterior, you see the segments included are 3 as well. What do I mean by that? That is very, very similar. And for a clinician, you will not see much of a difference in all of this. And it's very interesting how people try to attach to anatomical answers to trying to explain everything. I have seen papers in which people are saying the neurosurgery fixations, L5S1, they can be treated perfectly well with an ASP. So what it means that if you are anatomically, your anatomical theory is the one you want to sell, and you look at the distribution here, in fact, ESP wouldn't be the best one because it completely misses L4, L5 in practically all the specimens, and the segments affected are not relevant. So either you are consistent with your theory, or it's much better to say that it's a very weak evidence of any clinical superiority based only on anatomical differences. We know how variable everything is. So what does it mean? This is just a personal choice. Anatomical knowledge is the first step for a clinician. No doubt of that. But it's not the explanation to the clinical outcome. We need to put more effort in trying to use clinical studies, because at the end of the day, the final goal is a patient. Researching between groups, anterior, lateral, posterior, it is fine. But stop, please, be critical and saying this block is better than this block. All of them, they have the perfect effect. And this is what it is. So be critical to us, because there's always something behind us. We like it or not, we all bias about our way of doing things. We're trying to tell you or to teach you in into our perception, our view about things, but please be critical and take all these images and papers very seriously and just cut them in pieces. Anatomy is then the answer in only a partial way. But, and this comes into the last lecture, the answer could be local and for sure at molecular level. The real answer, you will find it in a math, although it's a very complicated explanation of the theory. The answer is very simple. It's molecular. All of this is molecular. No other theory, in my opinion, can explain consistently what it happens in terms of distribution, planes, point of ejection, etc. What it is for sure, that you always have to block. Always. And what it is for sure that if it works for you, it will work for your patient. I'll leave you in here very few papers that I found worth reading and worth spending a whole afternoon in each of them. And I just want to say to you thank you and my apologies for not being there, and also for these technicality issues we had at the beginning of the lecture. Thank you very much to all. Have a good day.
Thank you, Rafael. Because of lack of time, we can't take question answers just now. So we'll be going with the live session. Thank you, moderators. We have our patients ready in Sancheti Hospital for which will be interactive. And I would like to ask Dr. Bharti Adhe and Dr. Varshadi Kenya to moderate the session.
Yes, that was very loud.
Okay. Ma'am, we just getting the moderators on.
Yeah, sure. Sure. Do I recognize this voice?
That was Arnand talking.
Yes, of course.
Again, chain of necklace.
So how is the morning going there? Yeah, we are...
Morning was good, four lectures, very
Wonderful.
interesting.
Wonderful.
So we can start now. Sandeep, over to you.
Hello, can you hear me now? Yes, sir, we can. Yeah, thank you so much. So we have a couple of cases lined up. One will be the popliteal block by Dr. Roshali, and Himanshu is going to assist her. Everything has been done. I advise that the faculties demonstrating blocks just demonstrate the probe position, evoke motor responses if possible, needle position, drug spread, indication, contraindications, and the discussion will be done with the delegates in the conference hall later on. Is it okay?
That's fantastic.
Thank you very much.
That's fantastic. And do I dare to say not okay when Sandeep tells me to do it? All right. So we go ahead now. So we go straight to the block. This is a popliteal block, and here is the ergonomics. Can you zoom out a bit? So I am here, and the patient is right in front of me. And if you see, the machine is on the other end. So we have a line here, as it were. And for the sake of demonstration, since we want you to see the sonoanatomy in as details as we could show, Dr. Amjad is going to point it out with the yellow arrow. You shall soon see that. And Dr. Himanshu is here, who's helping me. So we are absolutely privileged. The patient is painted and draped, and we've been given the probe to show the block, and nothing can go as well as this, let me tell you that. Well, so now coming to holding of the probe and orientation. So that's the first thing Sandeep told us to show you. So this is betadine is the jelly actually which is worked on. We could use any other sterile jelly as well. So now let me just keep the probe at the popliteal crease and let us simply read the scan. So the reading of the scan goes as follows. The orientation marker is towards the lateral aspect of the patient. So if you see the markings here, this is the lateral, this is the medial. So the orientation marker is the lateral aspect of the patient. This is the medial aspect of the patient. Could you please show it with the arrow? That's the lateral, that's the medial, and the above is the posterior, and below is the anterior. So we are reading a chunk of a depth of 3 centimeters of his thigh from posterior inside. So this is how we've anchored ourselves in the scan itself, right at the popliteal crease. Now let us read the sonoanatomy. So it starts with the skin and subcutaneous tissue on the posterior aspect. Then there are fibrous strands in between, and then we come on the lateral aspect, and then we see the biceps femoris, a good nice muscle. And then we come towards the medial aspect to see the complex of semimembranosus and semitendinosus. And you can actually see something there which is bright, which can actually tell you that, hey, look here, I am the neural tissue, but it isn't, because we won't jump on conclusions, and we are going to see how we actually read the sciatic nerve right out here. So we have just seen what is lateral and what is medial, and that's going to aid us actually to understand the sonoanatomy even better. Now I'll show you how. So can you see the pulsations of the popliteal artery here? Dr. Amjad is showing you. Please concentrate on that. Always treat the sciatic nerve, the tibial component of it, as if it's a cap on this particular artery, and it's sitting like a cap at around 11 to 12 o'clock position, and that's always the tibial nerve. So any hyperechoic structure cannot be a nerve. It has to be in congruence with the anatomy. Right next to it, right next to lateral again, so we've come to the lateral, is another nerve almost very close to it, and that's the common peroneal, right, taking off on the lateral aspect. Now if you see, we are already at the crease and we see both of them together, otherwise by now it would have taken off and come right at the far lateral end. But but in here we are actually seeing it quite close. So let me go a little further away and look at the course that it has taken. Now it would go even more further lateral and disappear on the lateral aspect of the feet, as it were. And now see the right tibial right next to it, and now let us get both of them together. So now we could actually stretch our imaginations and think that these are, these are the two eyes of the cobra. And then let them get together, proving ourselves that actually they are not the divisions, but yeah, they are the divisions, but still they stand on their own and they are just taken up in a sheath. So we come a little proximal, and here you see the sciatic nerve in the entirety. If you want to give a popliteal block, yes, then this is a good position to give the popliteal block in at. So I see the nodding of Himanshu and Amjad, so I'm reassured, and let me go ahead with the needle positioning. Now there are two thoughts of needle positioning. You could go out of plane, you could go in plane, but for the sake of demonstration, I think in plane would always be a good idea so that the whole needle can be seen and appreciated. Now there is something that I want to share with you here. Look, the sciatic nerve in the body currently is at around 2 centimeters. How do I know it's 2 centimeters? Amjad is going to show you where the 2 lies. So it is right inside 2 centimeters. I can be bang on it rather than tilting the needle, and let's see how we can achieve that. What we could do is, from the probe, go 2 centimeters away, and so you would be right in the plane of the sciatic nerve itself. Let us see if that really happens. So we really don't have to take steep angles to reach it. And now the needle that I'm using is a 5 centimeters needle. The nerve is at 2 centimeters. By the way, I am talking away to glory. Am I heard there?
Yeah, very well.
Wonderful, Bharati. So here I am. Now I want to see my needle. So here I actually go in the geometric center of the probe. I know how the ultrasound beam is getting inside. I go around 2 centimeters away from the probe, and now let me see if I get to see my needle where the sciatic nerve is. So here is the needle coming out, and there is the sciatic nerve. Yeah, I am a little more careful as I approach the nerve. There is one layer of fascia that I actually can go in with, and I can actually wait for Himanshu to aspirate and inject. And Himanshu's hands are bigger than mine, so he has used 20 gauge. I stick to 10, and I never change that syringe. He's aspirating and injecting, and he doesn't. Since he's injecting, obviously he doesn't have much resistance. So yeah, I'm pulling the needle a little away, and I hope everybody's seeing the drug spread there.
Yes, very well seen.
Yeah. Now I go a little more. See, I'm on the posterior aspect of the nerve. Now since I'm demonstrating, let me show you how you can actually change the angles and go deeper, or you may go a little more anterior. So now I'm going to go anterior to the nerve. Not required to do, but if you can, try and see what is happening with the probe and the needle. I have just tilted it towards the anterior of the leg, anterior of the thigh. And now I am sitting on the anterior aspect of the nerve. And yes, aspirating, injecting. You can hear no resistance, he said. I am lifting up the sciatic nerve. And here is the needle. Yeah, and actually I'm enjoying the needle sweep here. Can you see that?
Yeah.
Yes?
Yes,
Can you see that? Yeah, isn't it a joy to watch? It's a joy to give. Here. Yeah. And all these needle passes actually are not required. Let me tell you that. Can you see the reverberations of the needle? Seen very well. Yeah. Yeah, the needle is falling short, otherwise I would have loved to sit right in between the fascia and a bit, yes. Now I guess, yes, if he says resistance, I better not go ahead. But this is a correct, nice place to give.
So how much volume will you be injecting here?
Here, yeah, Bharti, I have heard you. I'm coming back to you. Just doing the last wee bit of an injection. We have chosen, for the sake of demo, we have chosen around 15 ml, and in a popliteal fossa, I guess 15 ml is a good volume.
Fine. This is a foot case, no? I assume.
It's a bit unclear, Bharti.
Yeah, that's lovely.
Here you go. And the needle is falling short. I'm so tempted to go posterior to the sciatic nerve, above the sciatic nerve, in other words, in what you're seeing. Yeah, there you go.
Yeah.
See, sometimes, you know, as the needle gets inside, it kind of tags a tissue along, sometimes. So you need to understand when it would be the neural tissue, but it's always very, how should I put it? It is always very prudent to be very worried about the resistance that you get. Now let us go a little ahead and see what happens to the drug that we have injected around the sciatic nerve, because it's a nerve that really travels a very long, nice distance. So let's see what happens above. I'm going to leave the needle and remove it, maybe, and let's see what has happened to our drug. And by the way, Sandeep has also asked us to discuss the indications. So indications is ankle. If I have come a little lower down, I shall, you know, it's just so logical. If the surgeon is working on ankle, you go as low as you can with the sciatic.
Yeah.
Okay, now we increase the depth if we want to really go to this nerve and follow her high up in the thigh, because the thigh is now going to get bigger. So it's, yeah, here is the nerve. Maybe we can get the nerve in slightly in the center, and maybe we can adjust the gain a bit to see what has happened to the nerve. Yeah, there is a wee bit of drug right up.
You want to see the nerve in longitudinal axis as well?
Yes. Here is the drug.
Lovely.
Yeah. And now I'm taking her longe. Stay with the nerve. I'm taking the nerve longe. Bharti, that's a good suggestion you gave. And I'm getting it in the center. Oh wow, can you see the whole of the drug around? It's a thin strip of drug.
Correct.
Here?
Very nice spread. Going quite high.
Yes, no, that was your suggestion, Bharti. Thank you so much. Okay?
Yeah. Thanks. So,
Bharti,
yes.
So we have around 2 minutes. So
okay,
anything that you could...
any questions? Any questions from the audience you want?
Sandeep here. Vishali, normally it was said that where the sciatic nerve just bifurcates,
yes,
at the dumbbell you inject the drug.
Yes.
And I think so you have gone just above and injected, where it has completely joined together.
They were almost together. They were not about to bifurcate. I know what you mean, but here they weren't that way. I didn't catch them there. I caught them where they were still together. But you're right. The coverings would be a little more amenable for drug soakage if we go at that point.
Yeah, and one more, this if you do a nerve stimulation for this popliteal block, what will be your end response?
If I see the end response of plantar and dorsiflexions, I am happy, because if I'm doing both, I would really not rely much on the nerve stimulation at all, because I would see popliteal nerve even with eyes closed. Could I say that? Because this is one of the nicer blocks for the sciatic, rather than going high up in the gluteal area, the subgluteal and the mid thigh for an adult. So if the sonoanatomy is absolutely perfect, I really would not bank a lot on the PNS.
Yeah, just a comment. I remember Dr. Divan's article when you were doing the injecting the drug and trying to reach the nerves, actually, there were so many layers of paraneural sheath, isn't it?
Yes.
Yeah, I mean, you can't just stop by getting into one layer
Yes.
when you get the thing, and you need to reach till you actually see both the nerves separating, isn't it?
Yes.
Is Sandeep around? Sandeep sir?
Sandeep has already
Acha, wash for this.
yes, he signaled us to go ahead with the next block.
Okay.
And
Yeah. So that was very important actually, because you can't stop with just one pop and start injecting till you see the drug sprayed properly around both the components of the nerve.
Yes, and that's the pleasure of
Yes.
ultrasound guidance, isn't
Yes,
it,
yes.
Bharti? So that you can
Absolutely.
go all around. If you don't see the spread that you want to,
Yes,
you actually get the spread that you want
Correct,
by
correct.
moving around, isn't it? So.
Absolutely right. And
Yeah.
that was really wonderful. Wonderful demonstration of this block.
And thank you for the tip of going longitudinal and showing all the drug. I enjoyed it thoroughly, and thanks,
Yeah,
Hebanshu. Thanks, Gayatri. Yeah, thank you.
Thank you, Vrishali. We'll move to the next block.
Yes.
Yeah, you are on, Dr. Sandeep and Ritesh.
Yeah, good morning, everyone. This is a patient with anterior rib fracture of from second to fifth rib. So we are planning a serratus anterior plain block. There are a variety of options. I think there's a talk on the rib fracture. So that talk, the rest of the options can be cleared by Dr. Gaurav. And basically I am tensed and honored also because the master is along with me, assisting me. So basically, I will put my probe. This is a linear high frequency probe. The patient is lateral. The ergonomics, I have the machine in front. The patient is facing me because we are going to do a in-plane catheter from chorda to cephalad. That's why the ergonomics has slightly changed. First, I will put my probe in a transverse orientation just at the anterior axillary line.
Patient is, what is the position of the patient?
Patient is lateral.
Right.
And I put my probe in a transverse orientation on the anterior axillary line.
Okay.
As I put my probe, you can see from below down, you can see the pleura. You can see the rib followed by Shiva, can you just show? You can see the pleura. You can see the rib with a acoustic shadow. You can see the intercostal muscles just above the pleura, and above that is the serratus anterior muscle. As I slide posteriorly, you can see a new muscle which is coming up. Can you appreciate the new muscle coming up? That is your latissimus dorsi muscle, and you can see the difference in the texture of the muscle and see the fibers traveling in a different direction. The LD is traveling in a different direction. The serratus is traveling in a different direction. If you want to give a single shot block, you can give either just below the serratus, between the rib and the serratus anterior muscle. That plane you will open up. That's a deep serratus anterior plane block. Or you can inject between the latissimus dorsi and the serratus. You can see the pulsating thoracodorsal artery. Can you appreciate
Yes.
that? Yes.
Very well seen.
So that's a neurovascular plane. You want to inject in that neurovascular plane to block the anterior cutaneous branches and give relief to the patient. From here, I will just turn my probe in a sagittal orientation. As I turn my probe in a sagittal orientation, you can see the rib, you can see the latissimus serratus anterior muscle, and above that you can see the latissimus dorsi muscle. Since it's a rib fracture, I personally prefer giving a deep serratus anterior plane block because I don't want to block the other two nerves, the nerve to latissimus dorsi and the thoracodorsal nerve. I don't want to block those nerves. Okay, so I will try to put my needle over the rib, and I will try to go as high as possible. Local is already given. The patient is sedated, and I will go for an in-plane needling. I have used a 2He needle. So it's a
Any
slightly,
reason for preference of 2He needle?
we want to put a catheter.
Got
We
that.
want to put a catheter. That's why we have gone for a 2He needle. I will just try to see my needle. Yeah, you can see the needle coming.
Yeah, yeah. We can see the moment.
Yeah.
We'll see the needle as well.
Just a minute, boss.
The other problem with these facial pain blocks in the thorax is the respiratory movements. Sometimes they have got a very high respiratory rate, and then there's a possibility of not seeing the needle or visualizing it all the time. You have to be very cautious with that. So the needle tip is arriving, so very carefully has to be placed in that position.
Yeah. No, yeah. Just a minute. Kindly slightly give. No, but slightly more. Yeah, just slightly.
You want me to inject?
Yeah, slightly inject.
Yes. This is fine.
Yeah.
So I'm now going to inject a test dose, and let's see if the facial planes.
Slightly more.
Yeah.
Yeah.
Thoda sa? Yes.
Yeah. Can you see
Yes,
the
yes, yes.
muscle getting lifted?
Yeah, can appreciate.
So there are a lot of facial plane skews which usually are there because serratus anterior muscle is they interdigitate at couple of levels. So you can see the retrograde as well as the antegrade flow. The needle has been rightly positioned,
Just a minute.
and if we just move still higher up, you can see the spread as well in that plane.
No, I think.
So it can be at multiple levels, so that
Yeah.
is not a problem. You can see
you
it just above the rib.
Can
Yes.
you see the muscle getting lifted
Yes.
from the rib? Since the patient has a fracture, his movements are too high, and basically that's why. And since it's a 2He needle, it's not an echogenic needle, so the needle visibility sometimes you will start losing it. Yeah. So right now we'll try to thread the catheter. Tight.
We can
Just a
appreciate the needle movement and the level.
Just a minute,
Yeah.
yeah. So can you see the drug between the serratus anterior muscle and the rib? The
Yes.
serratus anterior muscle has got lifted up, and between the two ribs you can see the movement of the pleura. So that the plane between the serratus anterior and the rib has been unzipped, and we will thread the catheter for a long-term pain relief for that patient. So Sandeep sir is helping me to put the catheter. I will just try to show you the catheter tip.
How much length of catheter you will leave inside?
We leave around 3 to 4 centimeter of the catheter.
Okay.
Just a minute. No, it's going. But catheter we are not able to visualize.
That's the catheter.
Yeah.
Can you see the
Can you
catheter
see
in
the
plane?
catheter?
Yes.
Yeah.
We can appreciate.
Yeah.
Yes.
So that's the catheter
Yes.
inside.
So we will leave it at level of what Ritesh suggests.
We leave around 3 to 4 centimeters inside. So we were almost around 7, 8, and almost around 4, 5 centimeter inside. So another around at 8, 9 centimeter. We'll just leave the 9 to 10 with muscles and everything. Around 11 to 12 centimeter, we'll leave it. And right now we'll inject the drug to see whether while putting the catheter we have not displaced the needle, because first of all there's a movement, quite a lot of movement of the patient because of because of the fracture, and since it is a 2He needle, the echogenicity is not so good. So now we'll put.
You will find some resistance.
Yeah.
You can see the catheter in plane very nicely just above the ribs.
Yes.
And in
Yeah.
the facial plane.
Yes, yes, very nice.
So now we inject local anesthetic.
Can you see the unzipping?
Yes, yes, very nicely
Yes.
demonstrated.
So,
How much bolus you are going to give to this patient?
Save.
we will give around 25 to 30 ml of bolus, and then we can put him on a top-up dose or an infusion, depending upon the institution protocol. That can be done.
So the institution protocol is 0.2 ropine at around 6 to 8 ml per hour. We can increase the infusion rate if it's required, if the patient still has pain. But in spite of that, if the patient still has pain and increased requirement of opioids, it means that the catheter must have come out, probably, or it has been blocked.
Yes.
So this thing has to be kept in mind. We have injected initially 20 ml.
Okay.
Now this is 20 ml more. And so what I would like to show is that we have two machines here.
Yeah.
Can you show these two machines?
Yeah, so these two machines. We have got one more G machine. Sandeep sir will show the spread of drug in a panoramic view.
Black and white. So that was very nicely demonstrated by Ritesh regarding the in-plane SAP block. We do it quite commonly in ICU as well as in the operation theaters, and it has replaced the thoracic paravertebrals.
Yes,
and
exactly, yeah. Because these patients, if you go for just have a look at the spread of the drug in a panoramic view. Sandeep sir is showing in GE machine.
So we try to see the spread in in a panoramic view. This is a G machine which has got a special ability to look in the panoramic view. So when I say start, she will start. Yes, start please.
Lovely
so
spread.
now this is the entire whatever serratus they are seeing from the cephalad to caudal. On the left side is the cephalad, on the right side is the caudal. We are seeing the what we saw was a spread along 1, 2, 3, 4 and 5. Though we do not see the catheter here, probably we might see the catheter in some other plane. We have got the facility to have this marker going from say from the first strip, then the second, the third, the fourth, so that way. Now if she makes this into the yellow one, it looks even more elegant. Yes, it looks even more elegant and more well defined, and then you can have the entire spread, you can have a look at it. Can you remove that? Yeah, normal, black and white. So we are getting the second case ready by now.
So
okay.
Yeah.
So in another 3 minutes, the second OT will be ready. Yes, you had some question?
Yeah. So how many days do you plan to keep the catheter, and is any method to fix the catheter?
Yeah. So we can make a subcutaneous tunnel, and we can fix the catheters. I routinely do that. So what we do is
we can just
we do a subcutaneous tunnel this way.
This is the way we tunnel it.
Sandeep sir, can I ask you a question?
Yes, please. We have got 3 minutes.
Yeah. Sir, when we are giving serratus anterior plane block, we are basically blocking lateral cutaneous branches of the intercostal nerve.
Yes.
So how does it help to prevent pain of a rib fracture?
Basically, first of all, these intercostal muscle, they supply your bones and the muscles. Okay, the ribs and the muscles are supplied by the intercostal, these lateral cutaneous branches. And secondly, once you are giving there was a cadaveric study, they have seen that in a rib fracture, since you are giving a deep serratus plane block, this drug finds its own path because the whole, because of the fracture, the whole continuity is broken. And the drug seeps inside, and it has a local effect also. If you want, I can share that article. It's a beautiful article, why a deep serratus plane block works wonderful in
Yes,
the
Ritas,
refracture patient.
I agree with you, and I read that article. But my question is, we are putting catheter away from the fractured ribs. So this patient has anterior rib fractures, and we are putting in the mid or posterior axillary line.
Yeah.
So how does it help?
The drug, it's an interfacial plane block. The drug will spread and catch the nerves running in that plane.
Okay, thank you.
And secondly, because of the diffusion, okay, because of the diffusion which I told, because of the breakage of the continuity following a trauma, following a rib fracture, it has got, because of the diffusion also, it has a local effect. If you see the mechanism of action of an interfacial plane block, there are multiple actions by which an interfacial plane block works. It's about the diffusion, it's by a direct blockade of the nerve which runs in that plane. So there are multiple actions by which the interfacial plane blocks, not only this, other interfacial plane blocks works by multiple actions.
Yeah, Hetal, I would like to add there to exactly what Ritesh said. Basically, it diffuses and it involves the anterior and lateral branch of the intercostal nerve. So that's where it will help. It will cover both the areas.
Thank you.
So this is how we subcutaneous tunnel it. It's ready there.
Yes, we
And then we have this filter here, and then we have the infusion pump which is ready.
One more question. Are we? Yeah.
Ritesh, sometimes it is very difficult to thread the catheter.
Right, sir.
Any tricks for threading the catheter? Like we are doing for epidural, if you are injecting and injecting saline while passing the catheter.
So, it's the same thing. If you are in the right plane, it means the catheter should go. If it's not going, it means there is some tissue in between. So either flush it, open up that space, what we do with epidural, or just rotate your needle. Okay, the things which we do with a interfacial plane, with a epidural. So the same principle works even with a interfacial plane catheters.
So the next theater is ready. I thank Dr. Nitin who was with us here. Dr. Bala is going to demonstrate an interscalene block in an obese patient with proximal humerus fracture.
So thank you very much. Thank you very much.
Thank you, Diwan sir and Dr. Ritesh. Wonderful demonstration. Thank you.
Thank you.
Thanks.
So we'll move to the next.
If we go to the next one, I would request the audience to ask
Bala
questions.
sir, your mic on, sir.
Yeah, Dr. Bala sir, good morning.
Good morning, Dr. Bharti. Thank you so much for opening up your facility for Aora.
Yeah.
I thank Sancheti
It's our
Hospital
pleasure.
and Sancheti Senior Sir and Parag Sancheti Sir. Now we go on to do interscalene approach to brachial plexus block in a patient with a proximal humerus fracture, and she's extremely obese. And so what I'm planning to do is, I will do the block and then I'm going to describe the anatomy, because we have needed the external help. Brushali Ponde is trying to create a space for me. There is hardly any space in the neck, but the tip of my finger is in the, the tip of my finger is in the apex of the scalene groove. And we think it's the scalene groove, and it's pretty deep inside, and my tip of the thumb is covering my perception of the apex of the scalene groove. I'm using a 50 millimeters Stimuplex needle, and I'm going to go in a direction towards the opposite nipple. So one small injection. I kept a current of 1.5 milliamps. So I'm looking for the.
So what are you looking for? What stimulation, what nerve responses, I mean?
Can you increase the current a bit?
Can we adjust the drape a bit so that we can see your...
Yeah, 1 minute.
Yeah.
Now, only thing is, it's kind of deep inside,
Yes.
and No, I'm fine. So can you see the contraction of the deltoid muscle? Can you see that?
The camera needs to move a little because we are on the, we can see the hand. Okay, now good. Yes, we can.
So I wanted to decrease the current. You see the contractions of the deltoid, the pectoralis.
Yes. It's gone. Yeah, wonderful. How low you will go on your current now?
I'm going to go down up to 0.6. Slightly alter the needle.
Yeah. This PNS machine has Sensi technology. Do you use it regularly?
I think in a humerus fracture, I don't think we should give that.
Okay.
And can you slightly increase the current a bit?
So which muscle contractions will you prefer?
So as you saw, I will take the deltoid and the pectoralis. Actually, yeah. So you see the contractions now?
Yes.
Yeah. At 0.6, you're getting an excellent contraction. And now we are going to inject the drug. It's an analgesic dose. So, Dr. Bhardiadya, madam, are you able to see that?
Yes. Very well seen.
So, this is a true challenge to do a case in obese patients.
Yeah, we have given you a very special patient. Just one question.
Aspirating, inject.
How low you will go on the current, whether you check that the current disappears at a particular level?
Yeah, actually I'll go until 0.4 to 0.5. We have gone up to 0.4 and we are injecting the drug.
Yes.
Now once the injection is completed, I'm just going to go back to show the anatomy and how we position the patient actually in spite of hardly seeing any neck. Okay? So now, thank you, Vrishali, for that pressure that you gave. And I'm going to remove, the drug has been injected. Now I'm just removing the drapes.
Yes, please.
So to show you, like, this is the sternal notch.
Yes.
And that's the sternal notch. This is the sternocleidomastoid and the medial one, and this is the lateral sternocleidomastoid, and I just 1 centimeter lateral I went, and that is the scalene groove. And I just wanted to show you, if we didn't create the position, she was like this.
Okay.
So there was no neck.
Oh, yes.
So we kind of made sure that we created a neck. We have put a small pillow below the shoulder and turn the head to the opposite side with the chin at the mid-clavicular line.
Yes.
And
it's so difficult to palpate the interscalene groove also, isn't it, in such patients?
Yeah, actually, but we created a space.
Yes.
And primarily this was to demonstrate that even though it looks very difficult, even though it looks that there is no neck, still in these patients, we'll be able to do it. So we move on to the, we will scan and also show the drug spread.
Yeah, that will be great.
Just 1 minute, yeah. And it's over, madam. We just given an injection to make you pain-free. Yeah. No, we are just demonstrating the injection that we gave. So you see the anechoic area, the drug spread.
Yeah.
Can you
Yeah,
see
yeah.
near the C5, C6?
Yes, yes, very well seen.
Yeah, so
Yeah, that
it goes
complete-
on to prove that if you get a peripheral nerve stimulator with a current of 0.4 to 0.5, you're pretty
Yes.
close to the neural tissues.
Yeah, and
Thank you
it's-
so much.
The drug is very well lateralized. I'm really surprised there is hardly any drug on the medial side. Any questions we have?
So thank you so much, Dr. Bharti. We move on to the next case
Can
now.
we take one question? Sandeep Mutha is already standing.
Yeah, please.
Well, that's a nice demonstration for an obese patient. Yeah, are there any other positions which you can give to open up the neck, like a lateral position or something?
Yeah, the only thing is even slight movement, she had significant pain. It's a 3-part fracture of the proximal humerus. So in this particular case, it's very uncomfortable for the patient until you set it to turn to the lateral position. But the point I want to tell is deceptive. It was very paradoxical in the sense the neck looked very short. She looked, the space looked narrow. But the minute you slightly opened up, I was able to feel both the scalene muscles very well. So we will not go by the first look. I think we can explore the region, and if you are able to feel the scalene groove, we can go ahead and do it with a peripheral nerve stimulator for all those who don't have an ultrasound. Thank you so much.
Thank you. Thank you, Dr. Bala. I think.
Yeah, we have another couple of minutes before we go on to the next block. And
any questions, audience?
one of the things which I
come
just
to the mic.
wanted to, when you do this block.
Can I have one question, please?
Yes, please.
Have you selected by choice the PNS guided block in this particular case?
Yeah,
or
because,
it's for demonstration?
No, Dr.
First of
Sandeep-
all, congratulations. It was a very difficult case and you demonstrated it so nicely. So the question is whether it would be easier with PNS in this particular case, or you would prefer ultrasound in this case?
No. Generally, after the advent of ultrasound, PNS you can never call it easy. In fact, the easiest option is to go to the ultrasound.
Yes.
So for demonstration purposes, you select.
Yeah, but then Sandeep felt that since ultrasound is not a part of several hospitals and many anesthesiologists do not have an access to ultrasound, he thought that this is an obese patient, and normally there is a feeling that if they're very obese like this, PNS becomes very difficult. So he said, shall we try doing this purely under a PNS and later demonstrate in the ultrasound to just re-emphasize the point that it's still possible to do it with peripheral nerve stimulator, so that all those who are using PNS, next time when they have an obese patient like this, still can go ahead doing this block. Before I gave this block, while we shifted, it was very difficult for us to shift. She was having so much of pain. But now, when we shifted back her to the stretcher, she didn't make even one small noise, showing that the drug was placed very close to the neural tissues and the block has started working.
So there is one more question.
So the volume that you have given, could we know how much volume you gave?
Yeah, actually, in this particular patient, the block was predominantly for analgesic purposes because of her obesity. The surgeon wanted, and it's a proximal 3-part fracture, which will need a lot of exposure, and it would be very difficult for them to keep the patient awake and do it because the drapes will be on the face. So the surgeon would wanted to do it under general anesthetic. So we decided to give an analgesia block. So we have used 0.2% tropine, about 12 ml. We took into consideration that it's only for the C5, C6, C7 if maybe, and not to produce any phrenic involvement in her. So we just gave a lower volume in this patient. And now, thank you so much to Sandeep and the entire team. It's just you feel so delighted to be so welcoming inside the theatre. And I thank the entire Sancheti team, and especially to Dr. Sancheti Senior and Parag Sancheti sir for giving us the opportunity to utilize their facility. Thank you so much, Dr. Bharti.
Thank you, Bala Venkat, sir. So this was another message he gave, that the primary aim is to keep the patient comfortable, and of course your surgeons should be comfortable, along with your blocks. So let's move to the next theater. What do we have here? You are on. Dr. Shiva?
Yeah, can you hear me, ma'am?
Yes.
Yes, now we have a clavicle fracture patient that he has got a 15-year-old boy having a fractured clavicle on the left side. So the clavicle fracture is towards the medial 1/3 and lateral 2/3. So I'm planning to demonstrate the scud block. So now to appreciate the sonoanatomy, you can see the sternocleidomastoid muscle on top.
Yes.
And then the scalene muscles at the lateral tapering end of the sternocleidomastoid muscle, you can see the scalene muscles.
Yes.
On top of the scalene muscle, the white facial line is the deep cervical fascia. Just on top of that, you can see a cluster of nerves.
Yes.
So those are all the supraclavicular nerves. So when I scan medially, you can see they are migrating towards the medial side.
Yeah,
As I scan down, they are becoming more and more superficial, splitting into 2-3 smaller branches. Can you able to appreciate?
Yes, very well.
As I come back, it is grouped together. As I scan down, it will split up.
Yeah.
So you have to inject when they are grouped together.
At the lateral end of the sternocleidomastoid.
Just at the lateral end of the sternocleidomastoid muscle.
Right.
Similarly, the phrenic nerve. Now Ritesh is showing the phrenic nerve on top of the C5 nerve root. As I scan down, you can see it is migrating towards the medial side.
Yes, we can appreciate.
You can see the anterior scalene, middle scalene, and then the brachial plexus element in between. And then the phrenic nerve is migrating medially, whereas the supraclavicular nerves goes laterally.
Correct.
So now first I am going to inject about 2 to 3 ml of local anesthetic, that is equal mixture within the supraclavicular nerve cluster.
Okay.
So can we give straight needle? Give that, no local. Yeah. Flush.
You are using a 50 mm.
Yeah, I am using a 25 gauge Quinky needle. So that is the smallest gauge.
Okay.
Then small prick. So don't aspirate. So my needle is coming out of plane. You can appreciate just there is a
there is a
flick
movement.
there. Yeah.
Yes.
Don't aspirate. Give 0.1 ml. 0.1 ml. 0.1 ml. Please give. Yes, another 0.1 ml. You can see the plane is getting opened up.
Yeah.
Yes.
0.1 ml. 0.1 ml. You can see the nerve is now floating. 0.1 ml.
Yes, you can appreciate it.
0.1 ml. 0.1. So how much? 0.5 you have given? So 0.5 ml can you give now? So now we are in the right plane, very close to the nerve. 0.5 ml. 0.5 ml. So you have given now 1 ml.
So what size
Give
syringe?
1.5.
What size syringe you are
So
using?
we are using a 10 ml syringe. We have loaded with equal mixture.
Okay.
Another 0.5. 0.5. 0.5. 0.5. Complete 3 ml there. Have you given? So now we have given 3 ml into the supraclavicular nerves. I am going to scan up and then show. Now you can see the group is well soaked with the local anesthetic.
Yes, very well.
So that is the supraclavicular nerves. As I scan down, they will split and go into the skin.
Okay.
So that is the supraclavicular nerve block is over. Now we will identify the upper trunk. The first root that pops out is a C5. So that is a C5 nerve root. I'm just scanning down. Now the second round circle that pops out between the wide C6 transverse process.
Yes.
So it's a U-shaped transverse process. The second sun rising out of mountain is the C6.
Yes.
So that is C6. As we go down, both C5 and C6 join together form the upper trunk. So that whole bunch is the upper trunk. Now I am going to inject about 3 to 4 ml of local anesthetic into the upper trunk. Same 25 gauge spinal needle I am using. I am going to come out of plane.
Okay. So you are injecting before the suprascapular nerve separates from the...
Yes. So I am just coming on top. So now carefully you go to any one of the sides so that you will not go into the fascicle but go into any one of the sides and stay there 0.1 ml and hydrolocate 0.1 ml. Don't aspirate 0.1 ml. So now you can see the local is just on the side of the C5 nerve root, 0.1 ml. as a 0.2, 0.2. You can see now I am at the lateral side. Patient is not complaining of any paresthesia. Injection pressure is the least, 0.1 ml. Can you inject 0.1? 0.1. How many has gone? 0.5 ml. 1 ml has gone. 1.5. 1.8. 2 ml. 2.2. 2.5. Stay there. So I have just injected only 2.5 ml into the upper trunk. Now I will just scan above and down and then show you the bulk flow of what we have discussed. So you can see the local is very closely attached to the neural elements. It has not gone to the phrenic nerve at all. You can see the anterior scalene muscle is completely intact. There is no opening up of any facial planes. As I go down, you can see the swelling up of the upper trunk.
Right.
So that is the upper trunk which has been swelled up. As we go down, it divides into anterior and posterior division. The last top up is the suprascapular now.
Correct.
So that's a suprascapular, posterior division behind it, then anterior division.
Yes.
So the upper trunk splits in an horizontal section.
Correct.
As I come up, it is all grouped as a single thing. As we go up, it is vertically separated and going into their corresponding transverse process. And you can see the phrenic nerve is more moving medially towards on top of the anterior scalene. So we have injected only 2.5 ml of local anesthetic into the upper trunk. I am going to top up with another 2 ml and then finish my procedure. So again, I am coming out of plane. Slow graded movement of the needle. You gently see I am coming to the other side of the C5 nerve root. Just dip into the connective tissue matrix, 0.1 ml.
Okay.
0.1, 0.1, 0.1, 0.1, 0.1, 0.1, 0.1. So you can see my needle tip is just on the lateral side of the trunk. So you should avoid going into the hypoechoic circle, 0.1. You can see my needle tip, 0.1. How many ml has gone totally? 4 ml. Here, including 2.5, 3.5, 4.
Is it really necessary to go on the medial side and inject?
4.5. We need not. We have to ensure. Wait. So we need not. We have to ensure that the trunk is completely soaked.
Correct.
Since we are using only 3 to 5 ml,
Correct.
even if you leave some of the fascicles not soaked, the block will become incomplete. So that you should make sure that the entire trunk has been completely swollen so that, yeah.
Have
So
you
now
added?
you can see the long thoracic nerve. Can you see onto the middle scalene?
Yeah.
So that chain of bead is a long thoracic nerve. It
Yes,
is going
yes,
into the on top of the surface.
Correct,
So it
correct,
comes out from the brachial plexus element ascend up into the middle scalene muscle. So that
Right.
is a long thoracic nerve. So you can see everything very clearly.
Yeah.
So this is a scud block for you.
Have you added any adjunct to this?
We have not added any adjuvant. So the C5,
Okay.
C6, the last one to come up is the C7 nerve root.
Down.
And
Yes.
then the below that, increase the depth. So we couldn't able to see the
Okay.
C8 is on top of the first strip. So
Yeah.
this one is the C8.
Yes. Below. Huh.
So that is the C8. So C5, C6 become an upper trunk. C7 is the middle trunk.
Right.
C8 you are seeing now, vertebral artery you can see pulsating on the
Correct,
medial
C7.
side. So the C8 nerve is very closely placed to the vertebral artery.
Correct.
When you come to the upper supraclavicular fossa only, the T1 will join as the last one.
Correct.
So since he has got a clavicle fracture, we couldn't able to insinuate under the clavicle. So
Correct.
the anatomy is bit altered.
Right.
So you are not seeing the C8 T1 in the interscalene groove. That is why whenever you do an interscalene block, the T1 will get spared.
Correct.
The T1 joins the brachial plexus only at the supraclavicular fossa at the corner pocket.
Right.
So
That is
since he
the-
has got a clavicle fracture, we couldn't able to go below that.
Yeah.
So any other questions? So we have used 3 ml.
Yeah, 3 questions.
Yeah.
Any particular reason to go out of plane?
Yeah, because here through the out of plane, we could able to access the target all 360 degrees.
Right.
If I come in plane, my liberty to inject or access the target is very limited. It's become really challenging to keep the needle and the target, everything in plane and try to deposit the local all around. It's a real challenge. So
Same for
because the-
supraclavicular nerves?
True, because even if you take off an in-plane, consider in this patient, see the ergonomics. The needle has to go like this. So it is very difficult to align. Out of plane will be much easier to do that. So that is why we take an out-of-plane route because the targets are very superficial and easy to access.
Yeah, and we always say that aspirate before inject, but your instructions were particular not to aspirate and only inject.
So there are specific reasons for it, because since we are using a very small liquids of local anesthetics, sometimes when the assistant, when they are aspirating, if they are too aggressive, they aspirate air. When they're injecting back, if you inject even 0.1 ml of air, all my targets will go off. So since we are using a very less amount of local anesthetic and we are seeing everything in picture, so I am specifically instructing them not to aspirate because I am seeing everything. Whenever they do a small liquid injections, I will see the tissue distension so that I know that I'm injecting only into the tissues, not in the vessel. So these are all the corrective measures that I have so that I'm not injecting into the blood vessels.
Yeah, I'm sure that you have particular reason to administer in aliquots.
Okay. Yeah. Yeah, true, because yesterday, as we said, if you inject with a high pressure, more volume, the bulk flow will happen because you will push the local anesthetic towards the phrenic nerve or other unnecessary areas. Can you increase the depth? We will show you the other areas.
Can we take some questions?
Yeah.
Good morning.
Yeah, morning, sir. So now, before that, I will just complete the other complications of the brachial plexus.
Yes.
So now you know that these are all the brachial plexus element. Can you activate the arrow? So these are all the brachial plexus elements. So this is where our target has to go. So if I scan medially, so this is the longus colli muscle and this is the sympathetic chain. So if your local has to go here, if it comes on top of the longus colli muscle, it will produce a sympathetic chain block and patient will develop Horner syndrome. So I'm going little more medially. You can see the thyroid gland and then esophagus below. So this is a trachea. The medial most round circle is the trachea. So this tracheoesophageal groove, only the recurrent laryngeal nerve will travel. So if your local come from there to the longus colli muscle and reach the tracheoesophageal groove, it will produce a hoarseness of voice or paralysis of recurrent laryngeal nerve. Can you ask the boy to swallow so that we can appreciate the movement of the esophagus? So while he is swallowing, you can see the movement of the esophagus. Can you see the movement in the esophagus? Air can move inside. So that is how we can confirm the esophagus. So now even in this scan, you can see the esophagus is lying lateral to the trachea. So this itself evokes another thought. We are doing routinely the Selix maneuver. But esophagus is all the time is lying either side of the trachea. So these are all the things now we have started observing that through a real-time ultrasound scanning. So that is how the complications are happening in brachial plexus block. So that is why we wanted to inject in small liquids so that we will not push our local anesthetic unnecessarily to the unwanted areas.
Yes. Dr. Shiva, you have a question here.
Yes. Good morning, sir. Excellent block demonstration, sir. So, how to be sure that the suprascapular nerve is not uncovered in this upper trunk block? Is it just because by tracing up and down, or is it some muscular landmark to be sure that a suprascapular nerve is not spared in the upper trunk block?
Yeah. Now, even while we are scanning, I understand. So, I will just clearly demonstrate where the suprascapular nerve takes off. Now you can see C5 and C6 are joined together, form the upper trunk. I am going down. So the suprascapular nerve will never ever take up at this level. I am scanning down, down, down. Only at the supraclavicular fossa only it is going to, yes. Right. So only at the suprascapular fossa only it is going to take out. So you need not worry when the group is formed like this. 100% you will not spare the suprascapular nerve when you inject at this level. So you can scan down and clearly see where it is leaving. So I don't want to attach any other anatomical targets to this because when you are seeing the actual target, it is better to focus on that than giving any other anatomical reference point because it will not be consistent in every individual. So my practice is to all the time scan the target and see where the suprascapular nerve takes out. It takes off only at the supraclavicular fossa when the whole trunk is split up in an horizontal section, suprascapular nerve, posterior division, anterior division. This is what is a SPA arrangement. So I am not attached to any other muscle, even a homohyoid, anything.
Okay, that's great. Any other questions we have?
Yes, sir.
Yes, one more question, sir.
Good morning. If I heard correctly, it was a spinal needle used for this
Can you
block.
just, Is it? So now, increase the depth.
So, one, you are coming out of the plane.
Yeah.
And second, we are using spinal needle. And so, Isn't it its potential for the nerve damage, in specifically for the interscalene?
Regarding the needle, I will just show you because you have seen the. Yeah, there are another question before that. The surgeon is with me. He asked a relevant question which is needed, practical for the patient safety. He asked, what is the relationship of subclavian artery to my fracture? So that while we are exploring, we will not injure it. So we can scan. So I'm just scanning down and try to go into the supraclavicular fossa and see where is my subclavian. Increase the gain.
Yes.
So the subclavian artery is pulsating here and the dorsal scapular artery takes up from that. Is it over? Okay. Yeah, that's the fracture. So I will mark it here so that you know while you're opening, this is where it comes. Yeah, okay, thank you.
That was a wonderful demonstration.
Thank you.
Excellent. You seem to have cleared so many doubts actually. Are we ready?
Don't joke, man.
Are we ready for the next case?
ஒரு மார்க்கர் மட்டும் கொடுங்க.
Yes. Welcome, Dr. Amjad. You are on.
Hi, am I audible?
Yes, you are.
Yeah. So good morning, everyone. We have a young lady, 32-year-old, diabetic. She has a fracture of her proximal tibia, and she'll be undergoing a plating for it. So she was quite anxious to undergo this procedure, so she is under a general anesthetic. She's asleep. Okay, we are giving her a sciatic nerve block, and the approach that we are using today is the subgluteal approach. So she's turned lateral. Her legs are in a bit of flexion to at the level of the hip, and she's lying in the lateral. As you can see, my hand is right now palpating the greater trochanter. And the other landmark that I'm going to look for is the ischial tuberosity. So this is a good way to start. I'm just going to clean this off.
Can you again show the landmarks, because we were not able to see
so
that.
This is the greater trochanter, which I'm palpating. She's quite, can we just, Himanshu, could we just straighten her up a little bit? I'm not sure if you can see, there's a small little groove over here, a small dip. And this is usually an indication where you would put the probe. This is the greater trochanter where my thumb is.
Right.
The ischial tuberosity is somewhere around here. It's quite deep. All right. So a midpoint, if you draw a line in between this, the midpoint is generally where a small dip in the skin appears. And this is a good place to place the probe. So I'm just going to wet the area up with some betadine. I'm going to place the probe exactly where I thought we would find the nerve. So now at this point I'm going to just move around a bit and look at the two bony landmarks. So there is one bony landmark that you're seeing here. This is towards the greater trochanter. You can see the greater trochanter there. And if I swing the probe a little bit posterior, you see another bony landmark. Yeah, I'll just try to get the arrow going. That will be where the ischial tuberosity is. The muscle on top, which is not very well defined in her, will be the gluteus maximus. Okay, and the nerve is sandwiched between another muscle much lower down, that is the quadratus femoris. So we are seeing something hyperechoic in between these two muscles. Yeah, there. If you look on to the right side of your screen, posteriorly, you see some pulsations happening.
Yeah.
All right, I'm just trying to move and maneuver the probe to see if we can get some better resolution on those pulsations. A little better now?
Yeah, a little bit. Yeah, we can
so
appreciate.
That is the inferior gluteal artery.
Right.
Okay, the pulsations of the inferior gluteal artery. The nerve is sandwiched in between these two muscles. It's a little flattened over here. All right, so we can approach the nerve in this area. Okay. Let me just do another little bit. So the subgluteal space, so there is an entity, the muscle, the nerve is actually sandwiched between these two muscles. So it's a little bit of dark hypoechoic area around the nerve, which is known as the subgluteal space. And when you can see that space, it's usually a good area to target. probably a little higher up. It's not everything. All right. Okay, so I'm just going to move the nerve a little bit to the right of the screen just to see my approach of the needle. I'm using a 100 millimeter needle here. Yeah, the bevel is up. All right. At this point, I'm just trying to get my needle tip going. Okay, so that's the needle tip, that's the nerve. So I'm just taking a little bit of time to ensure that I know exactly where my needle tip is going.
Yes.
Okay.
I don't know, he's at the reception, doctor.
Okay, so we're approaching just at about,
He's there, somebody needs to receive him.
yeah, I'm actually away from the nerve. I'm going at about 1 o'clock to the nerve and I'm feeling a pop. Okay, can you inject a little bit here?
Will adjusting the gain help a little bit?
Yeah. So is it a little dark over there?
Yes, a little dark. Maybe you can increase the gain.
Yeah. No, increase the gain, please. So the needle is parked at about.
Yeah, we can see the movements of the
Yeah,
needle.
so the needle is
Yes,
there. Can you inject,
yes.
please?
We can't see the needle. Can you do something about it? We can't see the needle at all.
Yeah, so the needle is, if you look down, the needle is actually very steep. Okay, this is about 5 centimeters in. Okay, we still can look to adjust it a little bit. So because the greater trochanter is in the way, my needle trajectory is such that it is fairly steep. So I'm just going to come a little closer. You can look at, yeah.
You can see the moment,
inject.
definitely, but
Yeah, you can inject here. Yeah. Smooth? Yeah, so it's a smooth injection happening.
yes.
Okay, so that is the needle tip there.
Yes.
The nerve has been pushed down. How much is done?
Can you point out the nerve with the arrow?
Okay, can somebody point out the nerve? The nerve is just below there. You can
Yeah.
see the needle. This is
Yes.
an echogenic needle. That is the tip.
Yes.
And that's a nerve below there.
Yes.
Okay. We can, I'm not being very aggressive here. We can go a little closer and inject. Yeah. Okay, so we've injected about 12 ml now. Yeah. So we can swing the probe and have a look at the nerve in the long axis.
Yes. Now we can actually see the nerve, bright structure. So how much total volume you intend to give?
15 ml, less than 15 ml has gone in.
Okay, beautiful.
Let's little. Yeah, can you inject little now? See, yeah. So you can see that. Yeah, we are going to inject in the long axis, And you can
Yes.
see the local tracking on top of the nerve here.
Yeah, very nicely seen now.
Yeah, she is quite obese. She's about 79 kgs, which is about 5'3", and the injection is actually done at this point. We have injected 20 ml. You can see the nerve in the long axis here and the local around it.
Right, we can appreciate that.
One more. Yeah, any questions?
Any questions?
You can
Yeah,
come to
one.
the mic. Dr. Amjad, you have some questions.
Yeah, Dr. Shweta here. Actually, why nerve stimulator was not used along with the USG? I mean, is it not preferable to use dual technique in sciatic?
So there's no harm in using a dual technique, but when the nerve is seen this well, you can. Now the other issue with the sciatic nerve is there's a lot of connective tissue within it. Sometimes to get a stimulation when you're using a dual guidance, you actually have to be within the nerve. Okay, so that again, that's a little controversial thing to say, but yes, that is true. You sometimes may not, you might reach the nerve physically with your needle, but you may not get a twitch. So at that point, you're going to finish it off. But most of the time in my practice, I just use ultrasound and do not use dual guidance. Again, it's just a preference from my side. If you want to use dual guidance, there's nothing wrong in doing so.
Any other question from the audience? I think everybody is so impressed that they are speechless. That was
This was a bit challenging. The needling wasn't very optimal. That's because she's quite obese, and the trajectory was very steep, and I had to avoid the greater trochanter. If I came in very flat, I would hit the greater trochanter as you see over here. So that's why my initial trajectory was quite steep. That's a small compromise you have to do here. Yeah, the other option is to come from the ischial tuberosity side, but then the artery is there.
Yes.
And because she's quite large and the image isn't really great, the artery was not very well defined. I know that the pulsations were there, but the artery was not well defined.
Correct.
So in her, it was a better idea to come from the greater trochanter side.
Yes.
The trajectory had to be changed to be steep. That's why the needling wasn't that bright, but we had a fair idea where the needle tip was.
Yes.
And sometimes that's all you need for delivering a safe block.
Yeah. Dr. Amjad, can we block this now a bit lower also, maybe 2-3 centimeters, or maybe subgluteal, if we are not able to see it here?
Yeah, so with ultrasound, the actual landmark is not clearly defined. You can actually put the probe on the subgluteal area, very classic area, but then move the probe actually a little bit down, a little bit up, and find the area where you get the best image. You do not need to stick to the landmark techniques. So suppose you saw Dr. Bala pull off that wonderful interscalene today. Now he may not be able to deviate from traditional landmark, but with ultrasound you can move around. In the end, it's a nerve and the local anesthetic has to surround it. If you do it 2 centimeters above, 3 centimeters below, it doesn't matter. The only concern in this particular area is if you go a little lower, if you go 3 centimeters lower from the subgluteal area, you may miss the posterior cutaneous nerve of the thigh.
Yeah, that's the reason I asked that.
So if you go a
the
little
preferred
higher,
site is this.
you're more likely. Subgluteal, again, it's very iffy if you're going to get the posterior cutaneous nerve all the time. If you go a little lower, definitely you're probably going to miss it.
Yeah.
But in her, we're not really interested in the posterior cutaneous nerve. She's having a tibia fracture, which is much lower down, so it doesn't come into play with her.
Thank you.
Thank you.
Yeah, wonderful demonstration. Thank you, Dr. Amjad.
Thank you.
Are we ready to move to the other theatre?
We're done.
Sir? Yes, sir. Yes, sir.
Sandeep sir, you want?
Yes, sir. Sir, good morning, everyone.
And this is a 16-year-old male having a right non-union of femur fracture, shaft of femur fracture, where implant is there. They want to remove the implant and put a plate, plus or minus bone grafting, that's what they are told. So we are planning for a lumbar plexus block with nerve stimulator guidance.
Patient is already in lateral position.
A patient is positioned laterally with a slight forward tilt, and you can see the hip is flexed 30 degrees and knee is flexed 90 degrees. So the first landmark what we have to make it is, we have to find out the posterior superior iliac spine. So when you see in the back, you can see a small dimple which is there in the back. So this is nothing but it is the posterior superior iliac spine.
Yes.
So I am going to mark this.
Right.
Then I have to mark the upper border of the iliac crest. To find out the upper border of iliac crest, you have to come from the subcostal region, and when you go down, the first bony landmark what you hit will be the upper border of the iliac crest. So I am just marking it so that it meets with the ESIS.
So what approach you are, what technique you are using for your?
I am using the Vinny's technique.
Okay.
Yeah, he's coming to that.
So from the upper border of the iliac crest, we are drawing a line that is the intercrystal line or the Taffius line, where it meets with the opposite iliac crest. So this is called as the Taffius line. The next we are going to draw a perpendicular line from PSIS which meets with the Taffius line. So this is the where it meets with the Taffius line. This is the point of insertion for lumbar plexus. We call this as the Vinny's approach. And if you go 1 centimeter medial, we call it as captivella. So I'm going to go for the Vinny's approach.
Okay.
I'm going to give a small amount of local also into this region, skin and subcutaneous tissue. Yes. So it's a B-Braun 10 centimeter needle. I'm going to enter into the Vinny's point. I'm going to start here. You can see the needle will be perpendicular to the skin and parallel to the table. And I'm going to insert the needle. And I'm going to start a nerve stimulator of 1.5 milliamps. So once I go,
we'll try to hit the transverse
we have to hit the transverse process. You'll be able to hit within 3 or 4 centimeters. So this is the transverse process which I have hit. You can see beyond this I can't introduce the needle. So once I hit the transverse process, I can go either cephaloid or caudal. I'm planning to go cephaloid.
So with this intercrystal line, you are at the level of L4, isn't it?
Yes, L4. So when I go from the transverse process, I'll be going 1.5 to 2 centimeters, where I have to see the quadriceps stitch.
Can you just withdraw 1 minute? Can you see these contractions? Those are the stimulation of the dorsal rami.
So
at 5 milliamperes.
Can we have a close look?
No, we can't see.
These ones?
The dorsal rami stimulation we couldn't appreciate.
Yeah.
The camera.
This is exactly at the level of transverse process. If you get that, probably this is one of the other gateways towards the lumbar plexus. So this is the erector spinae which are contracting. That's the stimulation of the dorsal rami. You can proceed.
Okay. We couldn't appreciate actually.
That's okay. That's okay. That is fine.
Yeah.
Not yet. The hip which is contracting psoas major. Patient is tilted this way.
Would you like to slightly go medial direction?
Hey, Nitin, you can remove the needle. Can remove.
Yeah.
So once you hit the transverse process and now at 1.6 milliamperes, can you see the response?
Yes.
That's the quadriceps extension of the knee joint, patellar response, and sometimes you also get the foot response. Sometimes you'll have to just see if he gets the foot response. You don't get that. It has come down to 0.5 milliamperes, and now it's at 0.7 milliamperes. Now what we do is we look at the placement of the needle with the help of the ultrasound probe. Jerry, please. So it has been correctly placed, the needle at around 8 centimeters.
Yes, 8 centimeters.
From the skin. So from the transverse process, it could be around 2 centimeters.
Around 2 centimeters.
So that this is the perfectly positioned needle at 0.5 milliamperes, 0.7 you can get the quadriceps contractions. We are just trying to evaluate whether we can see the needle tip. Can you see the can you increase the depth a bit? Both, okay. Yes. So that's the transverse process that you see at this level.
Yes.
And then we go down still a bit. We try to locate the needle tip. We go posteriorly and try to evaluate the needle tip. So this is at the level of the root, where you can see the lumbar root which is coming out exactly through the foramen. That is one with the red marker is the root which is coming out through the foramen. So you can isko hatao abhi. So we'll try to see the spread of the local at this point. I'm going to aspirate and inject. So it's very close to the vertebral foramen here, as you can see.
Yes.
That's the needle tip. It's very close to the vertebral foramen. So because it's medially placed needle, and yes. So this could also result in an epidural spread. But look, if you can see, the needle is not positioned medially. It is positioned exactly perpendicular to the to the skin. So we'll also see it with the longitudinal scan. Can you remove that? So that's the lumbar plexus next to the vertebral body that you can see, the hyperechoic structure.
So can we pinpoint with the pointer?
Yes, yes. Thoda sa niche. Correct. That's.
Yes.
That the entire is the lumbar plexus, and that's the local anesthetic that's going around that.
Correct.
Right.
So this thing, particular structure, that thing is entire is the lumbar plexus. What you are seeing.
Yes.
Just next to the intervertebral foramen, you see the paravertebral area. So this could be as good as probably a paravertebral along with the the lumbar plexus area.
Yes, we can see the drug.
Yes.
Yeah.
Can you make it panoramic, please? Panoramic. We'll just make it panoramic for you, and let's see how it spreads. And make it yellow. So this is the last block. Himanshu, Nitin, Ganesh. Thank you very much. इनको दिखाओ.
Thank you very much, Dr. Venkat and Dr. Divan.
इसको ये करो.
You are showing the
panoramic.
Yeah, panoramic way.
Not there here. So the panoramic will not be there in the linear probe. Anyways, from the iliac crest we go up. You can see the entire lumbar plexus, very bright hyperechoic, with a hypoechoic local anesthetic strip going around it. Grayscale. That's the grayscale, Anand.
Okay.
Okay. So he's going to now remove the needle. So can you just repeat the anatomical landmarks, Venkatesh, once more?
So it's very important for a nerve stimulator here, the landmarks has to be perfect. So first we feel for the PSIS, which looks like a small dimple in the back. And the next we have to go and feel for the upper border of the iliac crest. You have to start in the subcostal region. When you go down, the first bone, what we hit is with your palm is the upper border of the iliac crest. From there you draw a line to the PSIS. And from the upper border of the iliac crest to the upper border of the iliac crest on the opposite side, you draw a line down. This is called as intercrystal line or the Taffius line. And the third one is from the PSIS, you have to draw a line perpendicularly so that it meets the Taffius line. So this is the point of insertion for Vinny's approach. If you go 1 centimeter medial, it is called Capdevielle's approach. And this is the mid-spinal line. You can see this from the mid-spinal line to this Vinny's point, it will be around 4 centimeters. The most important thing with the nerve stimulator guidance is by 4 or 5 centimeters, we'll be able to hit the transverse process. After that, we have to be very careful. We should go only 1.5 to 2 centimeters to reach the lumbar plexus, because it is even in thin or obese patients, the lumbar plexus is situated anterior to the transverse process about 1.5 to 2 centimeters. Don't go beyond 2 centimeters, which can produce complications.
Thank you.
So thank you very much, Dr. Venkatesh. Thank you, Shiva,
Thank you,
Bala,
sir.
Gopal,
Yeah,
Amjad, and everybody.
before the
This is
live,
Sandeep, Himanshu, then Nitin, Ganesh, Roshali, and then we have our technicians, Praveen, and there's Prashant in the behind. So thank you very much, everybody.
If Sandeep
And
gives me some permission, just
sorry,
half
please.
a minute for
Yes.
me. Yes, on behalf of AORA, and of course Sandeep is actually personified AORA as well. Thank you very much, the entire Sancheti Hospital, for opening the facilities. You have seen the plethora of help that we've got, and it has been a pleasure. And there is one person that I cannot thank enough. Babu is sitting from Peter Anand's team, and Peter Anand there itself. So Anand, Peter, heartfelt thanks. A huge amount of gratitude for the patients who are here, and the OT staff, the OT nurses, and each and every person who has played a role in keeping this so flawless. Sandeep, it was a flawless show.
Thank you very much.
Thank you. And thank you the surgeons, of course.
Here, Dr. Praveen will be demonstrating continuous spinal tomorrow. His case will be postponed tomorrow. Thank you very much. We are not on time. Thank you, everybody. Anand, back to
We
you.
have a loud, yeah.
Yes, please.
Dr. Parag is here. One second.
Yes, sir.
Thank you. This is Parag Secretary. Great show. And really thankful to all of you for using the facility of Century Hospital.
Thank you very much, sir, for allowing us to use that. Thank you very much, sir, once again. Thanks a lot.
Can we have a loud round of applause for the whole team? Thank you. Thank you. I think we should break for this session.
Thank you.
Let us conclude this session. Any questions you have, you can meet the experts when they return to the hall. Thank you.
Kindly come back in, say, 4-5 minutes. We'll have an inaugural ceremony very soon.
Association of Regional Anesthesia Conference. I am most delighted to offer a hearty welcome to all faculty and delegates gathered here today and those watching us live on Anesthesia TV. There are no secrets to success. It is a result of meticulous preparation, hard work, and learning from failure. It is about being committed and consistent. These parameters define the eminent personalities who are the founder members of AORA. It is therefore a great honor to have with us today our chief guests who embody these same characteristics of success and hard work. Ladies and gentlemen, please join me in welcoming Dr. Rajiv Yeraudekar, Dean of the Faculty of Health Sciences of the Symbiosis International University. He is not only a gold medalist in MD Obs Gynae, but also a topper in the Maharashtra Public Service Commission. As a member of various national bodies, including the MCI and the MMC, he has contributed in a big way to policy formulation and regulatory mechanisms, influencing the healthcare delivery and education at a national level. He has been nominated to the WHO project on development of Health and Wellness Assessment Index for higher educational institutions in India. Dr. Vidya Yeraudekar, the Pro-Chancellor of the Symbiosis International University, who was also supposed to be here today, will be unable to join us. We will dearly miss her presence. May I now invite Padma Bhushan Dr. K.H. Sancheti. He is the inventor of the first indigenous knee implant from India, our very own Indus knee. He is also the founder of Maharashtra's first orthopedics dedicated specialty hospital, the Sancheti Institute of Orthopedics and Rehabilitation. Welcome, sir. I would also now like to invite Dr. Parag Sancheti, the professor and dean of the Sancheti Institute for Orthopedics and Rehabilitation. He has several academic and social awards to his name, and he is also the author of numerous publications and books. Welcome, sir. It is my pleasure to invite Dr. Satish Kulkarni, Senior Consultant in Anesthesia at the Leelavati Hospital, Mumbai. He is a founder member and treasurer of the AORA and the present president as well. We will now proceed for the lighting of the lamp and to seek the blessings of Lord Ganesha and Goddess Sharda, the symbols of knowledge at this academic extravaganza. We have with us Dr. Bhagyashree Kakade, who will sing the first few stanzas from the Jnaneshwari.
Om Namo Jiyadya Veda Pratipadya Jaya Jaya Swasamvedya Atmarupa Deva Tuchi Ganesho Sakalamati Prakashu Mane Nivrutti Dasu Avadhari Zoji Om Akara Charana Yugula Ukara Udara Vishala Makara Mahamandala Mastakakare He तेथ शब्द ब्रह्म कवळले ते मिया श्री गुरु कृपा नमिले आदि बीज आता अभिनव वाग्विलासिनी जे चातुर्यार्थ कला कामिनी ते श्री शारदा विश्वमोहिनी नमिली मिया ॐ नमो शिवाय ॐ
I would now request the dignitaries on the dais to light the lamp to symbolize the inauguration of this function.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते दीपज्योतिः परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापं सन्ध्यादीप नमोऽस्तु ते ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः.
May I request Padma Bhushan Dr. Sancheti to please felicitate Dr. Rajiv Yeravdekar with our Puneri Pagdi. I will now request Dr. Satish Kulkarni to felicitate Dr. Padma Bhushan Dr. Sancheti. I would now request Dr. Satish Kulkarni to felicitate Dr. Parag Sancheti. May I request Dr. Parag Sancheti to hand over the memento and to felicitate Dr. Satish Kulkarni, please. be seated. I would now request Dr. Rajiv Yeravadekar to share his thoughts with us.
Good morning, everyone. Padma Vibhushan, Doyen, legend, nationally and internationally known, respected Dr. Sancheti sir, my dear friend Dr. Parag, Dr. Diwan, Dr. Sandeep Mutha, other members of the organization committee of this National Congress of Academia of Regional Anesthesia, and delegates. At the outset, thank you Dr. Parag, Dr. Sandeep, both Mutha and Diwan, for having given us this privilege of inaugurating this inaugural event of the National Congress of Regional Anesthesia. Well, as you would have known by now, I am the provost of the faculty of the Symbiosis, of the Faculty of Medical and Health Sciences, under the aegis of which at the Symbiosis International University, we've established the Symbiosis Medical College for Women and the Symbiosis University Hospital and Research Center. Suffice it enough to say at this juncture, the medical college has been set up with a social mission of empowering the ladies to continue in the medical profession. Because as you know, at the time of admission, the ratio of girls and boys joining med school is roughly 51:49, lopsided in favor of boys. But unfortunately today, when we talk of practicing doctors, it is lopsided again, with the result that only 17% of the workforce are ladies. And therefore, Dr. Muzumdar, Professor Dr. Muzumdar, the founder, president, and the chancellor of the Symbiosis International University, deemed it fit as a step towards women empowerment to set up a medical college only for girls. And it's only the third medical college in the country to be, restricting the admission to the girls, and the first one to be 100% residential college for girls alone. The Symbiosis University Hospital and Research Center, the name connotes, has a thrust and focus on academics, teaching, training, and research. And its conferences like these in niche areas of regional anesthesia, niche areas of simulation, niche areas of learning management systems, niche areas of in vitro fertilization, and many other subspecialties within the broad domains of the mother specialties that we would like to promote teaching, training, raising a cadre of well-certified, well-trained healthcare professionals beyond medicos, to include the nurses, to include the technologists, to include the managers. And I believe the Sancheti Healthcare Academy, headed by another able lady, Manisha, is doing very good work in all this. And together, the Sancheti Parivar and the Symbiosis Parivar have decades of association where we all contributing in our own little way towards strengthening and helping develop resilient or sustainable healthcare systems in the city of Pune, but having a global, if not a regional or a national impact. I was just discussing with Sandeep just now, a few minutes back, is that we are doing a workshop on the 4th Sunday at Symbiosis University Hospital and Research Center in the cadaveric lab. And I explored the idea of him as to why does he need the cadavers. And then the discussions flowed from the fact, and we came to a consensus that we could start off making the anesthetist patient safe rather than patient ready alone. What do I mean by this? Can we have simulation as a pedagogy of training, where we train the anesthesia professionals into first understanding the procedure through the medium of simulation, through well-developed softwares which Dr. Parag has here. Dr. Parag is the director of the Center for Health Skills, and he's got a slew of mannequins and simulations, case scenarios and softwares for different healthcare professionals, be it the anesthesiologists, be it the surgeons, orthopedic surgeons, even the pre and paraclinical anatomists, etc., etc. Can we use simulation as a pedagogy of academic instruction to train the anesthetists on understanding the technique of regional anesthesia, then practicing it on the cadavers, before finally utilizing that technique on live patients. In this, we will ensure, as I say, patient safe rather than patient ready anesthetists alone. And Parag and me frequently interact on many platforms and fora, and it's so heartening to know that wherever Parag requires some sort of academic support and a research support, and I'm glad that you introduced me to Dr. Sham, who heads the research initiatives at SIOR. And it's guys like Dr. Bala, whom I got introduced recently, and of course Dr. Sandeep, the one whom I've been talking to. Niche areas and specialties need to come out of the confines and the broader outlook of mother specialties. Only can these niche specialties, whether it's pain clinic, whether it's regional anesthesia, whether it's whatever subspecialties you take in different clinical domains, can they flourish. So I congratulate the organizers and especially SIOR to have agreed to be host of this non-orthopedic event, and SIOR is fast emerging as one of the mecca of academic institutions in the country, known initially under the patronage of Dr. K.H. Sancheti sir, initially only as a center for excellence in orthopedics. Parag has taken it to the next level, and kudos to you, Parag, for having done this excellent work. And I'm sure the new building, which is fast coming up, and we wish you good luck in that new hospital, and my best wishes to this Congress. And I'm sure the delegates will go much more enlightened, much more competent, much more skilled in the techniques of regional anesthesia. Thank you.
Thank you very much indeed, Dr. Rajiv, for those encouraging words. May I now request Padma Vibhushan, Dr. K. Sancheti sir, to please address this august gathering.
Good morning, everybody. Dr. Satish Kulkarni, President, and other dignitaries, Dean, Yerodokar, and other members on the stage. This regional conference, regional anesthesia conference, is a great advancement in anesthesiology, and the recent advances more with ultrasonography, it has become very safe and very effective. In every field, there is a progress, and progress. But let me tell you, the progress in anesthesiology and the technique which you do, the skill is remarkable. In fact, an anesthetist, where is Bharati? She's our boss in the theatre. Anesthetist is the boss in the theatre, and we work with the anesthetist guidance, and they, with their good kind of, anyway. Well, I don't take much of your time. I wish the conference good success, and I am very, very happy to be here. Just for wishing you, I came, nothing more. Thank you.
I would now request our President, Dr. Satish Kulkarni, to give a brief presidential address, please.
Thank you, Dr. Malti. Respected dignitaries on stage, Dr. Rajiv Yarawde sir, Padma Vibhushan, Dr. Sancheti sir, Dr. Parag Sancheti, trustees, core and the executive committee of Aora, faculty members and esteemed members of Academy of Regional Anesthesia and friends. A very good afternoon to you. It is with great honor and humility that I stand in front of you today as the president of Academy of Regional Anesthesia of India, an organization that was founded in 2011 with a mission to learn, teach, research and innovate regional anesthesia throughout India and empower us to benefit our patients through this service. Since then, with this objective in mind, academies have been, our aim has been to encourage, educate and promote safe regional anesthesia practice, and impart systematic scientific training in regional anesthesia in all regions of the country, from rural to urban areas. This we do by way of our regular regional meetings, including outreach meetings in the interior, workshops, and annual All India conferences like this, and along with a successful and a very sought-after regional anesthesia fellowship program for training in almost 25 accredited centers throughout the country. With a primary aim to publish research from India, we have an online biannual official journal of our academy, that is the Indian Journal for Regional Anesthesia. Today, I'm proud to say that our membership stands at more than 2,000 members, to be precise 2,057 till yesterday evening, from all regions of our country. And we are actually, in the near future, we are looking up to opening up the memberships to our international colleagues and incorporating faculty of pain medicine to our academy. And also, as Dr. Rajiv said, we are looking at simulation as a part of our training during the workshops. So if you could look into those areas that we are seriously looking at. Today, we all regional anesthesia enthusiasts have gathered here under the banner of AORA to learn, teach, and grow so that we can deliver the very best to our patient. That is our primary aim. Now, I take this opportunity to congratulate Dr. Sandeep Diwan and the organizing team for putting up an excellent academic program, and looking forward to your active participation and support in future endeavors of AORA. Thank you very much.
Thank you, Dr. Kulkarni. I am pleased to announce that we have a book launch at the hands of Dr. Rajiv Yeravdekar and Padma Vibhushan Dr. Sancheti. Dr. Kapil Gupta and Dr. Anjali Kochar, who are two of the 6 co-editors of this book called Clinical Keys in Anesthesiology and Critical Care, is published by Springer. This will be available for purchase about 3 months from now. I would now request Dr. Rajiv Yeravdekar and Padma Vibhushan Dr. Sancheti to please release the book. This is an exam-oriented comprehensive book with many well-known and eminent national and international authors. The USP of this book is the stress laid on the latest evidence-based management guidelines and protocols. Dr. Sandeep Mutha will now give the vote of thanks.
Good morning. It was our great pleasure to have Dr. Rajiv Yeravdekar as the chief guest for this prestigious AORA, 13th AORA convention in Pune. I would like to thank Dr. Rajiv Yeravdekar who accepted our invitation graciously and blessed us with all his blessings for this future and future generation of anesthesiologists by giving an insight about simulation, cadaveric workshop, and then working on the patients to make anesthesia safe. Thank you, sir. I would like to thank Dr. K.H.S., K.H. Sancheti, sir, Padma Bhushan, sir, and he is always an inspiration for us, for everybody of us here and all over India, or if I may say, all over the world, as an iconic figure in medical practice. His way of dealing with the patients, his way of making the medical fraternity grow has always inspired us. Thank you, sir. Dr. Parag Sancheti, because I know him from the college days, we have been there together for a very long time. He is a great person. I would like to thank Dr. Parag Sancheti, who graced us with his presence in this August gathering. Our president, our inspiration for AORA, all the AORA members, and also the non-AORA members who may become AORA members in some time, Dr. Satish Kulkarni, I thank him for his gracious presence here. I would like to thank all the delegates, all the faculty from national and international who have come here to part with their knowledge, give insight about different things, different new things in our practice. I would like to thank everybody, all the national and international faculty, and also the delegates who are interacting with these faculties. Thank you, everybody. I would like to thank the JW Marriott Group, who are, as I've seen for a long time, they are perfect in their management. Mr. David, who is managing our show here, and Lena, they have both given us a best atmosphere, best comfort to have this conference here. I would like to thank all the pharma people, the medical fraternity, who always help us in this educational endeavor. I would like to thank the main sponsors, the prime sponsors like Neon, GE, Sonosite, Bebron, and Hospimedica, that is Payung, who graciously helped us in organizing this conference. Because organizing this conference takes a lot of things because of the medico-legal aspects like PSC patent date and everything. They all helped us in that. Thank you for that. I would also like to thank the audiovisual people, Peter and everybody, the whole team, whose work you can see everywhere. Thank you, Peter. I'd also like to thank the volunteers who are here or who will be there in the workshop, helping us gain more knowledge about regional anesthesia. Thank you for all the volunteers also. Thank you.
May I now request all to please rise for the national anthem. Yes, we will now officially declare the 13th AORA conference open and proceed with the Dr. Ravindra Bhatt oration. Dr. Sandeep Diwan.
परवाच टेकरीवर दोघं जण आणि परागचे वडील Good morning, everyone. I'm Dr. Janvi.
I'm Dr. Vedika Shankar.
And we are going to go ahead with the proceedings for the Ravindra Bhatt oration.
I would like to please call on stage Dr. Sandeep Diwan to begin the oration.
Thank you. Thank you very much for being here. I request everybody to be inside for this oration. I please request everyone. Thank you, Dr. Janvi and Dr. Vedika, for being very much with us here. And so, few years back, I was thinking who would be delivering the oration in Pune when we had this thought. So I thought that there would be none other than who has worked very much on the Indian soil, has worked in a place where it's all orthopedics and nothing else, and he has demonstrated blocks to all the interiors of our country. So far, we have been fortunate and to have all the speakers who were of foreign origin and also of the who have resided in foreign but of Indian origin. You have seen today a workshop which was done absolutely flawless. I thank everybody, all the faculties. But the block which Bala gave, interscreen block, we had discussion last night what exactly it would be, and he had mentioned that. And I was right that it would be none other than Bala who would be delivering this oration to all of us, and we thank him very much. Thank you, Bala. So he has been the founder, president, and current chairman of Aora, past president of OSRA from 19 to 22. He has been GCM 19 to 22. He's a member of WFSA, associate editor, RAPM, section editor of regional IJA and JOCP. So not only this, Bala, but we also will support you in all your future endeavors. Academics, the lectures that have been delivered, you can see the amount of lectures that have been delivered. This may be not the true numbers, it must be more than that. He must have already forgotten what he has done all in the past, because he always likes to live in the present. He has a lot of international representations as well in all these countries. And mainly he supports everybody. Like if you want to be supported in any way, he would definitely support you. You just offer him something and then he would say yes. He was the first anesthetist probably to deliver an oration in all other congresses apart from the anesthesia. So Dr. Bala Venkat, I welcome you very much on this stage. It's all yours. A very good friend of mine. Thank you so much.
Pranams to everyone. I would begin this oration by seeking the blessings of Almighty God to shower His blessings on each one of us and our families, to show us the right path to grow and in the process enrich this world and make this world a better place to live. I would begin the talk by offering my gratitude to Padma Vibhushan Dr. Sancheti, the vibrant young Dr. Parag Sancheti, the President of Academy of Regional Anesthesia, Dr. Satish Kulkarni, Secretary Dr. Vrushali Ponde, National Chairman Dr. TVS Gopal, the organizing chairman of this meet and also the 2013 meet and the founding Vice President of Aora, Dr. Sandeep Diwan, the organizing secretary Sandeep Mutta, and the entire organizing team of the 13th Aora National Meeting. Esteemed faculty from inside India and outside India, I would like to specifically wanted to welcome and pass a gratitude to Professor Narendra Raval from Sweden, an Indian anesthesiologist who did remarkable job in the world of regional anesthesia, and the first one who delivered the Aora oration. Professor Raval is here. Thank you so much, sir, for making the Indian flag fly very high in this world. He was the president of the European Society of Regional Anesthesia from 2000 to 2009. And not only that, I think he's the only Indian who has been bestowed with two important awards internationally, the Gaston Lebert Award and the Carl Kohler Award. Sir, thank you so much for gracing us and making India proud. To all the delegates who are present here, I'm sure it's a great learning process. We learn from each other. Before I could start my oration, two of my very famous statements which has enthused me throughout my life is from Mahathiriyara. It's for each one of us to read this message every morning. It says, we may be born in a middle-class family, but we can scale such heights in this lifetime that we can cause a revolution in the profession that we chose. We may be born to illiterate parents, but we can die as a scholar of world repute. We may have been considered a misfit during our childhood days, but we can become role models for the future generation. What we are and what we have been has no bearing on what we can be, and we can be what we choose to be. So, if we need to do this, we need to keep asking ourselves, my future comes from where my time goes, so where should my time go? For everything that you want to do, you need to have the time. In essence, we reach a point in life where time almost becomes our God. For all of us who realize this, we will be the most successful professional in this world. And it is important that all of us tell ourselves that we need to be successful. But to be successful, we need to have the core values right. It's all about, in the process of being, joyfully creating a life that reflects your highest values, your deepest dreams, and your greatest beliefs. And one such person who influenced my life is Dr. V. Ravindra Bhatt. Dr. V. Ravindra Bhatt was an epitome of success in what he did professionally. I've been extremely fortunate to work with him for decades. And it is very emotional to deliver a lecture in the memory of your own friend who was just 2 years elder to you, losing him at such a young age. I just wanted to show, this was the 2012 National Conference happened at Ganga Hospital. See the program. Welcome address, Dr. V. Ravindra Bhatt, organizing chairman, Aora India 2012. And exactly a week later, we saw him have a massive arrest, collapsed in the railway station, and no more he was with us. Within an hour, the entire executive committee of Aora decided the best way to gift him or to remember him forever for his contributions is to name the Aora oration as Dr. Ravindra Bhatt Memorial Oration. And when he fell and collapsed and died in the railway station, we did not have the Indian Resuscitation Council and Federation, where now every Indian has been taught how to do a CPR. He died at a place where nobody could do a CPR. I would like to thank the IRCF led by Dr. Chakkar Rao and team for doing this, and all the anesthesiologists who have taken it on them to teach the life support to every single Indian citizen. The hallmark of a developed country is that every citizen offers this life-saving life support to a fellow colleague. And I'm also very happy that IRCF has become a member of LCAR. I'm deeply indebted to my institution and the founders of our institution, Ganga Hospital, Dr. J.G. Shanmuganathan, an anesthesiologist by himself, Dr. Mrs. Kanakavalli Shanmuganathan, the Managing Director, the Chairman of Department of Plastic and Microvascular Surgery, Professor Dr. Rajesh Sapapati, and Professor Dr. Rajashekharan, the Chairman of Department of Orthopedics, for showing us the right path to grow and for allowing us to practice regional anesthesia and analgesia in our patients and for allowing us to become a perioperative physicians in a private institution. I am deeply indebted to them for allowing us to grow. To all the anesthesiologists and the orthopedic plastic colleagues in Ganga Hospital for sharing the responsibility and for allowing us to offer the best to our patients. To all my teachers at Coimbatore Medical College, at BJ Medical College, Pune, I learned my baby steps in anesthesia in this very city of Pune, and my teachers in PGI Chandigarh, where I did my MD. For my parents-in-law, and my family for sharing my responsibilities and for understanding me and for allowing me to grow. I'm deeply indebted to all of them. What we are is a culmination of what people contribute to us. We are individually nothing. A tryst with regional anesthesia and analgesia is a true boon to our surgical patients, and I'm extremely happy and delighted to recall at this juncture that this is the maiden document of AORA, which was taken in the year 2011. 6 of us met in a small hotel in Mumbai. Dr. TVS Gopal, Dr. Vrushali Ponde, Dr. Satish Kulkarni, Dr. Ashit Mehta from Sholapur, and Dr. Sandeep Diwan. This meeting was organized, I would like to recall, the late Mr. R.G. Sir of the Neon Laboratories, who convened the first meeting. It was just 6 of us who met, and we discussed, and we said we need to have an organized setup to teach regional anesthesia in this country, and I'm extremely happy and delighted that we had progressing very nicely in learning, teaching, and sharing regional anesthesia in this country. And with such a vibrant young brigade of, this is the executive committee of AORA, which has made many, many anesthesiologists who had illiteracy in regional anesthesia to become literate. I bow to every single executive member for their phenomenal contributions in moving this country forward in regional anesthesia. From 6, it has grown to 2,000, and this has been the symbol of success of an organization which strived to produce pain relief to all its patients, and we instituted the Aora Pledge. We just took this pledge, and it says, I hereby solemnly resolve that I will wipe out the pain and suffering of every patient and bring in brightness and smile to every surgical patient. And I'm deeply indebted to every anesthesiologist for doing this. I profusely thank AORA for immediately honoring Ravindra Bhatt for his work in regional anesthesia. Why did AORA agree to give Dr. Bhatt this prestigious oration? His life is a message. He was phenomenal in his contributions. And this was with one of the most inspiring leaders of this nation, Dr. APJ Abdul Kalam, when he visited our institution. I would want to quote Abdul Kalam. In a meeting of the doctors, he asked, do you believe that India will become a developed nation in 2020? And people said yes. And he asked, what would be your single most important contribution for this nation to make India a developed nation? There were multiple answers, and he was not happy with any of them. He said, if you're an anesthesiologist, I want you to become the best anesthesiologist in the world. I want the architect, engineer, every single person who is doing any kind of job in this country to become the best in the world. If each one of you become the best in the world, the country becomes the best country in the world. That was a strong message that Sri Abdul Kalam ji gave us. Dr. Ravindra Bhatt is remembered for advancing the quality of patient care. This was way back in 90s when there was no ultrasound, and he was the one who pioneered the on-arrival block to every single patient who came in. He joined Ganga Institution in the year 1993, and then he pioneered the work, landmark technique of giving a peripheral block with such a precision. This is the small book which I would want to quote, which propelled us to follow regional anesthesia. This is from the Green's Operative Hand Surgery book. It said, on the subclavian perivascular block, this block is very easy to perform. Once the landmarks are located, small volumes of the local anesthetic provide excellent anesthesia, which is established very rapidly. Since this block provides excellent anesthesia so easily, the author has difficulty in convincing the trainees to learn any other approach once they are exposed to the subclavian perivascular approach. Subarachnoid, epidural, and vertebral artery injections are practically impossible when you do this. This was in 90s, and this message, we took it up very seriously, and Dr. Bhatt especially. You see pediatric regional blocks being given with the landmark technique of subclavian perivascular block. His colleague, Dr. Venkateshwaran, who closely worked with him, who is here today, said regional blocks in the pre-ultrasound era had equal success. I think his left index finger was the ultrasound probe. That was the precision with which he gave the block. And he continuously made sure that every single patient who arrived in was made pain-free the minute the patient came. Like what I did today, even in obese patients, he did with the landmark technique with equal success and achieved almost success rates which is equivalent to that of an ultrasound. You see this Attila machine, patient with excruciating pain, within a minute he's made pain-free. Since then, on-arrival block has become a norm in our institution. And it's important just not to be an anesthesiologist providing pain relief. We need to go apart from providing anesthetic care in owning our responsibility and being extremely reliable to the institution for whom we work. We need to become good to great. I would want all of you to read this book by Jim Collins of how to become good to great. Responsibility means it's not your patient. Every patient becomes our patient. And you make a huge difference when you take over the perioperative care and the resuscitation of the trauma patients. And many, many lives have been saved by Dr. Bhatt, by his commitment, whether it's day or whether it's night. They all live to keep assuring us that the legacy of good professionals will live much long after they are gone. Our anteroom of the operating theater became the resuscitation room, a protocol which we still continue, and because the availability of the resources is at best in the day or in the night. He was extremely committed. He would take the patient inside himself. He will move the stretcher himself. He never wanted somebody to help. And he started pushing the boundaries. He started thinking that we need to publish this work. This was published way back in 1994, Subclavian Perivascular Approach for Brachial Plexus Blockade in Upper Extremity Surgery, when many of us don't even started thinking about regional anesthesia. This is an excellent special article that was published in the year 2020 on arrival block, management of upper extremity trauma with resuscitation in the operating room. And I would like to bow to Bhatt for having started this. It's important as anesthesiologists, we need to earn the respect for the specialty by the what acts we do. Surgeons did not have high regards to him, but had profound respect for his contributions. And this is the words of Dr. Stephen Moran, a hand surgeon who came from Mayo Clinic to Ganga Hospital. And Dr. Bhatt was explaining about subclavian perivascular block to him. He said, he wrote, Dr. Steve Moran wrote, "My concepts of hand surgery have been completely transformed by my visit to this institution." And when Dr. Bhatt left us, Dr. Raj Sabhabdi sir wrote a book. I think this is the biggest award that a person can get, a surgeon writing a book on the anesthesiologist. It only indicates that each one of us can become one like that, and make sure that every surgeon writes about you. And this is a book, he named it as Game Changer. And the foreword for this book was written by Dr. David Elliott, the past president of the British Society of Surgery of the Hand, and Mr. Martin Boyer, president-elect of the American Society of Surgery of Hand. It shows how surgeons can show their contributions to anesthesia, which they richly reward by the forewords that they wrote. As years passed by, this book got completely sold out, so a reprint was ordered. I just wanted to read this. When the need to reprint this booklet for the 5th time came up, the printer asked Dr. Raj Sabapati if I needed to update it. I thought over, read the booklet again, and decided that nothing needs to be added or deleted. The continued interest and demand for the booklet has proved the values that Bhatt espoused are timeless. People say that the pandemic has changed a lot of things, but thankfully, not all have changed. It has made us realize that the power of the purpose, strength of character, and being self-motivated, and more important than ever before, and rightly so. We know to find reason and strength to complete a task, even in challenging circumstances, without giving up or needing someone to encourage us. Reading the booklets gives me a reason to keep going. We need to keep thinking and working that there is nothing more important than this movement and this patient's need. Bhatt was an example for this. Such people become leaders, iconic enough to be remembered as role models even for people who have never met them. Perhaps that explains the demand of this booklet. It's so important. If God has blessed us to be an anesthesiologist, we have to become a regional anesthetist. In some form, we have to adopt regional anesthesia. As Modern said, regional anesthesia always works provided you put the right dose of the right drug in the right place, and the advent of ultrasound has made it so simple that severe mutilating injuries can be made comfortable. And I would urge each one of the anesthesiologists present here to create a block room in the place where they work so that the advancement of regional anesthesia could happen in this place. I would want you to read this article on block success, the definition in the contemporary literature. And if the successful block has to be given, it's the one that covers the entire dermatome, myotome, and osteotome for that particular surgery within a designated period of time. And hence it becomes very crucial and vital that each one of us make sure that we get the right anatomy, pharmacology, and physiology, and take the appropriate steps to make sure that technically we become competent in using the ultrasound machine. And if we start doing that, there is no anxiety while you perform a block. It becomes important to know a little more about the nerve, where to deposit the drug, the optimal endpoint, the way the nerve fibers are arranged, and how the drug spreads. Read a little bit about the tissue level action of how a drug works in the sodium channel. Read more about how the receptors are distributed in the body. And you also know that apart from pain relief, the stress response and regional anesthesia is very clear that when there is an injury or surgery, there is tremendous amount of stress response which are mediated because of the metabolic, immunological, inflammatory response and the neuroendocrine response that happens in the body. There is a plethora of chemical activity happening. So many mediators are released, which results in increased sympathetic activity and a plethora of negative metabolism happening, and it's such a bliss to our patient to get a regional analgesia because it suppresses this stress response, and apart from pain relief, does so much good to the patient. And with the advent of adjuvants, if we add it to our block, we know that the duration of discomfort becomes excellent, and also we know that when you do this block, when the patient is having acute pain, you are going to prevent the pathway and prevent chronic pain happening. So this is something, a big message that each of us have to take into us, that it's just not pain relief, but decrease the stress response, prevent chronic pain in these patients. And also this is a great tool to do site-specific analgesia. See this patient with mixed edema coming with an open injury of the thigh. And just you don't have to think about anything. Go for a site-specific anesthesia and offer this patient the best in the given scenario. When you have a patient with head injury with a subtotal amputation, you just needn't have to bother. Just do the block. Keep seeing the neurology of the patient without sedating him. And when you have a 10-finger amputation, going for 17 hours, just bilateral block, and enjoy the benefits of regional anesthesia. So when a patient comes like this, one needle, one prick, 10 ml of the drug, just imagine the amount of comfort that you offer to this patient. So I would like to bow to Harvey Cushing, who first coined the terminology of regional anesthesia, when at an era and time when it was considered the pain like pleasure is a passion of the soul, that an emotion and not one of senses. So fortunately, we have been born 2 centuries later. Had we born earlier, when there was pain, people started putting burr holes in the skull to release the evil spirit from the body to take care of the pain. And thanks to the advent of few medications which came in, and now, you know, the journey has been excellent. Pain alleviation from there 2 centuries ago, we have crossed many a miles, and pain alleviation has become a vital part of perioperative care, with rapid resurgence in regional anesthesia like continuous perineural catheters, sophisticated nerve stimulators, depth-coded insulated stimulating needle. We are making history every day. If you see the literature, we have gone too much deep into seeing, like, for example, in liver transplant patients, when many drugs are contraindicated, subcostal transverse abdominis plane block gives excellent quality of analgesia. Analgesia for arthroplasty has made a huge resurgence, and we have gone to the extent of seeing how the local anesthetic spreads when you do an erector spinae block in an MRI of human volunteers. We have moved on to neuromodulation in acute pain settings. All this goes to prove that we are moving forward and surging ahead. This is, I want to share the wife and the daughter of Ravindra Bhatt, and he was also not an excellent anesthesiologist, but a person who participated immensely in our cultural activities, and he was there for everyone at every time. Has left giant footprints in the growth of our institution, and we had the pleasure of working and learning from Dr. Bhatt. It was just 4 of us to start with, and I'm happy to say we were able to continue his legacy, that we grew slowly. We started the Esculap Academy Guidance Center with about 4 people we train every month since 2005. We're happy to say that we have trained more than 1,400 people through this. In 2009, we started the National Board of Anesthesia, DNB seats with 2 seats. Now we have 8 seats per year. We started in 2012 the Dr. MGR Medical University 1-year program of postdoctoral fellowship in regional anesthesia. And fortunately, the first one, Dr. Amit Dikshit, was the one who did this, and is part of this city in Pune. From there, we grew strength to strength, and now we train about 84 fellows every year in regional anesthesia. And we are very, very happy that in 2014, the World Federation recognized us, and we started teaching the anesthesiologist from Africa and Southeast Asia, and this was in 2014. The current president of WFSA, Dr. Wayne Morris, was there to inaugurate the session, and we have so far trained 28 anesthesiologists from 18 countries. And I'm very, very happy to say one of the trainees from Zimbabwe has become the secretary of the Zimbabwean Society of Regional Anesthesia, and one of our trainees has become the founder president of Philippine Society of Regional Anesthesia, Dr. Dalia Arencel. And to help us, we also started the anesthesia technician program, who will ably assist us when we do the nerve blocks and minimize the duration of the blocks. So anesthesiologists are very special children of God. God produced pain, and he also produced anesthesiologists to take care of the pain. We need to introspect. Are we doing it? Are we true to ourselves in what God wanted us to do? And the desired prerequisite to become an effective and safe regional anesthesia expert is to have a sound knowledge of anatomy, to treat the possible complication aggressively, use newer gadgets to achieve perfection, and also believe to accept failure, a egoless nerve block. The mission remains. These are the phrases of Captain James of the Star Trek: to explore new indications, to seek out new research, to boldly go where no person has gone before. And each one of us have to dare to go to the places where our previous generation has not gone. And it's important that we need to put the patient first. We are so jubilant when the Indian Army Jawan, with diligence and precision guards our country. We are very jubilant when the Indian Space Research Organization sends a PSLV into the space. We are very jubilant when Virat Kohli or Mahendra Singh Dhoni hits a six in the last ball to win the match for us. Are we jubilant enough to introspect to find out that each one of us are contributing to our fraternity like what an army Jawan does, what his ISRO scientist does, or what Mahendra Dhoni did for the country. So we cannot bask in the glory of other professionals for putting this country forward. Each one of us have to take on us the onus and the responsibility to make every single surgical patient smile at the end of the surgery. And if we do that, the mission is accomplished. I look forward for a day that we together put this country first, to put every single patient have the least morbidity and definitely no mortality by our clinical acumen and the ability to give an excellent block. A tryst with regional anesthesia and analgesia is a boon to every single surgical patient. And I would urge each one of you to take it up on you, introspect, and make this world a different place to live. I thank you so much for patient hearing. I'm deeply indebted to the entire organizing team for giving me an opportunity to be a part of this deliberations. Thank you.
Thank you so much, sir. Vedika and me are also indebted because we are sir students from Ganga Hospital.
Thank you for everything, sir, and thank you for that wonderful oration. We would now like to call upon stage the Aora Core Committee.
Can I please invite on stage Dr. Sandeep Diwan, Dr. TVS Gopal, Dr. Vrushali Ponde, Dr. Satish Kulkarni, Dr. Ashit Mehta, and Dr. Sandeep Mutha. Pagdi will be given by Dr. Satish Kulkarni.
The shawl by Dr. TVS Gopal, sir.
The Shrifal will be handed over by Dr. Ashit Mehta.
And the plaque will be handed over by Dr. Sandeep Diwan, sir, Dr. Sandeep Mutha, and Dr. Vrishali.
Dr. Bala Venkat from 13th National Conference of Academy of Regional Anesthesia of India. We award the Aora Dr. V. Ravindra Bhatt Memorial Oration. Thank you, Dr. Bala.
Thank you so much for this very nice gesture. But the true award is to see each one of you make every patient that whom you anesthetize smile, and make sure. I always believed that when each one of us wanted to stitch a shirt, we wanted to go to the best tailor in the city. When we want to build a house, we wanted to go to the best architect in the city. But are we the best anesthetist to our patient? Is a question which we need to ask ourselves. Fill up the gaps and make sure that somebody who believed in you completely, and it is just not a haircut, it is just not a shirt, but his life. And I think we need to become the best professional on earth. Thank you so much for the kind gesture.
Thank you, Dr. Bala. Thank you, Parag sir and Dr. Ashok Sham for being with us for this oration. Thanks a lot. We now begin with the scientific session. You want to say something?
We would like to thank everyone and conclude the session. And also a small reminder, we have the AORA quiz, which is today at 5:30 p.m.
The preliminaries will be held between 1:30 and 2 in Hall D. Registration flyers are out by the registration desks. Please register. It is open for postgraduates, for senior residents, and fellows.
We have very attractive prizes.
Yes.
Thank you.
Thank you.
Thank you, Dr. Janvi, Dr. Vedika, for that accompanying this particular function. I also am happy to tell you that Dr. Ophelia is with us, as well as Dr. Philippe Lurk. You have already heard him in the morning, and Dr. George Figel. He will be at his best. So we begin with our didactics right away, and I ask the coordinator of this to start. Please, the moderators of the didactics.
Good afternoon, all. Let's begin our next session of the didactics. Invite Dr. George to please start the session.
Thank you very much. After such a wonderful presentation and talk, I'm not the light now. That was just before. And I just want to thank now really officially that I was invited to come over here. It's an absolute great pleasure. And even more, a great honor. So, block failure. Of course, seen from an anatomist, what can happen. And as you already heard a lot about the brachial plexus, I want to move a little bit, going to the lower limb. And just to give you some expressions and also some new, not new informations, but some of our investigations already published and not published. So we are still working on that, especially on one of my examples. I want to give you how or why failures can happen. So I'm going now to my role I absolutely love indeed, which is the advocatus diaboli. Yeah? It's like the lawyer of the devil. And we always see the bad things. I want to tell them to you. I say, watch out, take care. So imagine that you get a patient with a rupture of the Achilles tendon. You are the anesthetist. Surgeon is waiting for you and say, okay, we want to have a regional anesthetic setting. So you prepare everything, you are enthusiastic, motivated, and say, yeah, I do it. You perform it according to the guidelines. Popliteal sciatic nerve block, saphenous nerve block, should work, yeah. That's the guideline. So you're perfectly trained. You know the anatomy, you know to find it, you perform it well, you see the needle, you get a wonderful spread, you're happy, you're satisfied. It went well. And then, skin incision. The patients say, ouch. You're not happy with that because the surgeon will come up and say, come on, that didn't work. And you say, oh. I don't know anything, it went well, sorry. It's not my fault. Okay, so what went wrong? Were you the fault? Did you make something wrong? Not, because you followed the guidelines. So the problem is, are the guidelines correct? Okay. So let's take a look on that. A nerve, example number 1, posterior femoral cutaneous, which nobody wanted to learn in our studying in the university. Or did you really study the posterior femoral cutaneous on your own? No. It was like, okay, he's over here. That's it. Sacral plexus, one of these guys. So why him? You know him. He's running down with a sciatic nerve just close to it. If we dissect him, he's underneath the fascia lata. So you see already the trunk over here. And if we enlarge, you see the trunk remains underneath. So you always send small fibers to the subcutaneous tissue to cover the skin innervation areas. He's allocated too. But the problem is, how far does it go distally? And if you see, oh well, cool, that's really a huge one, but separated to the sciatic nerve due to fascias and fascial layers. So he's running distally. Again, if we remove the gluteus maximus, you still do not see any sciatic nerve. So it's very important concerning the block techniques, because the far distal you go, for example, subgluteal, midfemoral, popliteal, he will be too far away that if you block the sciatic nerve, you will get the posterior femoral cutaneous. So you need to sniper him separately. Oh, damn, again. Remember, axillary fossa? Okay. So, as you can see it on cross sections, this is the sciatic nerve. He's really far away in the midfemoral area, and again, still well visible. And if you see the cross section in the popliteal fossa, still visible. So he's over there. He's running distally. This is already in the popliteal fossa, where he should end, according to our literature. Because if you take the literature now, I love this. This is ending over here. If you go to Hollinshed, it said maybe proximal third of the leg. And I received a call by a colleague and said, okay, how far does it go distally? I said, I have no idea. It's regular in popliteal fossa. You're sure? Wait a minute. Took a book. Oh no, proximal third. Are you sure? I said, why are you asking me? I said, well, I'm in the operating room, it didn't work. Oh. Now that's the beep in the backside. Yes, it is. It didn't work. According to the guidelines, it should have worked. So I said, yeah, I have no idea. But we'll take care of it. So we went into the dissection hall and dissected. Fortunately, we had a dissection course about a week later with 50 cadavers, not 50 cadavers, 50 limbs. So we took all the 50 and just dissected it. And then we took another one, some of them, altogether about 90 limbs, and these are the results. And we were not quite happy with that, because as you see, we dissected it as far as distal as possible. Sorry, it's German, but anyway, over here, this is the publication in BGA. And you see, we just had the proximal third of the leg, the distal part of the leg, and then divided into different sections. And most important, these are the results. So you see, if you take the zone 3, we are high frequently in this area where you have the Achilles tendon. So he's covering not only the Achilles tendon area, but also the ankle area, even reaches the plantar pedis. And that's causing some troubles now. Well, not real ones, because if you make now the popliteal block, it's no problem at all. You just go underneath the fascia, search for the posterior cutaneal femurs, and then over there you sniper him out. In one block, just with repositioning the needle. So it's not a real big deal. But if you do not, prior your skin incision, you get into troubles with your surgeon. So quite a good idea, isn't it? Okay, example number 2. Adductor canal block and the distal femoral triangle block. I do not want to go on the definitions because Bernhard Morigl already dealt with that. Concerning the anatomy, it doesn't matter. You just try to perform a femoral nerve block very distally, or even, let's say it like that, regularly just the saphenous nerve itself. Concerning the anatomy, you know that the adductor canal block should be performed somewhere around over here. You see this the vastus medialis, you see the adductor muscles, and over here this is the membrane. So, just a minute. I'm a little bit nervous. It's the membrane, you see the vascular systems, and over here this is the saphenous nerve. I just enlarge it, and you see the sartorial muscle. So, block indeed for the adductor canal, while underneath, just get the nerve, voila. Should be like that, shouldn't it? I think so. Okay, but when we take a look closer to the anterior branches, anterior cutaneous branches of the femoral nerve, you're just having over here, this is the sartorius muscle on the right leg, medial aspect. You see all these different nerve fibers. They are running distally. You see subcutaneous fat tissue. And over here, also some nerve fibers in the deep. And watch out, coming this one and this one. Because we trace it a little bit. And if we enlarge and put the sartorius down, the nerve fibers are running underneath and then whoop up. You see? Well, who is it? Well, that's your infrapatellar branch. And you all know regularly this should come or arise from the saphenous nerve. Where's my saphenous nerve now? That's over here. So we are absolutely now in the wrong area, because if you make an adductor canal block down there, and there is your infrapatellar branch, you will get another trouble with your surgeon concerning any knee arthroscopy. You see, you make nothing wrong. It's the guideline who says, but your nerve is not over there. That's unfair, isn't it? Okay, so what can we do? Well, you see, if we get back to our cross-section, it's also visible. You get over here your saphenous nerve, but unfortunately all these little dots are your superficial nerve branches, which you should cover too. And nobody is saying it to you that you should go superficial to the sartorius muscle, because you know there should be a subsartorial plexus, but subsartorially there is nothing. This is unpublished yet. We are working on that, so you will see the entire results. Nevertheless, we were wondering too, because this is not described in our textbooks. So, as you can see, we are facing variable anatomy. That's the law of life. Variability is the law of life, according to William Osler. The problem is that we just following our textbooks, we're just still not precise enough. Fortunately, because of you, because you are performing the blocks, you get the problems, and we have to take a look, especially concerning the anatomical point of view, if we find something what we could change for you and to adapt a block technique or to make it more efficiently from the anatomical point of view, of course. The second thing, as you see, fascial walls are developed as on the brachial plexus. You might be in the wrong space. As you can see, if you want to have the intercostal brachial nerve and you inject underneath the deep axillary fascia, you are in the wrong space. You will never reach the intercostal brachial. You have to get to him separately. Also with the axillary nerve. And as you can see, other nerves might be involved in the innervation of a certain area. And this is one of the most important things, what we already published recently. We have to go back a little bit, not to the innervation provided in the textbooks, which are allocated to nerves. As you know, for example, the thumb region should be innervated, the dorsal part, by the radial nerve, superficial ramus. That's not true, because you have to think about the embryology, how the limb is developed. It's taking your dermatoma with it, the spinal segment, and this is the very important information. So every nerve who is getting from the spinal cord segment fibers might also reach this dermatoma. And that's the reason why, for example, the lateral antebrachial cutaneous nerve might provide parts of the thumb skin innervation. You see, we have to go back, because this is also regularly not written in your textbooks and atlases. Second, if you use ultrasound, which is a wonderful device, you have to also be responsible with it concerning your interpretation of the image. You have to advance the needle only inside, because then you can position the needle tip precisely. This is the deal with ultrasound. And according to the volume, I already talked about this today, don't use these tsunamis. So go back a little bit, also from the anatomical point of view. I'm learning anatomy each day. Again, after 30 years, repeat it, learn it, but respect it too. Okay, so just finally giving you something. It's absolutely clear that something goes wrong. You get more stress than myself, because I have the cadavers. You have living patients. So, thanks a lot for being Advocatus Diaboli.
Dr. Philip? Yeah.
Thank you so much. Thank you, Georg, for this wonderful lecture. And thank you, ladies and gentlemen. Welcome to the second session also from me. The topic I've been given to talk about is stratification for regional anesthesia. Do we do it by procedure or by patient? The brief answer is both, but I hope you'll give me a few minutes to explain. First, I would like to also say thank you for being allowed to be here, experiencing your country for the first time. This is a little pic from home. This is where I live and work now. I'm originally from Austria, just as Georg, then lived in Amsterdam for a little while, and now I'm in Boston. This is the Longwood Medical Area. It's a conglomerate of hospitals, of colleges, and of schools that all to do with health sciences. Then this is called Fenway Park, home to the best baseball stadium in the world, directly in the city here. Then you see downtown Boston, the old city, where Massachusetts General Hospital is, the Atlantic Ocean in the background, and then you see another body of water, that's the Charles River that separates Boston from its sister town, Cambridge, where the main campus of Harvard University of MIT is. It's a great place to be, very stimulating. After having experienced only 3 days of India, I think I will come home and I will miss the vibrancy and the energy and everything I experienced here. It may be that I find Boston quite boring when I come back, to be honest. The content of this lecture is a little historic introduction to the evidence-based medicine, acute pain medicine. How can we stratify patients for regional anesthesia, and what would the best practice randomized controlled trial of the future look like? Because we know we struggle to make everybody know how cool our techniques are, but when we get to the real outcomes, even long-term outcomes, we really have a hard time convincing everybody that what we do is really worth it. I would like to say that I have no conflicts of interest again for this, and then I would like to go directly into my lecture. A little historical treatise here. How did evidence-based medicine come into acute pain medicine? I think the first thing was the Oxford League tables. Here the focus was the medication, not the patient, not the procedure, just the medication. And evidence was gathered from different trials, and what we came up with, numbers needed to treat. And this was like all the rage in the 1990s, the 2000s. And soon people came and said, well, there are different procedures, right? And these procedures are different by the pain intensity that they cause. And they're different even in the etiology and the pathophysiology of the pain they cause. So bony pain is different from an abdominal pain, and different drugs may have different workings. And from this came a little bit this focus on the procedure-specific side of things, the age of the protocols and the guidelines. I had the pleasure of working with Professor Rawal on the Prospect Group for a few years, and he and Dr. Girish Joshi, who also has very strong roots here in Pune, have been instrumental in making guidelines that helped thousands and tens of thousands of patients, tens of thousands of providers treat their patients in a more evidence and better way. So thank you for that, Dr. Rawal. But then I would like to tell you a little story, and you can tell me if you find yourself in what I'm about to tell you. So you wake up in the morning and you make your way to the hospital. There is a black box in between with lots of coffee and the commute to the hospital. And then you're there and you see your schedule, and it's 3 surgeries. 3 surgeries, all 3 hip replacements. And the surgeon is very opinionated in the anesthesia that they require. And so he says, it's a posterior approach. I would like you to do general anesthesia. So you go back to the Prospect guidelines and you look up the perfect plan for general anesthesia. And you give the same to all 3 patients. There's the same surgeon, the same team in the room. And when you go back to the patients afterwards, one patient will tell you that they were extremely anxious before, and they were right, because they're hurting so much, it's not okay. They need more and more opiates and they're not doing well. Another patient may say, it was bad, but it's okay now. And the third patient may say, you're the best. You're the best. I will recommend you to all my friends. Everyone should come here. You're the best anesthesiologist I've ever met. Does that sound familiar? And you did the same thing, same technique, same procedure, same day, but you think, I don't know. So are patients really that different? And I think they are. The inter-individual variability is very huge. This was a meta-analysis of elective hip surgery patients where groups, the control groups, were basically taken out of all the trials. So this was only people who got a very basic analgesia, opiates, paracetamol, and maybe a COX-2 inhibitor. 70 studies, about 6,000 patients, and some of them had, about half of them had the general anesthesia, the blue curve, and the purple is spinal anesthesia. And what you see here is that in the general anesthesia group, 1 hour after surgery, mean and standard deviation are 6 ± 2. So it's between 4, which we consider absolutely acceptable, and 8, which is really bad. And the range is actually between 3 and 9. So from mild pain to excruciating pain, same procedure, same analgesic regimen. If we go into, are patients really that different? Then we find basic science experiments where they took volunteers and they brought them in. So this is 321 volunteers, no chronic pain patients, no opiate users. And they were brought in and they were given a heat stimulus that was supposed to trigger a VAS of about 7, clearly discernible moderate pain. And this is what patients described. Among these 300 patients, on a scale from 0 to 100, some said 4 and some said 100. And even more complex, as we grow older, the likelihood of experiencing different types of pain, acute or chronic pain, changes. So some types of pain increase, some types of chronic pain and some types of acute pain actually decrease when you get older. If we transfer this to our surgical patients, I would like to point you towards a study by Patrick Teich from Florida. What they did is they looked at a surgical patient collective, just regular surgical patients that were treated at the discretion of the anesthesiologists and surgeons that were there. And they looked at the average pain over the first 7 days. And if you look at the mean plus standard deviation, it looks like a pretty homogeneous collective. And you think this is about it. But if you look closely, you will actually identify 5 groups within this. And granted, most of them are this line and this line. These are the, within here lies the bulk of the patients. But then there is a subset of patients who have high pain all throughout this, who never get below severe pain. And then there are patients who have very little pain to start with, and some patients who recover very fast. And granted, the bulk is on the average, but there are patient categories that should maybe be treated differently, especially this one up here. And it's so hard to predict which patient is in which group because the biopsychosocial model of pain that we all know is difficult to implement in each and every surgical patient that we get. So it's impossible if you have 3 rooms and 3 surgeries in every room to do a holistic assessment of the patient's risk factors as they go into surgery. So we need something a little bit more practical. If we knew what the practical thing was, we might be able to tailor our interventions better. The summary of the first part of my lecture is that in acute medicine, we have seen an evolution in the evidence-based medicine from 1990s until now. We started out with league tables focusing on the medication. We moved to procedural characteristics as the basis for guidelines and focused more on the procedure than on the other factors. And now it's becoming apparent that we need to take the individual characteristics of the patients into account to do a much more detailed stratification to account for the individual variability, which is actually enormous. So how to stratify our patients? And this is work in progress. We have no perfect answer to this. I would like to introduce you to some of the methods and show you preliminary studies how they might be applied. The tools that we can use are broadly defined into 2 classes. One is psychometric and one is biophysical. Psychometric means that you basically give the patient a questionnaire. You ask them about self-reporting factors such as catastrophizing. Are the patients very anxious, very worried about pain, and worked up about the pain before we even started the whole procedure? Then that's a risk factor for having more acute and possibly chronic pain after surgery. The other thing is biophysical, so you can actually test how the patients are wired by applying different stimuli. Wind-up ratio means you apply the same stimulus again and again. If the patients start to feel the pain more and more as you repeat the stimulus, even though it's not really painful, then they may have something that's predisposing them to a very exaggerated pain response. Between those 2, you should be able to get a good idea of the patient and what their propensity for pain is, but it's difficult to do this in each and every patient. So there have been some studies that I would like to share with you that shed a little light on this. And to see the effect of this, we would need to have a surgery where we know regional blocks work, but we don't do them on a regular basis. And so one of the things the group I worked with tried was mastectomy, because it's patients that go through a very difficult time. We want to do our best for them. We know blocks work and make it better, but most hospitals don't offer this to every woman that comes in and has the surgery, because we think that most of the patients will do okay, but we also know that there are some who won't. So using the catastrophizing scale, we could stratify the patients into those that have psychosocial risk factors for acute and chronic pain and those who don't. And so this first trial by Nathan was published in 2019. And these were patients that got a nerve block for mastectomy, single-shot long-acting nerve block. And if you look at the low catastrophizers, and then this is just one of the outcome parameters, you look at who took opiates 2 weeks later, you see that there is not a big difference. But if you look at the high catastrophizers, you see that there is a big difference, and they can actually be brought back to the baseline by doing a nerve block. So you have some patients here that actually don't need a nerve block to do well afterwards, and you have some patients for whom it seems very beneficial to get a nerve block. If you did a randomized controlled trial and lumped all these patients together, the outcome would be nothing. But if you stratify, maybe we can get closer to the truth. And this is early days and small numbers, but it's just a glimpse into what we might strive for in the future. What about chronic pain? This is a follow-up of the trial just before. It was published 2 years later. And if you look at longitudinal pain, pain intensity, pain severity at 3, 6, and 12 months, and you look at the pain severity index in the patients who got a block or no block, and this would be the typical trial, you see nothing. There is no difference. What you do see is that longitudinal pain is higher in those patients that are high, that have these psychosocial flags on the psychosocial assessment. But if you combine it now, and again, I caution this is small numbers and preliminary studies, if you go the way forward and you say low catastrophizers, no benefit, whether they got a regional block or no, makes no difference in the pain. And this is the majority of the patients. In the high catastrophizers, you actually have less chronic pain at 3, 6, and 12 months if you do this one intervention around surgery. And again, small numbers, early days, but you can see that there is a really big difference in that what we can make if we just try to look a little bit more at the individual patient. If we lump it all together, no difference, but if we try to find out who are the patients that really benefit the most from our interventions, we analyze them separately, we might come up with very cool results. And this is a call against watering down our own research. I was always having trouble with this report by Spencer Leo from 2007 already, where he summarized basically all the evidence on different analgesic methods, among them epidural analgesia. And he says if you sum up all the studies on epidural analgesia and you average out the average pain benefit on a scale from 0 to 10, it's 1. But it doesn't mean epidural doesn't work. It means a lot of patients got an epidural who might have done fine without it. And we failed to pick out those who really need it. So we could stratify our patients prospectively. So this is a study on back surgery patients. And this is pain and disability after surgery. So you might agree with me that the red group has high pain and high disability. How could we find them out? So these could be identified by, again, a psychosocial and an amnestic assessment that can be done relatively quickly. And then we come to what's called precision medicine that other specialties have embraced more than us, where we try to predict what's going to happen, we try to prevent what's going to happen, we tailor it to the patient, and we make the patient participate in it. I think even for the patient it may be nice if they say, a test's been done on me, the doctor really tried to get to the bottom of who I am, how I respond to the pain, and then we tailor the plan especially for me. I think buy-in from the patients could be tremendous. And my dream is that at one point, jealously looking over to the microbiologists, the way they assess what's going to work and what's not going to work before they go into a difficult situation, we have not an antibiogram, but an anti-algogram, where in difficult patients we try to look a little bit and predict what's going to work and what's not going to work. And how does that fit into evidence medicine? Actually very, very well, because the patient values and expectations is something that we may have neglected a little bit. We always had individual clinical expertise, and we had a lot of focus on the best evidence-based medicine on the group level in the past decades, and it's time that we brought the patient, the values, and the psychosocial risk factors more into the equation. The summary too is that patients have complex biosocial profiles. The challenge is to develop easily teachable and implementable markers. The future will be personalized. My dream would be the anti-algogram. The evidence-based medicine needs to consider physician expertise, patient predispositions, and the procedure-specific evidence. Acute and chronic pain medicine have seen this amazing evolution. We've come to appreciate individual differences, and I told you a little bit about the methods we might use to stratify. And evidence-based medicine needs to focus on all three elements of the triad. Coming back to the first slide, the changes in focus of acute pain medicine were from drug to procedure plus patient. How can we stratify patients for regional anesthesia? I would still say procedure-specific guidelines are the basis, at patient characteristics, and we should really be in a good place. And what would the best practice RCT of the future look like? It would give us much more information on the detailed patients. It may even try to stratify them, and we may be surprised of how cool the results of these trials would be. Thank you very much for your attention.
Thank you, Professor Fiegel. I call upon the next speaker. Meanwhile, I would just share a thought that crossed my mind right now. Professor Fiegel told us that, okay, anatomy is going to be variable, and he's very vociferous in saying so. We can see from that slides that he said. Dr. Philip told us that now the perception is also going to be different. Variable anatomy, variable perceptions, and our journey of 100% regional blocks go on. So let's see.
Hello, everybody. I'm Ophélie Grimaud from France, and I'm honored and delighted to be here and to be invited by Sandeep, and thank you very much. So I'm going to share with you my experience in neuraxial blocks today, which will be continuous spinal, and that I practice since more than 25 years. Continuous spinal anesthesia is a centennial technique which has been invented or imagined by Dean in 1906. Then it has been improved continuously by Lemon, Lang, Bizari, and Thuoyi since 1944. They used it in different surgical anesthesia and also in obstetrics for labor and cesarean delivery. First of all, you should distinguish the two types of catheters. The through-the-needle catheter, which is epidural catheter, for instance, everybody knows this device. Microcatheters that have been used in 1985, 1987, and then they stopped because of a lot of reasons. And actually, there is on the market, it's a Payung intralong catheter, which is a 27-gauge catheter introduced through a 22-gauge Quincke spinal needle. And the over-the-needle catheters that I know and I use since 95, which is Spinocat, not any more available in the market, and the Wiley spinal, which is a 23-gauge flexible catheter introduced over a 27 pencil point needle, introduced both of them through a peel-away sheet over a standard Thuoyi needle. For major abdominal surgery, regional anesthesia provides stress-free surgery, reducing morbidity and mortality by affording a powerful neural blockade, total muscular relaxation, so total comfort for surgery, with hemodynamic stability, especially in elderly frail patients, and efficient postoperative pain relief, which allows rapid mobilization, reducing postoperative hypoxemia, affords the inhibition of the reflex response of the intestinal motility, anticipating the discharge. So the key to obtain all these advantages is spinal anesthesia, of course, but spinal anesthesia is limited in time and in dose. So it's better to use continuous spinal anesthesia. And if we compare continuous spinal anesthesia to combined spinal epidural, continuous spinal offers better surgical comfort because muscular relaxation is 100% and for an unlimited period. Also, you can use lower doses of local anesthetic and opiates because you can add anytime you want. And it offers also a more efficient postoperative pain relief. So, Continuous spinal is indicated for major abdominal surgery by laparotomy and laparoscopy. In elderly and frail patients with cardiomyopathy, chronic obstructive pulmonary disease, morbid obesity, renal dysfunction, giving the possibility of titration. It is also very useful in emergency situation with bowel obstruction, full stomach. So we shall see some case reports. This is a wireless spinal. Recurrent cancer and metastasis depends on the immune competence during the direct period of perioperative period. And this immune competence is impaired by surgery per se, anesthesia, and opiates. We can hope that CSA may reduce the risk of recurrence after major cancer surgery because regional anesthesia can improve the immunity competence by decreasing the stress of the surgery and the requirements of anesthetic drugs. There are some studies since 2008, but I think some new ones are getting ready. So let us see some two examples of cancer surgery with laparotomy and also another case with laparoscopy. So, despite the limits of continuous spinal, which are urinary drainage and the need of a good experience and careful technique, continuous spinal is safe and efficient, avoiding general anesthesia and the use of muscular relaxants. It affords early mobilization, active nursing, early nutrition, decreasing the respiratory morbidity rate, and the cost effectiveness and its cost effectiveness, because it decreases also the global cost of the whole pathology. Now, another indication, except major abdominal surgery, is obstetrics, but it's more limited because it's only indicated in trial for labor patients, in those patients who have morbid obesity, gestational hypertension, previous spinal surgery, significant cardiac disease, and difficulty of airways, resulting safety with the possibility of immediate conversion to C-section and without risk of any complication like total spinal or intravascular injection, and satisfaction because of the rapid onset with high quality analgesia and minimal doses of drugs, but also hemodynamic stability without motor blockade. So now we shall look a little bit the next. So this is a C-section.
I'm afraid of the world, losing love in the dark. Every time that I move too fast, I fall apart. But I think you're the same, and I know that you're scared. Think too much of the end, and we will never stop. We still sleep with the light on, so afraid it'll go wrong. Take your time if you need it, but don't wait. When you know you feel it and you're ready to go, ready to call this love. Don't speak if you don't believe it, but please say those words if you mean it and you're ready to call this love. I don't know what to say, that's unusual for me. First step is the hardest one you'll ever take. Sparks with the light on. Oh, let's be brave, turn the light on. Take your time if you need it, but don't wait. When you know you feel it and you're ready to call this love. Don't speak if you don't believe it, but please say those words if you mean it and you're ready to call this love. Are you ready yet? Are you ready? Are you ready to call? Are you ready to call? Are you ready to call this love? Are you ready?
So it's, I only just to tell you the, no.
I'm afraid of the world, losing love in the dark.
Now, I wanted to show you the working labor with continuous spinal, but it's too late, I think. So thank you very much.
Thank you. Thank you for that wonderful lecture. We call upon the next speaker, who's none other than Dr. Diwan.
Dr. AJ, she is called AJ Yamak. She won't be here because she's not well, and we pray for her health. This was a talk on Peng. She's my friend, and we do a lot of academics. Next, please. So, this was about the talk on Peng block. What do we know? So far, we saw that the sci-fi block, the circumpsoas block, or the femoral nerve block. Does it act on the obturator nerve? Because a complete lumboplexus block will be one which would act on all these three nerves. So did any of these blocks reach the obturator nerve? It's no. The Peng is a result of obsession for obturator nerve. This is what I feel, and this is what most of my colleagues, they feel. They have been striving hard to reach the obturator nerve with all these blocks. They don't, probably they don't remember that there is a big facial layer which might separate these two nerves. We have been studying on that. Based on innervation of hip, Short described the femoral obturator nerve and the accessory obturator nerve which innervates the capsule. So these are the three important nerves. The articular branch to the femoral, articular branch to the obturator, and the accessory obturator nerve. Clinical study by these authors, what they did was they positioned their needle here, lateral to the psoas tendon, under ultrasound, injected 20 ml, and they seemed to block these two nerves. So the target area was the iliopectineal eminence, and suddenly these two structures became of paramount importance for all the anesthesiologists throughout the world. Placing a probe here and getting your needle lateral to the psoas tendon. Cadaveric study, which was mentioned again yesterday by Ramurthy, and they found that these obturator nerve can be soaked with 20 ml, and this can be with 10 ml, it does not. And they claim that this is a true pericapsular block. So if you understand anatomic concept here, you will find that this is the psoas tendon, that's the iliacus, and then you have the psoas iliacus fascia with the femoral nerve on the top. But remember, you have a iliopectineal bursa here, and this is intrapelvic and extrapelvic both, and 15% of the times it communicates with the capsule of the hip joint, and it would be quite possible that if you invade this, there is a possibility that it might extend inside the capsule. Some radiological studies have found that when you inject into this, you have got profound pain relief when you have hip joint pain. So sometimes I feel that whether the Peng is really an intrabursal injection, whether we have been doing this. So my friend, she has described in her article about the extent that what the local anesthetic would spread, and it depends upon the barriers. And these are the iliofemoral, the pubofemoral, the bursa, and the iliopsoas. So these ones. And these changes with age and with the fractures. With the fractures, you might traumatize this, and there could be the local anesthetic spreading either ways. And in old age patients, this could be ruptured. So the possibility of overcoming the barriers. So the mechanism is spread, which is cranial and caudal between the ligaments and the psoas bursa. So it could be just like that, and then it could be this way. In one of the studies where it was a dose-finding study in cadavers, where they injected 10, 20, and 30, and they found that with the 10 ml, it did not soak the femoral nerve, but with 30 ml, yes, and the obturator nerve was surprisingly 16%, and they concluded that this is not a motor sparing. High volume is not for ambulation. Low volume does not soak the obturator. Now, we did a couple of studies. One was in Mysuru in the CAD lab, and we injected, what we did was we injected the sci-fi block and the PENG block. The sci-fi was with the blue and the PENG was with the green. And we injected both at the one single point. And what we found was that if you split the iliacus, it was methylene blue because we do not have latex. And it was the green on the dorsal side of the iliacus, while the blue was on the ventral side of the iliacus. The green went until the lateral femoral cutaneous nerves. In the infrainguinal, the green, that is the PENG, it stained the anterior division of obturator nerve. And we found just one specimen on which the accessory obturator nerve, which is quite rare, and we found it in only one specimen. So when you inject over the iliopubic eminence, it will stain everything, the bone, but not the nerves on that. And surprisingly, it stains the lateral femoral cutaneous nerve and the obturator nerve, but that is infrainguinal, and also the femoral nerve. We had another study in Madurai in the CAD lab again, but this time we had cross sections. And when we did the cross sections, you can see the psoas tendon, the point of injection, and the flow of the dye going lateral and then going on the ventral aspect. This came somewhere at the level of the femur bone, and it was quite lower than the hip capsule. And somehow it went intraosseous. I'm not sure how did this dye go intraosseous in the cadaver. So all in all, this was like you're giving a block at the level of the psoas tendon and ventral and dorsal to the iliacus. We felt like it was just nothing but a dorsal fascia iliaca block. They claim that these are all the indications. They have opioid sparing, early ambulation, immediate recovery, and it's safe in anticoagulated patients. So what is the clinical fate? These are the authors. That's the consistent site of injection with one variability. Consistent volume injections, again with one variability. They all mention that it's like a fascia iliaca block. The mechanism is bursal spread. Quadriceps weakness, 25 to 40%. Now these are the ones which were earlier and then a bit recent one. The site remaining the same, the depth remaining the same, the volume same, no quadriceps weakness, and there is no mechanism of spread which has been mentioned. So we really do not know how the PENG really acts. Do they really block these nerves? How it blocks? Or it's just another fascia iliaca block from below? Hence, I call it as a dorsal fascia iliaca block. So do we have any answers? Does it act independently? No, you need to have a block along with it. Does it provide analgesia to the entire hip joint? It's no. Do you need to inject for a patient to sit? I'm quite surprised that there are a lot of articles where you give a PENG and make the patient sit. Why do you want to do that? I'm unsure about this. What could be the duration of a single bolus? Again, it's questionable. And could you recommend catheters in this case, in the PENG block? It's a no. So it's for you to decide whether to use it or not. Thank you very much.
Yes. So we've covered quite a diverse thing. We've covered from uncertainties to a very, very certain spinal. Open for discussions. House is open for discussions. Yeah, Sandeep hinted. Yes, you can. Yes, sir, please.
So can you come to the mic, please?
Comment and question, Ophelia. Where shall I stand? Here? Okay. Ophelia, good to see you in India. Thank you for talking about the spinal technique. And I'm also thankful for the organizers to include that, because everywhere you go here in this Congress, it's all these peripheral blocks and ultrasound all the time. So I have a comment and a question. So spinal technique, which is 125 years old and still going strong. You don't need ultrasound. It works anywhere from here all the way. Can be used all over the world. Anyone can do it. Surgeons do it, others do it. And all you need is a small syringe, little bit of local anesthetic, homeopathic dose of morphine, 100 micrograms, and it works. So it's not being used so much. It's also considered almost obsolete. And to then use a catheter is fantastic, in my opinion. And it can be used, if you're lucky, with that tiny dose of morphine. You can get, even as a single dose, maybe 24 hours if you're really lucky. And this is evidence-based, even up to 40 hours of analgesia. Sorry. And so my question is, I think we should be using more spinal technique. But my question to you is, you did great demonstrations and you made all the claims. Everything is fantastic, including this impressive video, etc. If it is that good, why isn't the whole world using it? It's been around. Even spinal, continuous spinal has been used, you said yourself, more than 100 years. Nobody's using it. Why?
Thank you, Narinder. I love this question because it's my, I'm already retreated, but I still work. And I'm so sad to see how our profession is submitted to money. Because the answer to your question, it's just money. It's not enough expensive. That's all. And not only this one, you'll see the other things I do. And I remember when I started to come in the ESRA conferences, and I met so nice people as you, and we were talking really about regional anesthesia, about neuraxial blocks, which are, in my opinion, the most efficient. But then, when peripheral blocks started to be developed, which is very good things, peripheral blocks are absolutely interesting and useful, but this simple spinal anesthesia, or combined spinal, or continuous spinal, are not enough expensive. They cost between 30 euros up to 130 for the per-operative and post-operative, 2-3 days post-operatively. So it's, the sponsoring is not interested anymore. So I give you the right, what I really feel, and I'm very sad about. And I think that I know that here in India, you use neuraxial blocks because they are efficient and because they are not expensive. And I really congratulate and love you for that. But I do also in France.
Madam Mansuka.
Yeah, I guess that should be the last question because I can sense hunger.
Actually, the continuous spinal, what is your experience about the Kodaikanna syndrome? Because that is the complication because of which it went in disrepute when initially it was introduced.
Well, absolutely none, no quadratic syndrome. It was a story about that with the microcatheters. And I think, well, the problem of the microcatheters that have been used in 1985, I think, and then stopped quickly in America, I think, it was the problem, the real problem is the catheter. It's so fine that you cannot put it in, you cannot place it in order to have a good level of surgery. This is a problem of microcatheter. Then the syndrome of quadra echina, I think it was the reason was lidocaine. But by that time, we used lidocaine, hyperbaric lidocaine was used, 5%, and it was toxic. And maybe also the fact that this microcatheter went, touched a nerve, only one nerve, because it was so difficult to handle. With this toxic lidocaine was the result of quadra echina. But I never had such a syndrome in my experience.
Dr. Shali, just one question. Just one question. So, Dr. Ophelia, would you recommend, I'm here, I'm right in front. Would you use a continuous spinal for instance for an emergency?
For what?
For an emergency laparotomy, for example, it's a perforation peritonitis or a case, you would. That's my question.
This is the solution because I do not like cellocurin. I don't use it at all. so
I didn't get that. You don't like
cellocurin? What's the name? Suxametonium. Because of the risk of
muscle relaxants.
Yes.
Thank
you. So I always prefer when I can, if there is no contraindication, I always prefer a neuraxial block, continuous spinal or combined spinal epidural. Depends on the duration of the procedure.
Thank you. Even if the patient has anticoagulants, would you use it? No.
If I use it with?
With anticoagulants, if a patient was on anticoagulants.
That depends. That depends. Yeah, I understand. That depends of the anticoagulants. If in a vascular surgery, they are all antiaggregants, and I use it routinely. That depends, and if they have an indication of anticoagulation, I can make a window, you know, in order to have the good period for the surgeon and for me in the same time. Normally, you don't have bleeding when you do such a neuraxial block. If you do it properly, of course, it's a matter of how you do it.
Thank you.
So thank you very much for that interactions. There is a quiz round which is being held, elimination round, which is being held in Hall D. So whoever are the participants, please join. So thank you very much, Dr. Rushali, Dr. Satish, and
Thank you very much.
Ophelia, Lurk, and George. Thank you very much.
Speaker. Mic. Hello. Good afternoon, everyone. So after a wonderful lunch, before you people get dozed off, so we'll start a very interesting session which will keep you awake. So for that, I will invite moderator Dr. George Feigl and Dr. Shahida Parveen. I think she'll join in a meanwhile. So we'll start the session. Dr. George, over to you.
Okay, thank you very much. I want to invite everybody to sit down and to get ready for this session with the title Obsolete Techniques, Reasons, Resurgence, or Replacement, which is quite confronting, but we're looking forward for the three presentations we have over here. And the first one is by Dr. Ujwal, the 3-in-1 block. So please, it's your stage.
Good afternoon, everybody. So as we are discussing the obsolete blocks, whether they are actually obsolete or they are being replaced or they are resurging, I'll be talking about 3-in-1 block. Let's see what is the verdict. Was described in 1973 by Vini, and he labeled it as axillary perivascular block of the lower limb. And he suggested that the nerve in the pelvic region are surrounded by sheath, which is formed by fascia iliaca laterally, psoas and iliopectoral fascia medially, anteriorly the fascia transversalis, and posteriorly the iliopsoas fascia. And this forms the basis of the proximal spread covering all the three nerves in one go. This was his statement by Vini in 1973. And he described the technique of single injection. You have to prick inguinally lateral to the femoral artery, elicit the paresthesia with hitting onto the nerve. When you get that paresthesia, you're supposed to inject, but before you inject, give distal pressure so that the drug is not going distally but goes cephalic. He suggested injecting more than 20 ml of local anesthetic to block all the three nerves. So what was the relevant anatomy, what he proposed? So if you see this region, you have the iliacus muscle over here, you have the psoas over here, and the three concerned nerves, the lateral femoral cutaneous nerve coming laterally onto the iliacus, the femoral nerve coming straight away behind the psoas lying onto the iliacus, and obturator over there medially, going medially behind the psoas. So three nerves in three different directions after they come out of the lumbar plexus. So what were the indications? What Mr. Vini suggested was surgical procedures and distributions of lateral cutaneous femoral and anterior division of obturator nerve, patella surgeries, perioperative analgesia for hip and shaft femur surgeries, and also knee surgeries, and pain therapy for phantom limb pains. And since then, it has been extensively used for analgesia of hip fractures, more so by the emergency medicine guys, and huge amount of literature published, good analgesia, all three nerves block, good pain relief should be given. But somewhere it did not stand the test of time, and as the literature kept on pouring, the obturator nerve was the culprit nerve, which was creating trouble most of the times. So in 1989, Koepe and colleagues decided to see whether it is a myth or a reality, whether it is actually a 3-in-1 block with a single injection or there is some issues with it. There are some issues with it. So they did a radiographic study of volunteers. About 20 to 60 ml of dye was injected, and they did radiographs and computerized tomographic scans, and they found that there are two types of diffusion happening. One is the internal diffusion towards the psoas muscle, and then the drug reaches the three nerves. But there is one more type of diffusion, which is the external diffusion, which happens in front of the iliacus muscle, and it never reaches the obturator nerve. So they said that this is a myth. And since Mr. Vini did not confirm his drug spread with any subjective finding, any objective finding, they say it's really a myth. And they concluded that 3-in-1 block does not block the obturator nerve consistently. Few years later, Parkinson reviewed 40 patients who received the 3-in-1 block with paresthesia as well as PNS technique. And they injected 0.5 ml per kg, so roughly more than 25 ml because their patient population was weighing from 50 to 116 kgs. So more than 25 ml in each and every patient, and evaluated motor sensory function using a nerve stimulator. And they said, irrespective of the technique you used to give the 3-in-1 block, whether it is paresthesia or nerve stimulator guided, obturator nerve was routinely spared. So again, they refuted that Wien's hypothesis of single shot 3-in-1 block. Then in 1993, Dr. Lang and colleagues, they revisited this block and did again objective assessment and demonstrated that only 4% had the ability to adduct the hip post block, had the inability. So only 4% of them had the blockage of obturator nerve. They also concluded this is a block which is good for lateral femoral cutaneous nerve as well as femoral nerve, but it spares obturator nerve. Now there was also an issue as the literature was pouring in. Now what is this? Is this 3-in-1 block or it is only femoral nerve block? So then they started saying that if you give 5 to 10 ml in the same area, it becomes femoral, and if you give more than 20 ml area, it becomes 3-in-1 block. So volume was the thing which was deciding whether it becomes femoral or 3-in-1 block. Plus spread was not consistent. So there were issues and the block started fading. Then came Dallin and he said there is something called as fascia iliaca compartment block, and he said this block is good enough to block all the 3 nerves. He did a comparison with 3-in-1 and fascia iliaca, and the technique he used was infrainguinal, pricking 1 to 2 centimeters away from the femoral artery using double pop technique. At the second pop, injected drug beneath the fascia iliaca in children. And he found that 90% of the time, all the 3 nerves were blocked. But this was used for analgesia. So it was not sure whether obturator was blocked. There was no objective assessment of obturator blockage and no objective assessment of dye spread or drug spread. Now, one more colleagues in 2012, they did it for arthroscopic and meniscal repairs of the knee, used landmark guided fascia iliaca suggested by Dallin, the double pop technique, used 45 ml in 3-in-1 block, and they compared both of them. And they found that both are equally effective, but fascia iliaca compartment block was technically more easier to give. Again, here the assessment was pain, analgesia. So as literature started pouring, people started understanding there are certain issues. So what is the issue? So the issue is that the facial layer, which we are thinking, the fascia iliaca, the femoral nerve is beneath it, and obturator and lateral cutaneous femoral is above it, both in medial and lateral direction. As you can see here, lateral cutaneous above the fascia iliaca, this one is the fascia iliaca going, femoral down, lateral cutaneous above, and obturator somewhere far away in the medial anterior and posterior division. So this was not giving the consistent result spread towards obturator, although some diffusion would occur with the lateral cutaneous form, some amount as it spread cephalad, it did block lateral cutaneous femoral. Volume was the key factor which determined the cephalic spread and blocking laterally as well as medially, reaching onto the lateral cutaneous nerve and the obturator nerve. And yes, anatomy isn't that consistent to permit the spread laterally, medially, and inferiorly equally, in spite of good amount of volumes. So literature was pouring and there was not a single block which was sufficient enough to give all the 3 nerve blockade. Then came suprainguinal fascia iliaca block. So described first by Hubbard in 2011, and he injected 20 ml dye in the cadavers and had good spread with lateral cutaneous femoral and femoral nerve. Then came these guys and they did suprainguinal fascia iliaca block and suggested that consistent spread towards the lumbar plexus than the infrainguinal fascia iliaca injection. There was a volunteer study and they had objective assessment. So they had objective assessment of the block using sensory and motor assessment. They actually went and checked the motor function of each and every muscle. And they had MRI imaging on top of that, both axial as well as coronal images, to figure out the drug spread. And they concluded that it blocks successively all three nerves, but the volume they used was 40 ml. So suprainguinal, 40 ml, they said it consistently blocks all the three nerves. So this was coming as a promising thing for single shot injection, which will cover all the three nerves. Now, what is the role of ultrasound? So if you are giving any block with ultrasound, you can actually look at the structures, target your needle point, and see the drug spread. So if you're giving a fascia iliaca block, this is the fascia iliaca, your needle tip is coming here, you deposit the drug, this is the femoral nerve, you can see the drug spreading here and here. And if you turn the probe, you can see how cephalic it is going and how rostral it is going. Same thing with USG. If you're giving a femoral nerve block, you're hitting, coming this way and putting the drug just close to the nerve, either beneath the transversalis fascia or beneath the nerve. Something similar what a volume of fascia iliaca would do. But then you can assess the drug spread. So ultrasound is a good technique, immediate assessment of drug spread. So it has a definite role. Now, as we were thinking that, literature is now refuting that there is no single 3-in-1 block, and SIFI could probably, the suprainguinal fascia iliaca block could probably be the single shot injection block. These guys came with a study for total knee replacement, and they used the same femoral 3-in-1 nerve block, but with a continuous catheter. They used the PNS guided technique, not the ultrasound one, and put the continuous catheter in the femoral nerve area, and they injected 40 ml local anesthetic solution. And they found good pain relief in total knee arthroplasty without hampering the motor function. So they went and suggested that 3-in-1 block is again resurging, and if you are using good volume, 40 ml or so, you would be getting good amount of coverage with all the three nerves. So now, is this something which is lost and found? I am not sure, because literature has a very skewed, not all of them have subjective and objective assessment together clubbed to understand whether this will cover all the three nerves. Most of the literature suggests that the drug spread is good on the basis of postoperative analgesia, which is again a subjective phenomenon, not an objective phenomenon. So before we conclude, we should understand that yes, there is a need for brachial plexus like block for the lower limb. When you give drug in the sheath and it covers all the 3-4 nerves, 3-in-1 block or SIFI block can offer it to certain extent, but volume is the biggest constraint in doing that. USG definitely has a role to play to understand the drug spread, and we know that more cephalic the drug spread, there is high possibility of covering all the three nerves. And you need to have objective assessment tools to understand whether this block will cover all the three nerves. Thank you.
Thank you very much. As we have the questions and answers after the 3 presentations, please keep down there and for questions. Okay, so next speaker is Dr. Harshal concerning the thoracic paravertebral block. Okay, we're looking forward.
Thank you very much.
For being here.
Good afternoon, everybody. So I'm Dr. Harshal Wagh. I'm consultant anesthetist at Kokilaben Dhirubhai Ambani Hospital. For those who follow cricket, T20 was supposed to be the next big thing. And people thought that, Test cricket is dying, it's dead. But if you go to see, actually, T20 has instilled life into Test cricket. And people with cricket interest will agree with me that Test cricket is becoming better, more results. And because the mindset of cricketers has changed. So T20, instead of making the death of Test cricket, has instilled life into it. So keeping that as an analogy and keeping that at the back of my mind, of your mind as well, let's try and see what we can come with this subject. So till about 10 years ago, I think from when I was doing my anesthesia as well, the only chest wall blocks were supposed to be the thoracic epidural, the thoracic paravertebral, and intercostal blocks, all time tested. We knew that they're effective. But obviously, they were not as popular because thoracic paravertebral technique-wise is difficult. Then the perceived complications, risk. So they were not as popular. Ultrasound has changed the entire thing where, people are putting local anesthetic in spatial planes within 1 centimeter of each other. And so the question comes is whether these facial plane blocks are giving the thoracic paravertebral blocks the run for its money, or has it kept its relevance? And that's probably the theme of this talk as well. So quickly, anatomy-wise, we know that the thoracic wall is supplied by the intercostal nerves. Intercostal nerves give off various branches, which is the dorsal ramus, which supplies the muscles of the back and the skin of the back. Then it comes around the contour of the chest, giving the lateral cutaneous nerves, goes along and forms the anterior cutaneous nerves. And from facial plane point of view, the plane that you put the local anesthetic describes the various facial plane blocks that have been described so far. So we know that. So quickly, from thoracic paravertebral point of view, thoracic paravertebral is putting local anesthetic in this wedge-shaped space which lies on the either side of the vertebral column. And this gives you a unilateral, segmental, somatic, and most importantly, a sympathetic nerve block as well. This is just a combination of, and to understand what kind of blocks and where they are put, to understand what exactly is the facial plane blocks. And now with recently so many plethora of blocks coming up, they're trying to get a nomenclature which describes where the local anesthetic is put. So just quickly running through, we know about the thoracic paravertebral block, which is pushed in the thoracic paravertebral area. A few paraspinal blocks, which is the retrolaminar, the midpoint to transverse process to pleura block, the erector spinae block, which is the flavor of the season apparently nowadays. Going further, laterally you have the rhomboid intercostal and the subserratus plane blocks. You know about the SAP blocks, which is putting local anesthetic. It becomes superficial serratus plane block if it is above the serratus anterior, deep if it is below the serratus anterior. The PEX block nowadays called as the interpectoral if it is the PEX 1, and pectoserratus if it is the PEX 2. We have the combination of the pecto-intercostal facial plane blocks, which are now called as superficial and deep. They were called the pecto-intercostal facial, the PIFB and the TTCA block earlier on. So one can see that installation of local anesthetic as various levels of the intercostal nerves gives you these effects. But putting local anesthetic close to where the thoracic paravertebral lies gives you the best effect, as we can see from a few publications. Now this credit goes to Dr. Amit Pava, who is from RA UK, and quite beautifully put in terms of pictorial wise. So you know that the upper part of the chest, just below the clavicle, is supplied by the supraclavicular nerves coming from the superficial cervical plexus. A good paravertebral block will give you a nice block of the hemithorax. But if you sort of compare it with these facial plane blocks, as we have learned over the years, only a combination is going to give you the same effect as a paravertebral block does. So a parasternal will give you sort of midway towards in the clavicular line. The interpectoral or the pectoserratus goes a little bit more posteriorly. So does the serratus anterior, depending on where you put the local anesthetic. Now, very nice review 2021 in RAPM about the mechanism of action of facial plane blocks. So like Dhoni, that was one of the fastest which is known. We will go through what is known about facial plane blocks. Okay, so we know that the nerves run in and through facial planes. We know that the local anesthetic spreads in facial planes and can achieve relatively high concentrations for neural conduction blockade. We also know that local anesthetic can spread out of the facial planes into adjacent tissue compartments. The amount of local anesthetic required for neural conduction is relatively small. but different nerve fibers have different sensitivity to local anesthetics. It is for a fact that these facial plane blocks don't always give you an expected pattern of the cutaneous or sensory nerve blockade. There's also something which we should consider is pain coming from the deeper tissues, which is from the deeper cutaneous tissues, from the bones, from the connecting tissue, muscles, which whether facial plane blocks do cover, we're not really sure. What is uncertain? Now, so many cadaveric studies coming into publication, and we get excited about the spread of the local anesthetic, but they don't always replicate what you can see in volunteers or live patients. Obviously, the facial planes they're all facial plane blocks. The fascia is different, so the spread is going to be different in individuals. The vascular absorption and the local anesthetic concentration in plasma will vary in individuals. The relation, the clinical efficacy of facial plane block and relation to the volume, the concentration, and the drug mass of local anesthetics is something that we're still looking into. As I said, from deep musculoskeletal pain point of view, we don't know how much the facial plane blocks contribute. Motor nerve blockade, again, is something which is under contention. The additives in the facial plane blocks, whether they consistently improve clinical anesthesia, and whether this is mediated by a local effect or systemic effect is something which is still uncertain. So this article finally came down that the most plausible mechanisms of analgesia with facial plane blocks is probably localized action of these the local anesthetic on the nociceptors and the neurons where the local anesthetic is instilled. This is by way of bulk flow, but also by way of diffusion into other tissues. There is a contention of vascular absorption of local anesthetic leading to a systemic effect similar to that of an intravenous lignocaine infusion. But again, the relative importance of their contribution still remains uncertain. Quickly going through some meta-analysis. This one says you need to put some sort of regional anesthetic techniques when they compared it to control or even local anesthetic. So nothing versus, or control versus local anesthetic versus some regional anesthetic techniques. Obviously, regional anesthetics techniques sort of score higher. They found limited difference in what type of local anesthetic or what type of regional anesthetic technique that you use. Has ultrasound improved the efficacy of paravertebral blocks? Yes. We are privileged to have Dr. Anjali Chabra, who is the author of this. And they have proved that it does, in fact, have safer and more consistency in terms of the paravertebral blocks, because obviously the technology is better, the image process is better, the acquisition is better. And as more people use the ultrasound, more people are getting used to the hand-eye coordination. So obviously practice makes perfect. So the perceived risks of doing paravertebral blocks, as again Madam's publication later on shows, that the adverse events are not as much. Again, quickly going through some publications about comparing facial plane blocks with paravertebral blocks, and you'll realize that the conclusions of quite a few of them sort of sway on either side. So this meta-analysis says that the PECs and the paravertebral block are comparable in post-operative analgesia efficacy for mastectomy. In fact, they go on to say that further studies are unlikely to alter the conclusion. Similar systematic review and meta-analysis says that there is low-quality evidence that a PECs block provides marginal post-operative analgesic benefit, but at the most for 2 hours, as compared to a paravertebral block, but nothing beyond that. Coming to intercostal nerve blocks, this meta-analysis definitely says that a paravertebral scores over them in terms of an intercostal nerve block. Flavor of the season, the erector spinae block. I think erector spinae is so many publications. I think we have had over 1,000 publications since it was described. Now, this one says that ESP proved analgesic efficacy in breast and thoracic surgeries as compared to non-block care, and current literature supports similar or comparable efficacy to a thoracic paravertebral block. Whereas similarly, this one says that if you compare erector spinae block with the pectoralis nerve block and a paravertebral block, it says that analgesic efficacy was inferior to a pectoralis nerve block, but comparable to a thoracic paravertebral block. They found an incidence of 2.6% pneumothorax, whereas no complications as compared when facial plane blocks were given. What about VATS? This was another meta-analysis, 21 RCTs. As compared to control, the thoracic paravertebral shows the greatest effect on opioid consumption. Early pain scores, they said that ESP had the greatest effect, whereas in the middle and late periods, they said that the thoracic paravertebral, ESP, and the intercostal nerve blocks had superior analgesic effect. as compared to controls, but not as much the serratus plane block. Again, Madam's publication, which is a Cochrane database review about paravertebral anesthesia with or without sedation versus general anesthesia, and fairly proven to say that the paravertebral anesthesia reduces the PONV, hospital stay, post-operative pain at 2 hours, time to ambulation, greater patient satisfaction as compared to general anesthetic. But most importantly, even the complications are lesser. There's something else as a paravertebral by proxy. Again, they make an important point that they do affect the somatic nerves, but whether they actually affect the sympathetic nervous system is something to be looked at, because sympathetic nerve blockade improves the quality of acute pain, but also prevents persistent post-operative pain. The main thing of the block would probably whether you can use it as sole anesthetic. So this group used it for 15 cases, and they found that it is a feasible technique to do a combination of thoracic paravertebral and a pectoral nerve blocks. We have got this case series of 70 patients where we have done high-risk patients under combination of blocks. We can discuss if you have time later. And I know for a fact that this is a private practitioner who does these only under landmark guided, not even ultrasound guided, and she has probably done more cases than she has presented here as well. There are a few publications which claim that even pectoral blocks provide enough analgesia for modified radical mastectomy. If you ask me, I'm not sure whether that can really be done even anatomy-wise, but publication stays. This was a recent in BJA about erector spinae block being, this is an editorial actually, whether it is plan A block, because especially for thoracoabdominal anesthesia, because it's safe, easy to do, easy to learn, non-regional anesthetists can do it, and even non-anesthetists can do it. Okay, but the main proponents of thoracic paravertebral blocks, who are also big names in regional anesthesia, like Dr. Steve Coppens, Dr. Vishal Uppal, Dr. Hari Kalagari, Dr. Melody, were quick to give a letter in reply saying that with due respect, paravertebral and epidural blocks still remain the most effective techniques for thoracoabdominal surgeries. They do agree that it is more challenging to perform, and in anticoagulated patients, maybe you need to be more careful. But there is enough evidence to show that these two are still in vogue. Now, this I found just recently is they used a web science as data source to find out medical articles about application of thoracic paravertebral blocks in breast surgery. Published from 1900 to 2022, they found 299 articles totally. But what they found that the trend and the characteristic of thoracic paravertebral application research in breast surgery were visualized, and these studies are increasing every year, annually in the number. So the number of publications are up. So coming back to the topic, is thoracic paravertebral block really obsolete? But I think from so many publications that we have seen, we can agree that both are effective in providing pain relief after breast surgery and thoracic surgery. But whether it has probably kept its relevance, especially from surgical anesthesia point of view, and those facial plane blocks will probably need more time and experience to replace the thoracic paravertebral in that area. Pretty much like Dhoni, we all agree that Dhoni is the best wicket keeper and the best captain we've had so far. With due respect to the other captains and the wicket keepers, they still need more time to come to his level. So, thank you.
So, thank you very much. Well, final presentation now, Dr. Priyanka. Coming up with another topic, we are jumping now a little bit more cranially to the deep cervical plexus block. So it's your stage.
Thank you, sir. And since it's an afternoon session, I've tried to make it as interesting as possible. I bring greetings from PGIMS Rohtak. This is a beautiful place, and I wake to this place every single day. Special gratitude, my patients, my technical staff. Starting with a very small story, since we have a lot of residents. Once upon a time, there was a nerve. And one of our over-enthusiastic residents was told to block the nerve. Meanwhile, this is the consultant who is afraid, never know what's the future, and the surgeon. The anatomy was beautifully covered yesterday by Dr. Sandeep, not going into the details. There are basically three types of cervical plexus blocks: the superficial, intermediate, and the deep. This is the history that it kept on changing, the various studies kept on coming, various techniques how to do, what is the difference between actually subcutaneous and superficial block. So this is the superficial cervical fascia. This is cut section at the level of C4. The superficial cervical fascia is actually the subcutaneous tissue, and this is the investing fascia that made all the difference. It's differentiating from the superficial, intermediate, and the deep. This is the investing fascia, also known as the masticator submandibular sternocleidomastoid trapezius fascia. Then this is the middle layer, and another layer which is of concern is the deep layer of the deep cervical fascia, also is the perivertebral fascia. The indications are the superficial surgery on the neck and the shoulder, the vascular excess surgery, the thyroid surgeries, carotid endarterectomies, clavicle fracture repairs. The contraindications are what obvious, quite for other blocks too, like patient refusal, local infection, previous surgery, radiation therapy to the neck, contralateral phrenic nerve palsy, significant pulmonary compromise, and vocal cord palsy. This was a study in 2003 that studied the spread of the injected. It was quite controversial what are the recommendations they gave. After removing the investing layer, they gave in two cadavers, they studied the spread, and the confusion was between the subcutaneous and the superficial cervical block. They labeled it together as superficial. It was later on objected in another study by Dr. Telford, and they said that the actual superficial block should label the same which was given by the concept by Dr. Murphy, and what has been labeled in the study by Dr. Pandit is actually an intermediate block, that is the block that pricks the investing layer of the fascia. The technique is very much similar, but the needle goes beyond the subcutaneous tissue and pricks the investing layer. This is a very old study in 1975, but the first concept of what actually is the deep block was given by Dr. Vinny, and he was the one who said that piercing the prevertebral fascia blocks at the root level. But in this study, the direction of the needle was explicitly mentioned to be slightly corded to prevent the injury to the nerve roots, to prevent subarachnoid injection, to prevent injection to the vascular artery. This figure is specifically shown because the direction of the needle to prevent any complications of the deep block, they have mentioned it slightly caudal. And it is very clear that the concept of damage, the actual damage that this block can do, was very clear from very beginning of 1975. Another study in 2013 by Dr. Perry Sandendis, he said that there were no complications observed in his study, and it is surprising because bilateral intermediate and deep cervical plexus block was given. It is controversial, maybe the sample size were less or whatever, but it was quite satisfactory. And the surgeries were maxillofacial surgeries, where even the relaxation of the muscles as it is was required. This is the ultrasound images that were provided in this study. Now, as far as the deep cervical plexus block, whatever the literature is there, it is quite sparse. And according to Dr. Shiv in his study in 2015, he said most surgeries can be accomplished with either superficial or intermediate cervical plexus block. Why to go into those complexities, those complications of deep block? Superficial is easier. It has fewer complications. It is as effective as deep, but no doubt the relaxation of the muscle is less than the deep block. But considering those things, the risk-benefit ratio, the deep block leads to diaphragmatic paralysis. It may lead to acute respiratory distress, frank intra-arterial injection into the vertebral artery. There is maybe sudden loss of consciousness, convulsions. There may be subarachnoid injection or intrathecal injection. Basically, it is the gentle, controlled needle movements that are required. That is not possible in all cases. And also, if we look into the carotid endarterectomy, the airway access is limited. There may be urgent need to secure the airway for various reasons. The patient may become suddenly anxious. There may be loss of consciousness. The patient may throw fits. Whatever it is, the airway is away from us, and there are technical issues in securing the airway. There may be sudden hemodynamic instability, and combining the deep with superficial, the rate of conversion is up to almost 11%. It is similar. If we give superficial and intermediate block, it is just 4%. What are the benefits of GA is that the ventilation is controlled, EtCO2 monitoring is better. Also in neuro cases, propofol's neuroprotective effects well has been shown. Another study by Dr. Matthias in 2021, the depth of the cervical plexus block and the involvement of the phrenic nerve was compared using MRI study, and it was concluded that the depth of the block due to the spread between the vertebral fascia and the anatomical vicinity have a significant impact on the blockage of the phrenic nerve and consequently hemidiaphragmatic motion as measured on USG. This is the M-mode USG examined, diaphragmatic motion was examined, and it can be clearly seen that the ipsilateral diaphragmatic paralysis is definitely there. The injection at the intermediate level demonstrated a very similar anatomical vicinity to the phrenic nerve as deep. Its effects were considerably less pronounced. Maybe they just postulated, it's yet not clear, that the location of the phrenic nerve, which is typically situated ventral of the anterior scalene muscle. It is very clear from that below that green layer is the phrenic nerve. It is situated below the, situated ventral to the anterior scalene, but beneath the deep paravertebral fascia. It may account for this impediment to diffusion across the deep fascia. So summarizing the radiographic spread, the lung function, the potential for complications, block effectiveness, intermediate block does represent an ideal middle ground rather than giving a subcutaneous or the deep block. Now this study was quite controversial, and in summarizing it in a very nutshell, I would say, the cadavers were injected to 6 cadavers only, and 2 were injected subcutaneous, 2 were given intermediate, and 2 were given deep, and the problem was that the spread of subcutaneous was limited to subcutaneous. The spread beyond the prevertebral layer remained deep, but the spread of the drug that was given in the intermediate layer that spread to the deep. So how is it possible? The deep cervical fascia may be porous. It may allow the spread of local anesthetic, but why not spread the abscess or any tissue damage? It is quite controversial. In carotid endarterectomies, superficial deep block are equally effective. A superficial injection would need to block all the nerve terminals. A deep block, it is given at the root level. So it is quite surprising. So superficial block, considering all this, they carry fewer risk. The effect is similar to the deep block. Do we really need to give this deep block? The complications of the deep block already have summarized so many complications. They are twice as many. Also, it is 5 times more likely conversion into general anesthesia. In this study, they said that the block-related serious complications reflect the safety of the block. The conversion to GA reflect the efficacy of the block, and the serious systemic complication reflect the overall risk of surgical anesthesia process. There are definite advantages of regional. We cannot go for GA every time. Patient is conscious. The speech, the cerebration is easily monitored in carotid endarterectomies. But after 2,500 studies by Dr. J.J. and 30 years of publication, he said that the superficial intermediate has ever been formally described so beautifully, and the complications are so less, it is best to consider as a replacement for a deep block. Now, there was this famous Gala trial, that is GA versus local, and it was, the conclusion was that the difference between the GA and the local for carotid endarterectomy did not show, just 0.4% difference was there. Does the investing layer of deep cervical fascia actually exist? A question was raised on the very existence of this investing fascia by Dr. Nash. In his study by Dr. Ramachandran, he compared this Gala trial and the Nash study. We really need to reflect upon our thought. Is there a difference between superficial and intermediate layer? Does this layer of investing fascia, that is, the hype has been created so much, does it actually exist? These are all theories, and we really need to reflect the actual difference between the subcutaneous and the intermediate block. And finally, is the deep block justified? It is just overexcitement that we are giving this block. Superficial block is easier to teach. It is associated with fewer complications. It is as effective as deep block. Another study by Dr. Greengrass, he's made certain disclosures that in cervical plexus block, there is blockade of the anterior rami of C2 and C4, and if we need to block the anterior and the posterior, it is better paravertebral rather than cervical plexus block. And also in carotid surgeries, the blockade of the glossopharyngeal nerve is actually required, that is made by the surgeon when he injects intraoperatively into the carotid sheath. This is a case report in which the serious respiratory distress occurred to a patient, and it reflects the importance of the PAC. We should actually know the cord damage or ipsilateral cord movement, because to prevent the coincidence of ipsilateral plexus blockade induced and pre-existing asymptomatic contralateral recurrent laryngeal nerve paralysis. And finally, this true block, the most less complication, the block which is associated with lesser number of complications, actually does not exist. And finally, I would suggest a replacement like 2 actually is required. Superficial is associated with lesser number of complications. Paravertebral D block is associated with complications, phrenic nerve palsy, subarachnoid, vertebral, and whatnot. Replacement is actually required. Thank you.
Thank you very much for this running through this topic. All 3 manuscripts, all 3 presentations are now open for discussion. So are there any questions? Oh yes, please. Come up for one of the micros. Number 1 is ready for you.
My question for Dr. Harshal. Dr. Harshal, you presented evidence of thoracic paravertebral block on thoracic surgeries and breast surgeries. What's the evidence on upper abdominal surgeries? I mean, is there any, or what is your experience about that? Single shot.
I'll be very honest with you. Whatever thoracic paravertebral blocks we've used is mainly for thorax purpose. I don't know whether Dr. Anjali has used the thoracic paravertebral. Because, I mean, there are a few cases, reports and studies about the lumbar paravertebrals, but that anatomy has not been defined. I don't know if Dr. George, who's the anatomist, has anything to say about the lumbar paravertebral space, but.
Okay, concerning the lumbar paravertebral space, you know it better than as a so-called psoas compartment block, where you advance the needle just ventral to the so-called aponeurosis lumbalis, lumbar aponeurosis, which is in between the costal processes. And if you advance the needle, you're just in a small space in between the superficial and deep portion of the psoas major. And this is the so-called paravertebral space in the lumbar area. Well, it's not the same, of course, as in the thoracic area, because in the thoracic area the psoas is missing, so there are no muscular structures over there. So it's not comparable at all. But anyway, it's like a space. But if you clearly inject into the thoracic part, you get a total different spread as in the lumbar part.
Yeah, so thoracic paravertebral causes, I mean, reaching up for any surgeries from the upper abdominal, I'm not really sure. I've probably used it only from thorax point of view. I don't know if anybody else has any other experience of using thoracic paravertebral blocks for upper abdominal surgeries. I have not used it for upper abdominal procedures.
Yes, please. Another question?
Advantage of a paravertebral is it's a unilateral. If you can use it bilaterally as well, but for abdominal surgery you'll have to do a bilateral paravertebral block.
Same like we do bilateral ESP block.
Yes, but then you could do an epidural.
That is the whole idea.
So what would you gain if you did that? That's my question.
On one forum we discuss about benefits of like facial pain blocks and thoracic epidural getting obsolete, and some other forum we discuss it otherwise. So just for the sake of discussion, nothing else.
No, I mean, yes, the epidurals are probably not as popular now as when you have the ultrasound guided, paravertebral blocks as well. But now even with the ultrasound, you can do a thoracic epidural as well. So, I mean, you can argue on that point as well.
So I want to just give two comments to the other two presentations concerning the 3-in-1 first. Well, you see, it might depend on the volume which is injected first. And unfortunately, I think none of these investigations ever really took a look on the needle tip position, where it is injected. So this is maybe just a small lack concerning the important information, how the spread might be predictable or not. Anyway, concerning my anatomical experience under the sections, this medial spread is absolutely in no way. And I would now just ask what you would prefer. Would you prefer the so-called 3-in-1 by a supra-inguinal block, for example, or would you prefer just to go distal to the inguinal ligament and shot all three of them separately? What is your opinion?
Definitely 3 injections, identifying all the 3 nerves. Nothing like it.
Because it's pretty faster, isn't it?
Faster, go down on volume, sure short results. If you have ultrasound, you don't need a single short block.
There's also one thing what I want to mention concerning the techniques distal. The ultrasound is really a wonderful tool if you are really skilled with the maneuvering of the needle. Yeah, so you're pretty fast, especially when you're experienced. Concerning the classical techniques with the landmarks, you always have to be aware which landmarks are given and about the definition of the landmarks. I want to give you an example. If somebody's using the anterior suprailiac spine as a landmark, you always have to think about which part of it. Is it the most medial part, the tip, or the lateral part? Because this is 2 centimeters, which is the width of an ASIS. And same with the artery. Which part of the artery do you palpate in obese patients? So watch out with these landmarks. So that's why in obese, ultrasound is really not bad. Okay.
Just adding on to what we were discussing about 3 different pricks. As compared to for anesthetic requirement, 3 different pricks will be good. But for an extended post-operative, probably we will have to again go back and search single thing which would be giving a prolonged in the post-operative period also.
Yeah, that would be catheter technique, suprainguinal, not bad. I agree with that. Or infrainguinal, yes, absolutely. But the problem exists with the obturator. Yeah?
I think we were just discussing that there's a study by Dr. Bernstein who's dissected that area, and they've said that the obturator nerve lies in a totally different facial plane as compared to the femoral nerve and the lateral femoral cutaneous nerve. So even if you put 50, 60, 70 ml, unless you breach that facial layer, you're not going to catch the obturator nerve. So probably easier just to do it separately.
Do you mean distally to the inguinal ligament or proximally?
Above the inguinal ligament.
Okay, yeah, absolutely. One other thing concerning the deep cervical plexus, just one short comment. We investigated that too, and also dissected and have a book contribution in Manoj Karmakar's book. And what we really recognized is a high irritation and confusion concerning the fascial terminology and the use of it, which causes then the interpretation and also the use of these different techniques. Anyway, concerning the deep plexus block, it's really, I think, quite a danger concerning the spread and the volume used. So thank you for your presentation about that and saying, okay, be more superficial. What is the opinion of the audience? Or is it still a postprandial phase you're facing? No?
Can I extend the discussion a bit more on the thoracic paravertebrals?
Oh, yes, of course. Come on.
So I want to have an opinion from the audience. How many of you are giving thoracic paravertebrals ultrasound guided? Oh, good one. And how many of you are giving those in sitting position with ultrasound? That's quite a bit, because I tried it. I find sitting position ultrasound guided little too challenging. Needs a lot of patient support. Lateral is better, but then when I've tried lateral thoracic paravertebral, invariably I've realized that I've blocked the opposite side as well. And this side, the effect, because the volume has gone down onto the opposite side, this side the effect is little poor. So that's my concern.
Another point of view concerning the thoracic paravertebral, with the use of ultrasound, what we are facing all the time, also in the workshops, is that sometimes the important anatomical landmark, which is the superior costotransversal ligament, is not really well defined or located. So if you are unaware or you really do not precisely know the course of it, please go into the anatomy lab and dissect it with your anatomist just to get an overview over this area. Review this area for your own, and then you will be much safer in positioning the probe, and then you get your landmarks. Because if you have your landmarks, you can advance the needle precisely and with the responsibility you need over there. Be very respectful with this area, especially if you you just pierce the ligament and get into the space. Okay? This is my message, because not only Bernard Moragli and myself to support this, but also our clinicians in Europe. And for example, Rainer Litz is one of the most experienced concerning epidural and also thoracic paravertebral blockades, blocks. Sorry.
Just to add with that, the sitting position, I think Dr. Anjali also does it in the lateral position, isn't it? So just few points about the sitting position is, I think, especially when you start off, it is a bit fiddly while doing it. Your hands start getting fatigued. So the accuracy of holding the probe, and because it's fine needling, you need to get a good picture. The needle should be well visible because it's a deep block. So sitting position, your hand starts to get a bit fatigued. That's what I found. The second thing is, if there is any vasovagal in sitting position, then you have to do the whole thing extra. Whereas if you're in a lateral position, whichever position, so if I'm doing it, you probably make the patient lateral side to be blocked up. He's facing me. You can rest the arms on the patient's chest and do it in plane or whatever technique that you use with the thing in front. Two advantages of that: if there is vasovagal, patient is already lateral. Second thing, you can sedate, oxygen. You can do, for some surgeries, you can do it after a general anesthetic as well. So all these advantages are lost in doing in sitting position. Dr. Hitesh.
Basically, I have a question for Harshal. Is there any difference if you inject in the apex or in the true paravertebral space? Because usually you will see the definition of the superior costotransversal ligament is much better when at the apex. And seeing the needle tip is much better if you are depositing your drug in the apex of the paravertebral space. When you reach the true, if you get a sonoanatomy view, when you are seeing the true paravertebral space, usually the needle visibility sometimes becomes difficult, and the definition of the superior costotransversal ligaments is slightly compromised. So is there any difference if you inject there or at the apex?
I would think if you don't inject it in the right place, it becomes an intercostal nerve block. So unless you have breached the superior costotransverse ligament, it's not going to be a paravertebral block. I've got a couple of videos where you put local anesthetic and you can visualize the spread from inside the thorax, how these spreads.
After breaching the superior costotransverse ligament at the apex, because the true paravertebral space is slightly more deeper.
That's correct, yeah. If you pierce it, you're in the paravertebral space. The problem is if you go too laterally a little bit,
it's not
the problem is where is the intercostal space starting? But it's the same space. You know?
So when we saw the spread of local anesthetic from the opposite side, as in we're putting a camera inside the chest and someone doing the paravertebral block from outside, we could see that the local anesthetic actually tracks up from the path of least resistance. So it goes more, in the intercostal space as compared to that way. So there is spread on both the sides.
Yep. Okay. So you see, it's quite a cool and already
wonderful discussion. Anyway, time is over now for the first session. So we will continue with the next one. I just go for 1 minute and leave, and we'll get to my next chair. So I'm your co-chair.
So we're going to start the next session, or do you need a minute, Dr. George?
Yeah, we can start. He's starting.
So
He's the moderator.
I think he's already there. Dr. Ramoti Kulkarni is one of the moderators. Dr. George Figel is going to moderate with him. And this session is called Sparing, Sparing, Sparing. So basically, what would one do if there is any sparing of the area after that particular block is done? Yes.
Thank you, Dr. Harshal. So I invite Dr. Himjyoti for the first talk is by Dr. Himjyoti. The topic is sparing in the back of the arm and thigh. Over to you, Dr. Himjyoti.
Good afternoon, Chairperson, sir, ladies and gentlemen. And early afternoon, Dr. George already made my presentation a little easier because he already talked about the LFCN. So I'll try to find a little more about LFCN in the preceding slides. I start with the back of the arm first. How many of you give a block for the distal humerus leading a posterior incision? The moment surgeon put an incision and patient cries in pain, how many of you have felt it in your practice? No one? Yeah, a few of you. So why this happened actually? This person, this young boy, was operated last week. He had an incision over the elbow going up to the mid-arm and below to the mid-forearm. And this photograph, I took it because he had the, so he had the pain, then I had to supplement this. Coming to the anatomy, the cutaneous distribution of upper limb is very confusing. You probably have heard about antebrachial cutaneous, brachial cutaneous, lateral brachial cutaneous, medial brachial cutaneous, all these. So I try to make it little more easier for you at the beginning of the presentation. Any nerve that supplies from the shoulder to the elbow, we call it brachial cutaneous. Anything below from the elbow to the wrist, we call it antebrachial cutaneous nerve. So subsequently, whenever talk about or name them, don't get confused further. So if you look at this photograph here, the upper arm is actually supplied by varied kind of nerves. It's not only the nerve coming out from the brachial plexus. You have supply from the supraclavicular, which is a branch of superficial cervical plexus. So if your incision goes high up to the nape of the shoulder, so you probably need to think about blocking the supraclavicular nerve well. Otherwise, this area, which we call classically the regimental badge, that is supplied by the axillary nerve. Axillary nerve sometimes might get spared when you give a intraclavicular block. Then coming down, the entire back of the arm up to the forearm is supplied by the branches of radial nerve. And of course, this was discussed yesterday. This area, the medial posterior part, is supplied by intercostobrachial nerve. Need not to forget about that. So if you look at this diagram, it's a very busy diagram. If you can see, that's the area where the supraclavicular nerve come out. Then you have got the posterior brachial cutaneous nerve. Then you have got the superior posterior brachial cutaneous, which is a branch of axillary. Then you have got inferior posterior brachial cutaneous nerve, which is again a branch of radial. Then you have got posterior antebrachial cutaneous nerve. All these are coming out from the posterior cord. That's the radial nerve. So keep it in mind, this is coming from the axillary. This is coming from radial, this is coming from radial, this is coming from radial. So most of the contribution of the back of arm cutaneous is from radial, apart from supraclavicular and probably axillary. So why this arm get blocked? Why this arm gets spared? Probably the posterior cord gets spared when you give an infraclavicular block. Most probable cause of sparing of radial nerve and subsequently posterior cutaneous supply of the arm is because of the sparing of posterior cord. Then probably not considering the intercostobrachial and supraclavicular supply, as I have already told you, and blocking the plexus too distally probably. So what to do now? If you have a sparing, what we can do? We can probably do a cutaneous, individual cutaneous block. We can repeat the posterior cord or radial injection if you feel that radial distribution is completely got spared. Or don't forget about supraclavicular and the intracostobrachial contribution to that area. So coming to blocking the posterior cutaneous nerve of arm, that's the most biggest culprit. Most of the time this gets paired because these posterior cutaneous nerve come out of the radial nerve in the axillary region and that run little away from the radial nerve and pierces in that medioposterior part and give rise to these and give this supply here. So to block this, the patient lies prone. This posterior cutaneous incision of that posterior part is mostly done in that prone position. So you can continue to keep the patient prone. Where the deltoid groove is finishing here, you take a subcutaneous injection from this anterolateral side to the posterolateral side and deposit around 10 ml of drug. That should be enough for blocking the posterior cutaneous nerve of arm. Coming to inferior lateral brachial cutaneous nerve. That's again a very big name, but again it's a branch of radial nerve, that come out in this area in the upper arm. So the same injection can be extended to this area to block this nerve, or you can take another injection few centimeter below to little more anterior posterior segment where you can block the inferior lateral brachial cutaneous nerve which come out from the radial again. Coming to the superior lateral brachial cutaneous nerve, this is a branch of axillary, keep it in mind. It's not from radial, rather it's from axillary. This nerve can be blocked with the same injection we have given for posterior brachial cutaneous nerve. Or if you feel you can block the axillary nerve at this area separately, you can put the probe here, you can block it by an ultrasound also. You can put the probe as I have shown you in the sitting or in a prone position, try to identify teres minor, that's the humerus, and you can see the circumflex and axillary nerve coming out from this, and it can be blocked from superior to middle needle direction. The needle will come like this and can deposit some drug here, can block the axillary nerve here. Posterior antebrachial cutaneous nerve, by name it tells that this supplies mostly the forearm, back of the forearm, but it has got some contribution to the lower part of the upper arm also. So here you can use ultrasonography help to find out that nerve and can block in the mid-humeral region. Here you can see, this probe is placed in the mid-arm, in the anterior part of the arm. You can see the humerus, that's the bicep. You can see the radial nerve coming from the posterior side to the anterior side to become small radial nerve in that lateral epicondyle here in the humerus. Then you can see the posterior antebrachial cutaneous nerve escaping from radial nerve in this fat tunnel. This is known as the fat tunnel of arm. So I'll continue to show you the video how it can be blocked. The needle come from medial to lateral, and you just need to deposit around 5 ml of drug around that, and it blocks that posterior antebrachial cutaneous nerve. Coming to intracostobrachial nerve, as you have already told you, this supplies the medio-posterior part of the arm, so it should not be forgotten. So if you have a pain in that particular area, it makes sense to probably block this nerve with a subcutaneous infiltration along that line. Or you can take the help of ultrasound, put an ultrasound probe, and you can find out that area where the medial cutaneous nerve of arm along with the intracostobrachial nerve lies, and you can deposit around 2 to 3 ml of drug there. That completes the arm. Then coming to the cutaneous supply of the back of the thigh, Dr. George already told in that afternoon about the posterior cutaneous nerve of thigh in detail. So this is coming out of the sacral plexus with S1, 2, and 3 root, and as this photograph has shown, that's the predominant area of supply, cutaneous supply of the posterior cutaneous nerve of arm, thigh. It's also known as posterior femoral cutaneous nerve. If you see in this diagram, you can see the bicep femoris muscle actually divides these two nerves separate. The sciatic nerve runs below, and the posterior cutaneous nerve of thigh runs above that between the fascia lata and bicep femoris, the long head of bicep femoris. So this was discussed in that afternoon. Dr. George already has published it in BJ, saying that the posterior femoral cutaneous nerve supply probably go down up to the foot and the ankle. And so probably we need to think about the pain in the back of leg, about the supply of the posterior femoral cutaneous nerve. The continuation of this publication, another publication came out in the BJ in November 2022, and they said that it is too early probably to say that posterior cutaneous nerve of thigh need to really be blocked for any surgery in the leg and the foot. I think Dr. George can put some light on it in that end of this talk. I look forward for that. And looking at that branches of the posterior cutaneous nerve of thigh, we have got infracranial nerve that come out. Then we have got multiple perforating cutaneous nerve that give branches throughout the back of the thigh. And of course, you have got a perineal branch that supplies the scrotum and the perineum and the labia majora in the female. This publication in the Journal of Ultrasound Medicine in 2017, they said that deep investing muscle fascia of the thigh appears to impede the spread of drug between the sciatic and PFCN. Thereby, an ultrasound-guided subgluteal PFCN blockade may be feasible technique to complement the sciatic nerve. If you plan to block the sciatic nerve below the subgluteal region, that it definitely makes sense to block this nerve separately, because these two nerves travels quite separately from the subgluteal region. Any block probably above that shouldn't be a big concern about not blocking the posterior femoral cutaneous nerve. But below the subgluteal fall, if you are planning to block the sciatic nerve, it's better to complement these blocks separately. What are the indications? We all know tourniquet pain, supplementation of sciatic nerve, and of course the posterior thigh skin graft, particularly in burn patient and all. These two images I took it from Naisora. These are subgluteal fall. You can take an injection of around 10 ml in that line. Hopefully, it will block the posterior cutaneous femoral nerve. We are not sure about that. If you're planning to block it in the mid-thigh region, you take around 5 centimeter from popliteal crease and block the nerve with around 5 ml and subcutaneous fashion. Otherwise, you can probably put the probe in the subgluteal fall, then you can get the posterior femoral cutaneous nerve sitting here. That's the sciatic nerve. You can see they're far away, actually. Yeah. That's towards the IT. Look at that. That's remain medial to the sciatic nerve. To conclude my presentation, cutaneous supply of posterior part of arm and thigh are really complex, and the nomenclature is very confusing, as I have already told you. Sparing with additional block is not uncommon, particularly if we if we plan to do a surgery with infraclavicular block, the posterior cord gets spared and the radial nerve gets spared. Subsequently, you get a sparing of the posterior cutaneous supply of the arm. Individual cutaneous block is warranted in cases of sparing. Thank you very much for your patience hearing.
Thank you, Dr. Himjyoti, for the talk. We'll take the questions at the end of the session.
Can I take permission from the chair to go to the next hall, because I have an engagement in the hall A?
Yes. You have a talk in the next hall?
Yes.
Yeah. We'll take the session.
Thank you very much.
Questions later. Yes. Thank you, Dr. Himjyoti. The next session, the next talk is by Dr. Medha Kulkarni. Her topic is, ouch, my hand still hurts after a brachial plexus block.
Good afternoon, respected chairpersons and all my dear colleagues. Ouch, my hand still hurts after a brachial plexus block. Well, this is a fairly common phenomena, not only encountered by novices, but also by sometimes experienced regional anesthesiologists. So the story goes like this. There's a 45-year-old female, hypertensive, diabetic, obese, with a BMI of 29, and she comes for a plating of the distal end of radius and ulna. With a neurostimulation, supraclavicular brachial plexus block is performed with 30 ml of local 0.5% bupivacaine. The analgesic effect is confirmed actually with a pinprick near the fracture site and surgery initiated. And ouch, she screams in pain at the time of fracture reduction. So the surgeon looks at you, he drops down his knife, and now what to do next? So the anesthesiologist starts thinking, what could be the reason for this? So For this, we need to go into the innervation of the skin, the muscles, and the bones. So as you can see in this, the dermatomes, the myotomes, and the osteotomes, and their innervation is predominantly in the forearm is predominantly by the median, the radial, and partly by the ulnar nerves. So in the forearm, the cutaneous supply is mainly by the, on the medial aspect is by from C8 and T1, the lateral antebrachial by C5, C6, and the superficial radial nerve and the dorsal ulnar nerve. The muscles, mainly the extensors, are supplied by the radial nerve and flexors by the median nerve. When it comes to the bone, the ventral aspect, the radius is ventral part is supplied by the median nerve and the dorsal by the radial nerve. Now, we check the block adequacy for the skin by pinprick and bones by manipulation of joint or by giving traction. But is pinprick equivalent to the skin incision? It is a traditionally followed method for block assessment, and loss of touch sensation, as documented by Rocco, Angelo et al., they said that loss of sensation can be taken as adequate sensory anesthesia. At the same time, change in skin temperature can also be taken as a adequacy of the block, and it has a 92% sensitivity and nearly 95% specificity when it comes to the efficacy. So with the sensory failure of the sensory block, the management, you can just go for infiltration of the surgical incision site and just supplement it with some sedation intravenously. Now, similarly, is the joint movement equivalent to a surgical manipulation? Yes. So, Ko et al., they concluded that muscle power assessment is an adequate indicator of a motor block. So what about the inadequate blockade of at the time of bone manipulation? So this management for this can again, if it's a minor inadequacy, you can go for intravenous sedation or intravenous analgesics, and the next option would be conversion to GA. However, a block supplementation, if a proximal block has been given, like a supraclavicular, you can go for a intraclavicular or axillary block. This can be done under the drapes if the surgery has already been initiated. You can go under the drapes and go in for an infraclavicular block, which could relatively be a feasible option, or a selective nerve. If you can identify which nerve has been spared, you can go for a selective nerve block with the axillary fossa approach. Now, in the first place, how can you try to avoid this situation? So you need to know your surgery and the surgeon. So as for the surgery, you need to know where the incision line is with the, for the particular surgery. For distal end radius, it's along the line of the flexor carpi radialis with a big incision of nearly 7 to 8 centimeters. And the muscles, the flexor carpi, flexor digitorum superficialis profundus, they're retracted on the ulnar side. And they do a release of the pronator quadratus muscle. So you need to know a few steps of your surgery, and at the same time, you need to know your surgeon, because various surgeons will go for different approaches for the surgery, and hence a good communication with your surgeon is very essential in order to tackle this kind of situations. At the same time, you need to know your block and its limitations. Like for a supraclavicular block, there can be ulnar nerve sparing, as you cannot reach up to the inferior trunk. With the infraclavicular, again, there could be sparing of the radial nerve, as you may not be able to stimulate the posterior cord, and particularly with neurostimulation. And at the same time, you also need to know whether all these blocks do, like the infraclavicular, the supraclavicular, the axillary, do they have the similar clinical outcomes for that particular surgery of distal end of radius fracture? So this was a comparison of infraclavicular and supraclavicular approaches to the brachial plexus. This was using neurostimulation by Yang and his colleagues. And they concluded that the block efficacy with supraclavicular block was equivalent to the infraclavicular block, whereas complications like Horner's syndrome and hoarseness of voice, they were more commonly found with the supraclavicular block rather than the infraclavicular, making the infraclavicular block a safer block to perform. In this randomized comparison with ultrasound, this supraclavicular, infraclavicular, and axillary brachial plexus blocks were compared, and they found that the total anesthesia-related time, the pain scores, the success rate, and the vascular puncture incidence was similar in all these three. And at the same time, the number of needle passes required for axillary block were more, the needling time was more, and performance time of the block was more with the axillary block as compared to the supraclavicular or infraclavicular block. So that brings us to the use of ultrasound, whether with ultrasound there will be decrease in the incidence of sparing. So in this article by Fredrickson, he studied the speed of onset of corner pocket supraclavicular injection of local anesthetic, and he compared it with the infraclavicular brachial plexus block. So with supraclavicular block, the ulnar nerve was still spared in spite of corner pocket injection. The onset of blockade was same as infraclavicular block. And here they had not used neurostimulation. So probably they felt that because they failed to confirm with neurostimulation, they found those, the above results. And in spite of a corner pocket injection of a local anesthetic with supraclavicular block, the complete sensory anesthesia was found in only 57% of the patients. So, leaving all this apart, we can also, if we find that the block is inadequate before the surgical intervention has started, you can go for forearm blocks. If you can individualize the which nerve has been spared, you can go for the individual nerve blockade within the forearm. So, for the median nerve, the mid forearm would be a good place to block. You can find the median nerve here, sandwiched between the flexor digitorum superficialis and profundus. And it can be blocked here with an in-plane technique with ultrasound or even with a neurostimulation. The radial nerve block can be carried out at the elbow. Here, it has already, or below, even below the elbow, where it has branched into the superficial and the deep branches. And injection into this plane would block both these branches, again with ultrasound. The ulnar nerve, can be blocked at the mid forearm level again. Here, as you can see here, there's some distance between the ulnar nerve and the ulnar artery, and this would be a good place to block the ulnar nerve, because as you go distally, the artery and the nerve lies in a very close proximity, and the incidence of vascular puncture will be more as you go distally. Hence, it is better to block this nerve little bit proximally. Now, what about the dorsal surgery? Can we prevent this? Well, that's a different story, and I'll leave it for discussion at some other occasion. Thank you.
So thank you very much. Third presentation now, Dr. Ritesh. What's the title?
This is long press, and this is slide changes. This is front. This is go ahead. This is to go back. Yeah, and this is slide change. Right.
Okay. By the way, thank you for this wonderful block today.
Oh, thank you,
I've
sir.
won.
My pleasure.
It's absolutely great.
Thank you, sir. Thank you very much. So Basically, I will be speaking on how on incision after lumbar and sacral plexus block for IT fracture. I will take you to a journey of a hip surgery. So, greetings from my hospital. These are my disclosures. Now, a 75-year-old male with an intracapsular IT fracture, known case of CAD with an ejection fraction of 20%, known case of COPD, asthmatic on regular inhalers, was planned for a total hip replacement. Now, the anesthesia options which I have, GA, spinal or epidural, and peripheral nerve block. Now my surgeon comes that I have to fix it. And seeing the patient factor, the GA is out, the spinal is out, and I am very new to a peripheral nerve block, and I have heard that the peripheral nerve block is very safe in this patient. So, and recent hip fracture guideline, I have to fix it. So I thought, why not go for a peripheral nerve block? But before that, obviously, I have to review the dermatomes, myotomes, and the osteotomes. So the dermatomes is by the lateral femoral cutaneous, by the subcostal nerve, by the iliohypogastric nerve, and the superior cluneal nerve. So, and the myotomes is all from the sacral plexus. Now coming to the osteotomes, the head, neck, and proximal shaft of femur and acetabulum is supplied by both the lumbar plexus and the sacral plexus, and the hip joint and capsule is all supplied by the combination of lumbar and sacral plexus. So, based on this, based on the surgical approach, the dermatomes, myotomes, and osteotomes, everything came that lumbar and sacral plexus will be enough to get a surgery done. But can I do a surgery under lumbar and sacral plexus block? I am doing the surgery for the first time in lumbar and sacral plexus. So I reviewed the literature, whether people have done it or not. And when I went to the internet, I saw loads of paper where they have done hip surgery under combined lumbar and sacral plexus block. And I became confident, and I gave a lumbar plexus block. I did a dual guidance lumbar plexus block. I did a dual guidance sacral plexus block by a parasacral parallel shift technique. I used a curvilinear probe, slide it down. I saw the posterior border of ischium. I saw the sacrum. I saw the gluteus maximus muscle, the piriformis, and below that, I saw the sacral plexus. Okay? So I inserted the needle from lateral to medial, and I tried to appreciate the sacral plexus, sciatic nerve response. And when the response came, I injected around 25 ml of drug. So my lumbar plexus was complete, my sacral plexus was complete, and I was pretty confident, yes, now I am ready to get this high-risk surgery done under the block. So, and I assessed the block. Obviously, when you are giving the block, you have to assess it. I checked for the sciatic by push. I checked the obturator by pull. I checked the LFCN by pinch. And I checked the femoral by punt. So all the nerves which were relevant were blocked. And I was ready for action for a hip surgery. My surgeon, I told the surgeon, yes, go ahead. As the surgeon put the incision, my patient screams, ow! And my surgeon sees me. What is this? And I was confused. What happened? What went wrong? So I started reviewing what happened. Now let's review the incision types. So you have got an anterior incision, you have got an anterolateral and lateral incisions, you have got a posterolateral incision. These are the 4 incisions which are mainly used for the hip surgery. And obviously the dermatomal, what I have read is the LFCN, and my LFCN was blocked. Does LFCN provide the complete dermatomal coverage of the incision? Let's review the literature. This is the article which came in 2014. The aim was to assess the potential use of blocking the lateral femoral cutaneous nerve for patient undergoing hip surgery. And they used 20 healthy volunteers, and after giving the block, these are the 3 types of incision which has been done: the anterior, the lateral, and the posterolateral incisions. And this is the coverage, this is the coverage of the LFCN territory. And what they found, that in almost half of the patients, the LFCN block doesn't cover any of the hip surgery incision. Now, this is a paper which came in 2018. It was done in 10 cadavers and 20 healthy volunteers. In cadaver, they did an ultrasound-guided new technique by injecting the drug in a fat-filled tunnel, and the success rate was 95%. And then they tried to assess the dermatomal coverage of different surgical incisions used for hip surgery by LFCN. These are the different incisions which are done. You can see the lateral incision, you can see the lateral incision, anterior incision, the lateral incision, the anterolateral and posterior incision. See the paresthesia after LFCN block. It hardly covers the hip surgery incision. And if you see the different incisions of the surgery, maximum are not covered by LFCN. So this was another, the sensory distribution of lateral femoral cutaneous nerve, a randomized controlled trial. The aim to investigate the sensory coverage of posterior and lateral incision line for hip surgery. It was done in healthy volunteers. They received bilateral LFCN block with 8 ml ropivacaine on right side and 8 ml on isotonic on left side. An orthopedic surgeon depicted the incision line, which was invisible to the investigator prior to the block performance. And the distribution of blocked area and coverage of incision line were assessed with temperature discrimination and pinprick test. What was the conclusion? An LFCN block consisting of 8 ml ropivacaine has limited coverage of posterior and lateral incisions. Now, evaluation of anesthetic blockade of the lateral femoral cutaneous nerve. It came in 1991. It was in 18 patients. This was done by a landmark technique, and what the success of blockade was high, but the area of sensory loss was inconsistent and was more anterior and distal than described in the textbook of anatomy. So, which nerves provide the dermatomal coverage of hip surgery incision? After reviewing all the literature, these are the 4 nerves: the lateral cutaneous branch of subcostal nerve, the lateral cutaneous branch of iliohypogastric nerve, the superior cluneal nerve, which are dorsal rami of T12 to L5, and LFCN. So, now coming to the cutaneous, so does iliohypogastric and subcostal nerve and superior cluneal nerve will help you in hip surgery incision? This was a randomized controlled trial which came in 2019. The background was anesthesia after LFCN is too distal for complete coverage of most hip surgery incision. The TFP block potentially anesthetized the iliohypogastric and subcostal nerve. So it was to investigate if TFP block can provide additional advantage for the cutaneous anesthesia after LFCN nerve block. And they did a TFP block, and prior to that, they did one day prior, they did a subcostal nerve block. And what was the result? The anesthesia after TFP block was 80%. TFP plus LFCN block increased the coverage of hip surgery incision compared to LFCN alone. But the success rate of blocking the subcostal nerve by TFP was only 50%. So the conclusion was the TFP block anesthetizes the skin proximal to LFCN nerve block by anesthetizing the iliohypogastric and subcostal nerve, so it can add to the coverage of proximal surgical incision used for hip surgery. You can see this is the area which was by LFCN, this was by TFP, and this was by the subcostal. These are the different incisions. If you combine it, maximum are covered, but still the posterior and the posterolateral incision, these are still left. So what are the nerves which will help you out? The answer is superior cluneal nerve. This was by the same authors in 2019 to describe a novel ultrasound-guided superior cluneal nerve block technique and to map the area of cutaneous anesthesia and its coverage for hip surgery incision. They did a superior cluneal nerve block in one group, and in another group they didn't do, but they had bilateral TFP and LFCN block done. And what they found, the novel ultrasound-guided nerve block reliably anesthetized the superior cluneal nerve. It anesthetizes the skin posterior to the area innervated by the iliohypogastric and subcostal nerve. It improves the anesthesia coverage of incision used for hip surgery. So this new nerve block technique may improve post-operative analgesia after hip surgery, and it can be used as a diagnostic block for chronic hip surgery. So if you see the different type of incision, you see this area is covered by LFCN, this area by transversus fascia plane block, that is iliohypogastric and subcostal, and remainder which is left by the superior cluneal nerve. So if you want to prevent the for complete dermatomal coverage for hip surgery incision and to prevent ow on incision, the nerves to be blocked are the lateral femoral cutaneous by lumbar plexus, the lateral cutaneous branch of subcostal nerve and lateral cutaneous branch of iliohypogastric, and rest by the superior cluneal nerves. So what are the RA addendum to lumbar and sacral plexus block as a sole anesthetic for hip surgery? First, RA options to block the lateral cutaneous branch of subcostal nerve and the lateral cutaneous branch of iliohypogastric nerve. You can use a TFP block or a subcostal nerve block. Secondly, you can use a T12 paravertebral block. This was the article which came, the surgical anesthesia with combination of T12 paravertebral block and lumbar plexus sacral plexus block for a hip replacement in a patient with ankylosing spondylitis. So you can use this combination, or you can use a lateral or an anterior QL block to block the iliohypogastric and subcostal nerve. Plus, you have to add the superior cluneal nerve block by using the ultrasound-guided superior cluneal nerve block technique. Or, if you want to avoid all these, if you don't want to have so much block, or if you don't know how to block these nerves, but you know how to block the lumbar and sacral plexus, you can just tell your surgeon, please infiltrate on the incision line. And in this patient, which I was given on incision when the patient shouted, the first thing which I will do, I will tell the surgeon, please infiltrate the incision line. Even in spite of that, the patient still complains of pain, just put a eye-gel and continue with your surgery. Okay? So thank you. And I take this opportunity to invite you all for Punch 2023 on 12th and 13th August at Bhubaneswar. It's a 2-day. First day you have got a USGRA hands-on workshop plus masterclass, and second day it's hands-on focus plus masterclass. And we have got all the leading faculties from all over India. Namaskar. Thank you.
Thank you very much. All three presentations are now open for discussion. Are there questions, remarks? Okay, I just want to start with one important thing. What we heard now is concerning skin innervations and so on really troubles, as you really presented absolutely marvelously. I just want to give you something to remember. As I already told today in the morning, I think we have to think back a little bit more to our embryology. The dermatoma are allocated to our spinal cord segments, which means when you have nerves getting fibers from the different segments, they might also reach the dermatoma. So this is the first important thing, that other nerves, as you saw it in the innervation of the hip area, can take, let's say, the skin innervation or cover it instead of the one who should be allocated to. And we all, myself included, always took the dermatoma allocated to nerves. We have to get back to the dermatoma allocated to the segments. So please take these ones and then into account which nerves might contribute. And those nerves you have to block. And that was your problem. It was also the problem, for example, with the thumb. This is always the problem with the area of Henry's incision concerning the radius fractures. So these are all the problems we are facing now, because myself also just took a look on the wrong images, yeah? And we didn't get back to the embryology. So if we go back, I think we get better results then, okay? Any other questions, remarks?
Dr. Harshal. Sorry, yeah. I think Dr. Ritesh and maybe Dr. Josh also can answer that. So we've got a case series of about 20 cases hoping to get published, similar, where we have done high-risk patients under lumbosacral plexus block for hip surgeries. And even if they complain, what we have realized is if there is some sort of sparing of nerves while incision or while doing that, it's not that clinically significant in terms of converting them to a general anesthetic. Is that something that you have experienced as well? Or what I mean is, if there is sparing, you usually get away by putting a little bit of local anesthetic or some small amount of fentanyl. Very rarely we have, none of our patients have required to convert them into a full-blown general anesthetic, because maybe one of few nerves have been missed. We can easily get away by just pure local infiltration or some fentanyl or something.
So you mean to say that cutaneous sparing is easy to handle than the myotomal and
yeah, basically, as I showed in my talk, obviously, the dermatomal, you can just tell your surgeon to infiltrate the incision line, okay? And you can, because obviously, while preparing the presentation, I will tell you very frankly, there were many things which were eye-opener to me also, okay? Because we only relied LFCA and lumbar plexus, sacral plexus. So while preparing the presentation, right now, in my hip surgery, after making this presentation, I have started adding few blocks, and compared to earlier, my patients are more pain-free after adding these few blocks. Obviously, superior cluneal I don't add. I have started putting TFP block in almost all patients for post-op, and they are quite better. So obviously, when you are doing an isolated hip surgery only a lumbar and sacral plexus block, you can just tell your surgeon, just before incision, just infiltrate. I think that is enough to take care of the dermatomal part.
Maybe you just have to take into consideration, you're an expert, you're doing it, you perform it, you review it. If somebody is starting with it, it's the setting which is always a little problem. So if he's getting trained, he's pretty faster, also in the setting of the needle, in performing the blocks. I think that's the experience you have to take into account. And then when you experience it's just an easy going process, even also the finding of the cluneal. You should try it first, because otherwise you search a long time.
Basically, I have done 2, 3, I just deposit in that plane.
Absolutely, I agree.
Seeing that small nerves is difficult, so I just deposit in that plane. I have started using this technique itself. We just deposit in that plane, and it takes care of that.
One thing, what we did, what Rainer Litz, for example, does, he comes to my department and then we just make injections and dissections later on. So we really try to identify it, and then we say, okay, that was it. So he really recognizes and then goes back to the patient, and it's easier.
Yeah, I think we will be waiting for your pictures of superior cluneal nerve. It will be helpful for us. Thank you.
One other question was concerning the posterior femoral cutaneous, about my opinion for this second publication, which was a little bit critical concerning our findings. I know this publication, unfortunately the second one who supported our results was not presented. Anyway, it was a Korean manuscript. Anyway, I just wanted to give you our experience concerning my clinicians who perform it all the time. It's a routine additional block wherever you are performing the sciatic nerve block, and they are quite happy with the surgeons. Themselves, they're happy, and the patients are happy too. So we do not see any critical problems with that. And I think to add it, it's not the failure. It's much more painful if the patient says, ouch. That's it. It's the coverage. I know that one case out of 100 dissected specimens going to the plantar is 1%. Not very much indeed. And if you take then your patients, 1 out of 100 will have it. So that's a little bit like the jackpot. Okay? So regularly you could cover everything, but sometimes you will not. And this is the only thing what we
Okay, the thing is we do a lot of diabetic foot amputations and everything under plain popliteal sciatic and saphenous. We'll keep collecting that data. Yeah. How many patients?
It's just that plantar or what you are doing on the foot. It's just one case out of many. Yeah. So this is just the worst case scenario. The Achilles tendon area should be covered. Okay. This is this was our main objective. That we found one going to the plantar. For us, it was not only a surprise; it was a shock, because we didn't dare to think about it even.
Okay, thank you.
Okay, other comments? No? Okay, yeah. Yes, please.
This is just open to the house. Many a times, you know your block is done well, any area. But on incision, the patient says he can feel something. Now, one aspect can be that you have not waited long enough for the block to act. But there are some times when after the incision is done, then the patient doesn't complain of much and the surgery goes on very well. Is there a reason to believe that obviously the patient goes from no intervention to a surgical incision and the perception of pain is different? Is that something?
Might be absolutely a very wonderful point, yes. I think
how do you realize after the incision is done, oh, it's not that bad, and then they settle down. So it's not whether really it is painful or they go from doing nothing to some intervention being done.
Interpretation of feelings, yes, might be very different. Yes, absolutely.
I just want to make a comment. Yep. Very impressive talk, and I know your talk was on lumbosacral plexus and all the cutaneous supply. But practically speaking, suppose you have an amputation of the leg and you have a 20% EF. Can't we do the case with 0.8 cc of unilateral spinal with noradrenaline ready? Practically, Madam, how many of you would do the case with a lumbosacral plexus and so many nerve blocks versus a unilateral spinal with just 0.6 or 0.8 cc? Practically, I'm asking this question.
Can I add something, ma'am? Obviously, with an EF of 20%, I will never dare to give a spinal.
See, because practically, I have done n number of questions. Cases, 20% EF with noradrenaline ready and even attached to the patient, just 0.01 mics per kg. And if we look at literature, and if we look at even literature, cardiac journals, they have started doing aortic stenosis for TAVIs with a little bit of spinal anesthetic. There are case reports and with noradrenaline. That's why I brought out this point. So if they started using it in cardiac cases with severe aortic stenosis, and why I'm saying is spinal is something which each and every one in the audience has done. Everyone has done. Practically, these sort of cases come anywhere and everywhere. Of course, lumbosacral plexus block, of course, is very good, but can we do it this way also?
Madam,
Because
working
we
in
have done, and I think
Madam,
we are quite
working in a
successful.
corporate setup and with a lot of medico-legal hassles, obviously I will never dare to do a under 20% EF a spinal. What I do, sometimes there are patients who are not ready for lumbar and sacral plexus. I just induce them with a etomidate, with 20 ml of Propofol. I just put a igel. I just do a analgesic block, and my surgery is done. But spinal, obviously, I will never dare to do it.
Ritesh, spinal is not contraindicated.
No, spinal, let me say, you want to do a unilateral spinal. You have a fracture on this side, right? You want the spinal to block that side. So how are you going to position this patient for the spinal?
That is the problem, that unilateral spinal is never unilateral. Only that low dose of this one with a little bit of vasoconstrictor or vasopressor like noradrenaline works fine. Same way, the lumbar plexus and sacral plexus combination also works fine. Whatever anybody is confident with or comfortable with, they can go with that. So both are not contraindicated.
So there are many ways of doing things, and obviously, whichever way you are comfortable, you can get the surgery done. Okay, and if you are confident that I can get this surgery done in this technique, and I can handle the complications, that's the best technique for you. That's a simple thing.
I think if you are using spinal, if you're using spinal, it's better to use. If you're using spinal, better to use a sequential compression device on the other leg, so that you don't have much of a complication and not requiring vasoconstriction.
Excuse me, sir. For spinal, I think isobaric levobuprofen can be used with segmental spinal.
And regarding TAVR with spinal, I am a little surprised. We are a high volume center for TAVRs. I have never seen this report anywhere.
It is not a common practice. I said there is a case report already come in the ACTA journal. There is a case reported. This is just an example I gave. Means first, if they have started this one case report, it is not a common practice. It is not standard of care. I'm not saying it's a standard of care. I'm just saying that these things, or see, they are risky always. So it is possible to do, and 15 and 20% EFs, we have done n number of cases with a low dose of noradrenaline. We have the arterial line in situ under local anesthesia when we do all this. We have an arterial line in situ, we have a NORAD low dose going on, and we can do this case with a low dose of CSC.
I got some, two comments, final comments almost. Concerning the thoracic paravertebral, well, it's not a real fascial plain block. No, that's going into a space. It's not, there are no fascias in this area. But anything what concerning anatomical investigations, if you take a look on, please always read them properly concerning the embalming methods, how the assessment took place and what was injected, like methylene blue or whatever. So please take this into consideration too, to regard these investigations critically. For myself, I already told you my experience with methylene blue. That's why I went away from it. It was a major mess. And if you dissect it, you have your injection of methylene blue everywhere, but also over there where you do not want to have it. So it's really spreading like mess. And the third thing is also take into account if you see a manuscript published in 2009, which is dealing with ultrasound. Ultrasound in 2009 is not comparable to anything what you perform over now. We are in a different universe already. Technique ran. We have images and also devices which are so good that we can identify now the clunium nerves, which we have never thought about it in 2009. So you see how the devices are developed, how the technique is running, and what what opportunities are given. But nevertheless, be also cautious concerning all the interpretations and what you see. This is the problem with ultrasound. We have to train, we have to train, we have to train. Myself too. When I started the first time, I have to realize what do I see in my images, and what is which structure. And this is what we have to go back to, because if you have a high definition ultrasound device, you see structures what we also as anatomists have never thought about, like the fascias in the subcutaneous tissues, okay? So we have to get back, and we have to step back too, because it's running too fast for us. So sometimes it's even better to have not the best ultrasound machine, that you really get back a little bit. But nevertheless, with the clunium, for example, you see how far we are going already. Okay, and the third thing, as you already said, was you have to speak also with your surgeon, especially concerning the hip surgery, which approach he is taking. Okay, that was from my point of view. Okay, any other comments? Yeah, well, I know. It said 16:20s. We still have 10 minutes, right? Theoretically. No, I think let's go and start to the next, or continue, or whatever. Well, okay, we close the session now. Okay, thank you very much for your, being here and for the discussions.
Thank you, Dr. George. Thank you, Dr. Ram. And we'll head to the next session, please.
I can motivate everybody to discuss and to think about it.
So, good evening. The next topic for discussion is coagulopathies and regional anesthesia techniques. I would like to welcome the moderators for this section, that is Dr. Philip and Dr. Sandeep Mutta. Thank you.
Hello.
Madam, we'll start at 4:25 sharp, because there'll be people who will time themselves to come for the session. So let's not start ahead of time.
Since we are waiting, we'll go back to our session. Anybody here has done any thoracic or breast surgeries just under blocks, or just under thoracic paravertebral? Any experience of doing breasts just under facial plane blocks? The reason I'm bringing that up is in one of the publications which we saw while I was doing that is a pectoral nerve block just as a sole technique for breast surgeries. TV sir, any comments on that? Or because anatomically I find it a little difficult to believe that a breast surgery alone can be done just under a pectoral nerve block.
Which one?
So when I was doing my talk, in my talk as well, there was a couple of publications which claim that just a pectoral nerve block for a radical mastectomy. So
actually, pectoral nerve block for radical mastectomy is an analgesic block.
Correct. No. So there are a couple of case reports which are saying that they will do a radical mastectomy just under pectoral nerve blocks. If
Not-
you ask me,
not possible.
from anatomical point of view as well, it is not possible because a pectoral nerve block will cover just a medial lateral pectoral nerve, maybe catch the intercostitobrachial as well. But to get a full thoracic, coverage.
A lot of times these case reports are not honest about how much of sedation they give to these patients and how many people are actually holding the patient down on the table. So I think we should not be misled by such isolated case reports which really have no anatomical basis.
Also, there were a lot of from comparisons of or meta-analysis as well, where thoracic paravertebrals were compared to chest wall blocks as a combination, and the evidence was sort of equivocal. So again, we come to the fact whether these facial plane blocks are really as good as a thoracic paravertebral as well. But I think having learned from our case series in doing is that you cannot have a one fits all sort of thing. You need to tailor your blocks as to what the surgeon is going to do, what the surgical process is, what nerve supply is, and then add the blocks as well. The other thing we have realized is just putting a paravertebral block, even if it is a good spread, is not always enough to cover the T2, which is the intercostobrachial, as well as if they raise the flap from the upper end, which is supplied by the superficial cervical plexus block. So the point I'm making is you need to do a combination of few things to get the entire chest for surgical anesthesia purpose. You may get away with a local anesthetic from analgesia point of view. When you give a general anesthetic and do the cases and post-operative, they are fine. But the true test of the block comes when they're actually wanting to do a surgical procedure under these blocks. So if you want to do that, especially from breast point of view, is you need to have a little bit of combination.
Actually, breast is supplied by 10 nerves.
Yeah, correct.
So you can't go by 2 nerves or 3 nerves blocking and getting the surgery done.
Absolutely.
It has to be basically cervical plexus or brachial plexus, cervical plexus, superficial cervical plexus, and paravertebral combination works well.
Correct.
Cervical epidural with superficial cervical plexus block, that also works well.
I have no experience of using the cervical epidural actually, but that's
actually we had a series of 25 cases done under cervical epidural for breast surgery,
right,
and 25 cases done for the thyroid surgery.
Right.
So only thing what we did was for the breast surgery we used to give pillow under the head and then give the drug. So the drug seeps down lower, this one, to around T4, T6 level. And for thyroid surgery we used to remove the pillow and then give the drug so that the drug goes up to around C3, C2 level.
How did you, well, is there, by CAM technique, how did you do those cervical epidurals?
Cervical epidural is direct. Sitting position, be standing behind him, the neck flex, C7, T1, you put the cervical epidural.
What volumes and all that?
So 7 cc of the drug was required normally, and we used to add 60 microgram of north into it.
Okay.
So normally 1 or 2 doses maximum. Top-ups.
Any adverse events so far? That
no adverse events were seen except one case had a Horner syndrome.
Okay.
Because of the cervical epidural and the action going up. And little bit of sedation was required because of the position, because of the proximity to the surgical, this one, and the airway. The drape used to come up to this, so the patient used to get a little bit uncomfortable. So a little bit of sedation and oxygenation was required. The rest of the things were fine. But it's not easy technique to do. But it can be done.
Shall we start the next session or? 5 minutes more.
We have a change in the next session. So Dr. Bala and they are coming. All the 3 speakers are going to do an interactive session.
Okay.
So instead of lecture, so you just wait for both of them to come.
Shall we just sit tight for 5 minutes? Yeah. Sorry, sir. Okay.
You see, many times we mention about meta-analysis results and all, and we explicitly quote the conclusion. But usually that doesn't give a very clear message. What we have to see is what was the control group, what was the intervention group, and what was the control group. And many times the results of the meta-analysis is what gives you the correct information. You have to read between the lines, see the forest plot, see the funnel plot, and only then, because
their inclusion criteria are also different. What they're looking at, their parameters also different.
Sometimes the sentences in the conclusion and they actually mislead the readers, and we try to follow and makes our like our perception changes for a particular medication or an intervention.
That's true. It's a good point actually. The publication or the editorial which came from the BGA, which is come in May 2023, the title is actually Erector Spinae Block Ultimate Plan A. But actually if you go read through that, they have also mentioned that you need to be a little, concerned about what actually the action is, and may not necessarily again be for all the anterior blocks. There is definite evidence to show that erector spinae will affect the posterior part. So for lumbar, anyway, back surgeries and all is fine, but whether actually it causes any anterior effects is still, though there are so many publications of that erector spinae block. I think we'll wait till our speakers.
Whatever drug we inject in the erector spinae, some of it goes to the paravertebral space and also in the apical space if you're giving a larger volume. So 100% there will be action on the anterior side.
Actually, recently on YouTube, there is a good explanation of the anatomy by Dr. Vincent Escolar. If you get time, just have a look at the video. He mentions it at the end that this is little bit mainly anatomy, but also a little bit of imagination and whether thinking about how the paravertebral and the ESP blocks works. So it's worthwhile seeing that video by Dr. Vincent Escolar. It's a great video in terms of the anatomy and the graphics as well, and gives you an idea about how the facial layers as well, and how the local anesthetic can actually spread. So it's worthwhile seeing that.
Till we have time. So any other way in the audience who does the breast surgeries, any other way they give analgesia? Other than this SAP block, paravertebral block, or anything? No ideas?
I think if you're hinting at intrathecal morphines, is that what you're hinting at, or? I know for a fact that there are a few case reports which say intrathecal morphines for...
Even music therapy.
Music therapy we have done for cases which are done under local anesthetic. So that's true. That's true. That gives you a view. Again, since Sir mentioned, we have also realized on these cases while doing under blocks, the breast surgeries under blocks is, they do need some sort of sedation. It's not like a spinal or an epidural where they give you a complete analgesia or anesthesia and then you expect them not to move during the procedure, because they will, first is they're quite apprehensive. The surgery is happening very close to the face. Second thing is so many retractors. You cannot take away the cautery effect while doing it, however good your blocks are. So the muscle contractions and all always make the patient very uncomfortable. So sedation, if not compulsory, but maybe definitely required to keep them cooperative during the procedure. That's one thing that we have realized after doing our cases.
Okay, we are starting with the next session. That is on coagulopathies and RA techniques. The moderators are Dr. Philip Ruck and myself, Sandeep. This session will start with Dr. Bhagyashree. She'll be giving a small talk, and then Dr. Bala and Dr. Shiva Shanmugam will come on the dais, and they will have an interactive session. So it should be a very interesting session with 3 stalwarts plus Philip Ruck on the dais. I will want Dr. Bhagyashree to start the session.
Hello, good evening everyone. I'm hardly a stalwart in front of Dr. Bala, Dr. Philip Lug and Dr. Shiva Shanmugam, but I'll be contributing a little bit whatever I can in this topic. I'm a transplant anesthetist and I deal with coagulopathies day-to-day basis, mostly organ-related, liver-related coagulopathies. Today's topic is slightly different. We'll be dealing with iatrogenic coagulopathies and how to manage these patients in perioperative settings. So it's a complex problem, handling this patient in perioperative settings, but it can be tackled by deconstructing into multiple solvable steps to formulate a safe perioperative plan for our patients. Usually as an anesthetist and even our surgical colleagues, we are mostly concerned with the hemorrhagic or the bleeding aspect of it. But we should also know why these patients are primarily put on these therapies. And can we stop these therapies? And if we decide to stop, what is the thromboembolic risk we are subjecting this patient to? Versus what is the bleeding risk if we decide to continue? So the basic steps of evaluation would involve preoperative risk evaluation. So we should know, should we stop the drug in this patient? If we cannot, when should we start the bridging, or is the bridging helpful? And what is the bleeding risk in managing all these things? This cannot be possible without knowing your drugs and what labs you will be ordering for these patients. And of course, everything is in respect to the clinical scenarios, whether this is an elective or emergency procedure. Are you planning any high-risk procedures like deep blocks or neuraxial anesthesia? And how to deal with the patient if the patient comes to you on anticoagulation with a major bleeding. So let's start with assessing the thromboembolic risk. So there are 3 main indications for which the patients are put on this therapy. One is atrial fibrillation, second prosthetic valve, and venous thromboembolism. There are specific scoring systems developed by ACC. For atrial fibrillation, it is the CHAD-VAS score. It is basically an acronym for congestive heart failure, hypertension, age more than 75 or less than 75 years, diabetes mellitus, prior history of stroke, any vascular disease, and female gender. So these conditions will be assigned points each. Less than 3 points, the patients will be in low risk category. Between 4 to 5, it is moderate risk, and more than 6 is high risk. For prosthetic valves, you have to know where is the valve. Mitral is more notorious than aortic. What is the type of valve? If it is a mechanical valve, or is it a bioprosthetic valve? And is there any additional risk factors for stroke for these patients? For venous thromboembolism, risk if the incidence of venous thromboembolism is more than 12 months and there is no recurrent episodes, these are low-risk patients. VT within 3 to 12 months with any history of recurrent VTs and active cancers and diagnosed thrombophilia but not a severe category would be in moderate risk, and VT during last 3 months with severe thrombophilia will be high-risk patients. So we know our patients now. Next, we have to decide what is the role of bridging therapy. So these are 3 categories of risk patients we are dealing with. There are extensive studies are done in low-risk and intermediate-risk patients. One of the pioneering studies is by Dr. James Dokotis. He is a very well-known name, and he has contributed immensely to ASRA guidelines in managing anticoagulated patients in perioperative settings. What they found out was the surgical patients which were bridged and not bridged in the perioperative settings, who were low and moderate risk, not high risk patients, only low and moderate risk patients. There was no significant difference in arterial thromboembolism in these patients. But the concerning fact was there was a significant increase in the perioperative bleeding. So currently, majority of the guidelines, like PAUSE 1, PAUSE 2, and bridge trials, they advise bridging therapy in high-risk patient. Second thing, we have to know that bridging therapy is advised in patients who are on long-term anticoagulation. So the drugs for long-term anticoagulation are vitamin K antagonists, the DOACs and antiplatelets. DOACs are directly acting oral anticoagulants and antiplatelets. So patients who are on VK currently are more favored for bridging because as you see, according to their pharmacokinetic profile, they require longer cessation of the therapy. And of course, antiplatelets in acute coronary syndromes, the patient coming to you on emergency scenario, elective scenario with less than 6 months of stented patients. So next we have to check is the bleeding risk. This also has a specific scoring system. It's called as a Hasbled scoring system. It is again an acronym for hypertension, abnormal renal and liver function, prior history of stroke, any bleeding or predisposition to bleeding, labile INR, elderly patients, and drugs including herbal drugs and alcohol. Patients scoring more than 3 in this scenario will be classified as those who are high risk for bleeding in the perioperative setting. Again, next is, of course, what type of surgery or procedure the patient is undergoing. Usually superficial procedures where hemostasis is easily available, achievable, and patients who are surgeries which are minimally invasive are low-risk surgical procedures. High-risk surgical procedures would be those involving highly vascularized organs. For regional anesthesia, superficial blocks fall into low-risk categories, and majority of the times you need not stop anticoagulation to perform superficial blocks in these patients. And the neuraxial and deep-plexus blocks fall into high-risk patients. It is too complicated, but there is an app which is called as Anticoag Evaluator app. It is developed by the ACC, and you can make use of it in deciding the therapy for your patients. The indications for anticoagulation are primarily arterial thromboembolism, venous and mechanical heart valves. Patients for arterial thromboembolism, preferred agents are antiplatelets. For venous thromboembolism, for DVT prophylaxis, heparins are preferred. And for long-acting therapies, current DOACs, the directly acting oral anticoagulants, are surpassing VKs in almost all situations except mechanical heart valves, where VKs are still the preferred drug of choice. So we have decided a plan of bridging. We have evaluated the risk for this patient. Now we have to know what is the drug the patient is taking, what labs you will be ordering for these patients, what are the clinical scenarios, and what are the guidelines and evidences based on which these patients have to be treated perioperatively. For the next talk, we will make it an interactive session, and I'll call upon stage Dr. Bala Venkat sir and Dr. Shiva Shanmugam.
Sir, so now the session is going to become interesting. So it will be an interactive session between 4 stalwarts. Dr. Bala Venkat, Dr. Shiv Shanmugam, Bhagyashree, and Philip Luck.
Thank you, Bhagyashree, for giving an insight into one of the important topics. I think it's becoming important. The next topic actually was neuraxial anesthesia in a patient who are on antiplatelets. We decided to make it as an interactive session where I would wanted each one of you to participate, give your thoughts, give your case scenarios. But to start with, I just wanted to highlight few points. As per all the guidelines now, it is extremely clear that there is no need to stop aspirin in the perioperative period. I think I want to make this statement very clear because even today, we get phone calls from people saying that they've stopped aspirin. So this has to go. aspirin should never be stopped. And the most important thing is when you do the pre-anesthetic checkup of any patient, you just have to find out what was the indication for which the aspirin was started. We all know that aspirin is primarily for the arterial side. And if you see patient on anticoagulants, it is more for the venous side, in a broad perspective, as far as a perioperative surgical patient is concerned. So had this patient been put on an antiplatelet, it is because of a previous history where there has been a cerebrovascular or a cardiovascular accident involving the arterial supply. So this point is very important. And two drugs which are used the most, one is aspirin, the other is clopidogrel. And sometimes it's a combination of the two. And it also becomes important for us to know that the aspirin works on the primary platelet plug formation, whereas the clopidogrel works on the secondary platelet plug formation. So these two things we need to distinguish. So the first point we discussed was, in the history, if it was obvious that this patient had a previous arterial disorder and a thrombosis, this patient was put on an antiplatelet. So ecospirin or aspirin, 75 milligram, 150 milligram, 325 milligram, if this patient is on, no need to stop, continue it perioperatively, including if you want to do a neuraxial block. This has become a part of the guideline. So, Dr. Philip, do you agree with me? And what do you do in your center regarding aspirin and a neuraxial block?
Yes, exactly the same. Thank you so much. I couldn't agree more. So also with us, aspirin just is continued. There's no contraindication for any type of block, including neuraxial. And the one thing that puzzles me really since 10 years is that we, for example, know that clopidogrel has an incomplete responder rate. So there's lots of people that take it, but they don't really have an effect. And we could maybe probably even do a block, but we don't know. So we've got all these platelet analyzers, and we never use them to maybe determine where the patient's really at. So again, a plea to individualize and to maybe dig deeper into the individual patient. But unless it becomes really widespread adoption, I think the current guidelines make sense. Clopidogrel would preclude us from doing any central block unless we're out of this window of 5 to 7 days, and then aspirin is given.
Yes, I would like to add something to it, sir. So basically the patients on clopidogrel, we have seen there is two ends of the spectrum, the high responders and the low responders. The low responders are the one which we are very concerned about, that small doses leading to significant blockade. For this patient, the history of bleeding, prior bleeding, is very important. A patient coming with a history of epistaxis or a GI bleed or a parectal bleed, a female patient with a menorrhagia. So this prior history is something which we have to really look into it. And of course, we are not ready for it, but there are many papers where individualized or tailored therapy, according to pharmacogenetics of the patients, would be really handy. And we are privileged to have a platelet function analyzer, and we have been using it occasionally for a few of the patients. And it has really helped us in scenarios in some difficult patients where GA was very high risk.
Okay. Dr. Siva, you would wanted to add something on this? Yeah. So the first aspect of it regarding aspirin, I'm sure none of you, including the youngsters, have no doubt. And next we go on to the other commonly used drug, clopidogrel, which Dr. Bhagyashree gave an insight into that. Now, if it's an elective procedure, it becomes very easy. You stop the drug 5 to 7 days before. 5 days before. And now, next important point I would suggest is, if the drug was put for any kind of thrombus before, it becomes very, very important that you will start this patient on icosapent. Many times what happens, the clopidogrel is stopped, and the aspirin they forget to add to this patient. So this is the next point I just would wanted to convey to you. And there have been incidents and reporting of perioperative cardiac event and including morbidity and significant mortality because these patients were not started back on any form of antiplatelets. So the second take-home message is, whenever you decide to stop clopidogrel, I think please start this patient on aspirin. This is the second point. Now the third point. It is also important for us to understand if this patient is coming for an elective surgical procedure, waiting for 5 days and taking up this patient, putting this patient on aspirin is a perfect perioperative condition. There are no issues. But sometimes you're confronted with a situation which we come across very often in my institute because it's a pure orthopedic unit and we get plenty of geriatric patients with hip fracture. So this is the one which I really want to bring in and request all of you to introspect and think. Now, what are the issues? Number one, a hip fracture, the outcomes are extremely good if they are operated within 24 hours to 36 hours. Definite literature. Number two, patient was on clopidogrel and now we say that we shouldn't operate this patient for 5 days if it has to be under neuraxial block. If it has been done under general anesthetic, the only issues are the patient will lose more blood. The various studies have shown the increase in blood loss will vary between 250 to 350 ml more than those patients who were was not put on clopidogrel. So this is one aspect of it. So a neck of femur or a trochanter undergoing general anesthetic to be operated within 36 hours, again, I think it's all very clear. Just be prepared for increased bleeding. But the next scenario is, patient has got such multiple comorbid conditions where now you feel general anesthesia. And also we need to remember, all that we speak is in related to our country, our hospitals. Trochanters are being done in several small private units. So this discussion is inclusive of all the healthcare providers across this country. So when you work in a unit like that, giving a general anesthetic to an 85-year-old becomes a challenge. And the consequences of doing general anesthetic in a patient have got multiple medical issues, including pulmonary issues, poses a challenge, enhances the morbidity and sometimes even mortality. So now we come back to the point. In a scenario like this, what if a neuraxial block is performed in this patient, given the scenario, whether we can do it or not? Now I come back to one more study which says you also have to take into consideration that today I take 1 tablet of clopidogrel. All the circulating platelets got exposed to this and it loses its function to adhere. But tomorrow the platelets I produce are not exposed to clopidogrel. So now 3 days, the current studies indicate that the rate of production of platelets, the new platelets that are produced, are sufficient enough within 3 days to produce a clot, especially in the small vessels. Like the entire neuraxial region has got only small vessels. So now I throw this open for a discussion because we have very senior clinicians, anesthetists like Dr. TVS Gopal sitting here. And I just wanted to open up the discussion on waiting for 5 days. Now we know that within 3 days, adequate platelets are sufficiently produced to produce a clot. Here is a situation where general anesthetic will be more harmful to my patient given my scenario. And is this something which we need to think about for a country like us? To get a written informed consent about the possibility of epidural hematoma and a possible neurological deficit versus the enhanced morbidity produced by general anesthesia. I open this up for discussion. And Siva, if you want to say something. Yeah.
So I will just add up to that, the data to what Bala sir is saying. Say in BJA in 2019, they have compared spinal versus GA for hip fractures, and then they look at the morbidity. The group in the spinal, the death rate is less than by 33% compared to GA. The DVT incidence has come down by 43%. The cognitive dysfunction is less in spinal group by 50%. The pulmonary complication is again by 35. Acute renal failure is about 30% is less. Infection is 33. The blood transfusion requirement is 20% less. Comparing spinal versus general for hip procedures. That is the published data. And then the morbidity, the 30-day mortality. So if you wait 48 hours for a fractured hip, that's on the orthopedic societies, the mortality death rate is increases from 6 to 10. That is 40% increase in mortality if you don't operate them within 48%. So these two things are the fact, the group which we are dealing with. There is a benefit for central neuraxial regional anesthesia per se, but if you wait beyond 48 hours, the morbidity is going on one side. So this is what's the challenge we have been put in. I have offered the data for whatever the benefit Dr. Bala sir said. And there are data from the congenital deficient hemoglobins. They have assessed at least 40% of the clotting factors are enough to produce a surgical homeostasis, both platelet as well as the clotting factor. Even when we were replacing the components, we are not trying to achieve 100%. We are trying to achieve only 40%. So suppose your platelet turnaround time is 4 days. Theoretically, at the end of 48 hours to 72 hours, we should have at least 40% of the functioning platelet to achieve our surgical hemostasis. When they talk about surgical hemostasis, we are talking about a needle-induced trauma. So these are all the facts in the literature. So now how to go about it? What is your views? How you do in your practice?
Yeah, I would like to add just a few things. Since we are talking about clopidogrel, we assume that once the drug is taken, all the platelets are exposed to it and it is 100% working. But if you see the literature, even after 300 milligram of loading dose, in the responders, only 56% platelets are blocked at a time. And if we really look into the pharmacogenetics and the metabolism of the drug per se, it's a prodrug, and 85% of it would be metabolized away, and only 15% enters the circulation for hepatic metabolism, and it involves 2 oxidative steps. Eventually, it will go and bind the ADP receptors, and the platelet will be inhibited. So there is a significant variation, and they have identified few genetic variants where the patients are absolutely non-responders. And this variation is almost found in 30% of the patients. And second thing, assumption is we always believe the patient has taken all the even if the patient has taken a dose yesterday, has the patient taken all the doses in last entire week? Is there any other drug-drug interactions in these patients? So there are many other factors where these assumptions have to be questioned. And on the other hand, we also have to ask for the history for those patients of bleeding histories, especially in a preoperative evaluation. So based on this, maybe we can open it to the discussion now to the audience.
Dr. Philip, you have anything to contribute regarding the discussion we had now?
Thank you so much. So I applaud you for the discussion that you say, the informed consent of risks and benefits of both avenues.
And also the amount of platelets that get dysfunction because of a dose of clopidogrel.
Yes.
Taking all this into consideration and the new platelet production,
are
we in the right track? Are we being guided by a guideline which is good, or whether we need to improvise that?
Yeah, I think I come from a country that's living in Europe. I think we're moving a little bit towards an individual risk-benefit assessment, which I think is the way to go, especially because the number of these patients that we meet is going to go up exponentially and will be in difficult situations as you described them again and again and more often. Unfortunately, my second country of residence, the current one, I think is a little too litigious to allow for those discussions. I've heard these discussions in Europe, also superficial deep blocks like you alluded to, that we actually differentiate between which blocks we do and say this is acceptable, this isn't. But America is still very conservative and very on the safe side in the legal sense, even though you say that it may not always be the perfect opportunity for every single patient. So we're still more guideline driven in the States, more individualized from what I know in Europe.
So, I mean, to take the discussion, let me propose what, sir?
Just going back to the guideline, Bala, initially it was 7 days because the half-life of a circulating platelet is 7 days. Later on, it was brought down to 5 days because clopidogrel, as we know, the affinity for platelets is not 100%, which is why newer drugs such as prasugrel and ticagrelor were brought into use. So the fact remains that in 5 days, you have enough number of bound circulating platelets to make sure there is a clot that can form in case there is a bleed. Now, below 5 days, I think we cannot tell the audience here that it is all right to go ahead and do a spinal, even knowing that waiting for longer than 48 hours after a proximal femoral fracture can add to the morbidity and mortality of a geriatric patient. As you rightly said, the first option would be GA. And if GA cannot be given, she spoke in her lecture about point of care testing. If there is recourse to some point of care testing, like a TEG at least, that makes sense. But if that is not available, then as Philip rightly said, we have to go into individual risk versus benefit analysis and counsel the surgeon, counsel the patient and the patient's family that we are going ahead with a spinal for so-and-so reasons. And it is important that having decided on a spinal, the senior most anesthetist does the spinal. And we endeavor to get the spinal in the first shot. We use a 27 gauge pencil point needle as opposed to a Quincke needle, and use the lowest possible concentration and volume of the drug.
Yeah, excellent. I think, Dr. Siva, you want to add a few points? Yeah, yes, Bande sir.
The proposition looks absolutely attractive because we have been waiting for 5 days all along, and that's a guideline at this point of time. As I said, point of care may help us to do, we may need to do some pilot cases in a controlled environment by thromboelastogram, by looking at the amplitude as well as the platelet mapping. Both can help us. And in controlled environment with informed consent, we do some pilot cases because we know it is beneficial, definitely, and we don't see too much of a bleeding whenever people have done accidentally cases within the 5 days of period. So this can guide us provided we go forward with some consensus that these cases can be done. So I think that may help us to decrease the time from 5 days, depending on what period it shows the coagulation activity on the thromboelastogram and platelet mapping. That can give us qualitative as well as quantitative estimation of platelet function and dysfunction.
Excuse me, sir.
Yeah, yes, please.
Sir, next thing is actually cardiologists write on the paper for 3 days. So how can I cross this? We tell for 5 days stop to hold the antiplatelet for 5 days. And cardiologists write on the paper for 3 days.
Yeah.
So we have to go further.
So it's a published data that 3 days, it's already published in anesthesiology itself, that 3 days was sufficient enough to go ahead. So that's why we said guidelines said 5, and now we have publications for 3 days. And no, that's why this whole discussion is.
Yes.
That's why the session is.
Sir, sir, I want to also share some 2 cases.
Actually, agree with her. Lot of times there is no uniformity amongst cardiologists when it comes to cessation of antiplatelet drugs. Some cardiologists continue clopidogrel and stop aspirin. Some stop both. Some say clopidogrel for 7 days. Some say 5 days. Some say 3 days. Some say you don't need to stop at all. You can give a unit of single donor platelet. So I think beyond educating ourselves, it is also important that we educate the physicians, the surgeons also. So I go along with what she said. I mean, a lot of times cardiologists write 3 days, and that is a dilemma for us. So when that sort of a note is brought to my attention, I talk to that particular cardiologist, I show them the guideline. And if they still insist 3 days, we take specific consent and then go ahead.
And sir, excuse me, sir. Sir, just I want to share some things. And other 2 cases, I want to share the scenario. One patient posted for urological surgery, TURBT. The patient needs angiography, and it is stated that he require stents, dual stents and 2 coronaries. But he had history of bleeding. So please do the surgery before these procedures. And we had done it in general anesthesia as the ejection fraction was 35%. So
Actually,
before any cardiac interventions, we have to do these surgeries. We have done these surgeries.
No, this is an excellent clinical scenario. And this goes back to asking when we are confronted with a situation like what you said, and similarly what we face with hip fractures, there are a large number of studies, at least a proven entity, that whether these patients have to undergo an angiogram, unstenting and a loaded antiplatelets before surgery, or informed consent, get the surgery done, and then subject them to the coronary angiogram. So this is another very peculiar situation. These are all absolute challenges to science.
Sir,
Gray areas. Yeah, please.
Sir, also I had did one spine surgery patient having triple vessel disease. Actually, ejection fraction was 40%, it's okay. But surgeon also refused for any cardiac intervention, actually advised CABG. But we taken risk, done in a general anesthesia, patient recovered well, shifted in ward. But what is the stress we have deal with during the surgery? And no cardiac interventions done, these are all posted after it.
There are certain instances where doing a non-cardiac surgery takes preference over coronary stenting or a CABG. For example, you said the patient was bleeding from the urinary bladder. If you were to do a drug-eluting stent in this patient, the patient cannot undergo any elective or semi-elective non-cardiac surgery for 6 months. You cannot stop the antiplatelets for 6 months, not even one of them. And some of these people, when they have complex angioplasties, they are on 3 antiplatelets. Even cilostazol is added. It's not just aspirin and clopidogrel. So in such cases, they are right in saying you finish your non-cardiac surgery first, we'll deal with the cardiac issue later. That is acceptable.
spine surgeries, we can wait for the spine actually.
If it's a crippling issue which will affect the patient's quality of life or longevity, then doing the non-cardiac surgery first makes sense.
Yes, and all things come between high risk consent and all the explaining to the
You
relatives.
will explain everything to the patient and the family, and then go ahead.
So there was
one of the important things to keep in mind, see, ejection fraction of 35% and 40% does not indicate anything to us in terms of what the coronaries are. It's just an indication of how careful that you are going to be in the perioperative period and what medications that you are going to use. Are your medications going to drop the systemic vascular resistance so much? And what would be the degree of the hypotension and how much mean arterial pressure decreases? I think these are all the most important factors when you have a problem with the pump. So I think what you did was right, but also the factor is when we all do these cases, it is, I think, very, very crucial that simple logic works. Like this patient had a preoperative blood pressure that you measured. Say if it is 140/80. I think the brilliance of the anesthetist is to provide a form of anesthesia where he will be able to maintain the same perfusion pressures so that the perioperative period will become uneven full. The problems happen if you're going to crush the blood pressure because of your technique and technology. So I think this is another factor probably we need to keep in mind.
Regarding the central neuroaxial block in the settings of, say, you think that the spinal benefit is more over GA, and you wanted to do it with a proper consent, but TVS sir said that the senior-most person has to do. Even in the ASRA guidelines that previously it is published, if you look at the estimated incidence of spinal hematoma, with heparin, it is only 3. But if you do a traumatic spinal, the incidence is 112. That is 100 times the risk is more for a traumatic intervention than your heparin itself. Then do you understand who is the culprit? The performer is the biggest threat in terms of neuroaxial hematoma than the drug itself. So this is paramount important that traumatic intervention increases the risk more than 100 times than an atraumatic intervention. So that we should be keeping in mind.
Without trying to imply anything, I think one of the editorials, as well as I think it's mentioned in the guidelines as well, whether we need to also take into account when we do lumbar punctures on patients who actually cannot wait for 3 or 4 days, who are already on clopidogrel when the lumbar puncture is done as well. And if you speak to the neurologist and if you speak to even the hematologist for that point of matter, they say that we have to accept the risk and do it. So whether that also gives us one aspect of doing lumbar punctures with these patients already on antiplatelets or with low platelets as well.
Yeah, there are many papers published actually from the Neurological Society, and there are case series of involving 100 plus patients. I covered few in my yesterday's talk, and this is a critical scenario from which we all can learn, because we can't wait for diagnosing this patient for 5 days till the clopidogrel stops acting. And somehow we have to take that risk and go ahead and do the diagnostic puncture. And these case series involved all kinds of needle gauges, including 18 to 22 gauge, really big needle sizes. And they were performed by skilled doctors, trainees, and even the trained nurses. I mean, there was not just a senior anesthesiologist who was involved, and they have reported that there was not a significant the problem with this specific condition is it is such a rare incidence that if you were to statistically prove it to come to an existing guideline, to change a guideline, you have to require a very large volume of patients undergoing this kind of procedures. And it is difficult to collect such a big volume of patient up to, like the incidences for spinal is I think 1 in 220,000. And so you have to have that much of data at hand to change an established guideline. So what we are following is actually a pharmacokinetic model where the drug, and in this case specific, like for example, warfarin is acting on certain factors. So what is the half-life of those factors to be produced in the body? against the half-life of the drug itself. So based on this complexity, these guidelines have come into picture. If we have to change it into clinical scenario, we require really a large database of case series.
And for the benefit of the juniors in the audience, it's not just important to do a spinal and have it done properly, first go, no blood in the CSF, all that is fine. But especially private practitioners, you have to follow up the patient at least for the first 6 to 8 hours in the postoperative period. Because if this patient were to have an epidural hematoma causing a debilitating neurological deficit, studies have clearly shown that if the intervention comes within 6 to 8 hours, the patient has a good chance of recovery. So please, if you are not personally there, empower somebody to follow up the patient in the post-op period, which is why I said lowest possible volume, lowest possible concentration, so that the patient recovers quickly from the spinal and you can monitor the patient for any new onset neurological deficit.
Yes, I will ask Sherby. Now we talked about the antiplatelets. So now the patients on anticoagulants, they are coming for an emergency surgery.
Yes.
We talked about our central neurological intervention, but the reversal is very important for the surgery as well. So can you just tell us what are all the anticoagulants that you can effectively reverse, and any test can be done to ensure that yes, we have achieved a satisfactory hemostatic point? Do we have how to go about?
So we'll just go ahead with the next part of the presentation. We'll just concern ourselves with the emergency surgeries here. Most important and very dreaded is the patient who has taken warfarin on the day of the surgery and patient comes for emergency surgery. For warfarin, it is important that you monitor the INR of this patient and you have to check the INR. If the INR is less than 1.5, even if the patient has taken the dose on the morning of the surgery, you can proceed with the surgery. INR between 1.5 to 3 in a patient which we saw if he or she falls into low risk category of surgery, including superficial blocks, you can still proceed with the procedure which we have decided. But if INR is between 1.5 and 3 and the risk, it's a high risk procedure or a high bleeding surgery, you have to reverse this patient. And also in patients with INR more than 3, you will still have to reverse this patient. So reversal of warfarin is very specific. The prothrombin complex concentrate is available now and it is specifically used for reversal of warfarin. The dose is completely depends upon what is the INR of the patient. So between 2 to 4, you have to infuse 25 international units per kg. Between 4 to 6, it is 35, and more than 6, it is 50 international units of PCCs, along with vitamin K. But vitamin K takes longer to act, up to 6 to 24 hours surgery. So super emergent procedures, which are to be taken less than 1 hour, you can't wait for vitamin K to act. In that case, in addition, you can use FFPs 10 to 20 ml per kg. And for every trauma patient, guidelines have shown that 1 gram of tranexamic acid stat to be given, followed by followed every 8 hourly. So this is for vitamin K antagonists. For patients coming to us on DOACs, directly acting oral anticoagulants. The beauty of these drugs is they are direct inhibitors of those agents. That is, for dabigatran is a direct thrombin inhibitor, rivaroxaban and apixaban are direct anti-10A inhibitors. So they act fast and they stop acting faster, equally fast if you stop them in a stipulated period of time. So if this patient comes to you for emergency surgery, you have 24 to 48 hours at hand, you can just stop the drug and proceed with the surgery, try and delay the surgery. But if you do not have that much of a time at hand, the options are go ahead and do the specific assays. For all these drugs, if the drug levels are more than 50 international units, per ml, it will be high risk for bleeding. Between 30 to 50 is a moderate risk, and less than 30, it would be a low risk category. You do not have the factor assays, specific factor assays. So what do you do? For dabigatran, APTT is, or direct or thrombin time is something which you can go into. And the studies have come up that if you have a normal EpiDT or TT, there is unlikely to have a significant anticoagulation activity. Rivaroxaban, same thing is with PT. But for apixaban, although it affects PT, it will not exclude therapeutic presence. So you cannot undertake any high-risk procedures in these patients. So we covered the emergency scenarios of evaluation. Now, what to do if you have patients coming for emergency surgery on DOACs? So do you reverse? Reversal agents are very specific. For dabigatran, it is an antibody developed against it. It is idarucizumab. Rivaroxaban, apixaban, it is Adnexet. Adnexet is a synthetic synthetic factor 10A. These are only indicated currently in case of major bleeding. If there is no major bleeding, you can not do it. And of course, if you have to do it, it has to be a multidisciplinary decision because you might be subjecting your patients to an added thrombotic risks. PCC is controversial, and the biggest issue is the cost in these scenarios.
Okay. The last final question to Bala sir. Now we had a major epidural for major laparotomy, but postoperatively we have to put the patient on DVT prophylaxis. So how to handle this epidural catheter with DVT prophylaxis? I mean, how would you recommend and how you go about it?
So there are clear guidelines, but I just wanted to enact a clinical scenario. For example, we get patients coming for bilateral total knee replacement, obese patients. So we decide to do a staged procedure. They get admitted on day 1, and the day 2 will be the first knee. And since they are very obese and they are prone for, the scoring shows that they're highly prone for DVT, they will need both mechanoprophylaxis and chemoprophylaxis. So we put them on the intermittent pneumatic compression device, and also we start them on enoxaparin, single dose, which is for just prophylaxis. So what we do is we time it on the evenings, and 4 days later or 5 days later, when you decide to go for the next knee, there is absolutely, you don't stop the dose of enoxaparin that was given the previous day, because almost there is 12 hours that has gone between the last prophylactic dose and you're putting the needle inside the epidural space. But for some reason, if this patient is on a therapeutic dose, and if you want to site an epidural, you need to wait at least 24 hours between the last dose versus your siting the epidural. So this is in a nutshell on the strategies that you need to adopt. Dr. Philip, you wanted to add anything to this?
I only supplementary, only affirmative and supplementary. So I just thought of, you mentioned that the surgeons are actually pushing to operate patients faster, right? So I think in future we will not get more time to get the patient ready for surgery. We might get less time. There was a subgroup analysis of the hip attack trial that showed that several even high-risk patients actually benefit, as Dr. Gopal said, from just having the surgery done and then going for the cardiac evaluation instead of losing maybe a day or 2 for doing an echo and doing this and trying to do troponin. So I think they will, our surgical colleagues, I see them moving towards more rapidly going to the operating room, even with high-risk patients, even with patients that have a troponin leak. So they will put more pressure on us, unfortunately. And then the other thing was the risk-benefit analysis. It's different for different procedures. The 2 points I would like to make is that spinal, as you correctly said, is much less likely to cause an epidural hematoma than an epidural catheter. Another point I would like to make is that if you look at the literature, the analyzed cases, there is one study about with 650 cases. So the most prominent time of neurological deficit with epidural is after removal, not with placement. Because for placement, we usually, if everything teed up, the patient is perfect, everyone checks 10 times whether everything's been done. But then you have an accidental removal on the floor, and all your plan is gone. So the majority of the highest incidence is after removal. And if we have a traumatic, something that we call traumatic, or where we are not sure about the neurologic symptom, a catheter is prematurely removed even, and timing hasn't been followed just by accident, then we usually do the same. We follow the patients. We usually follow them for 24 hours to make sure that, again, very litigious, to make sure that we're fine and that the patient is fine. Thank you for this wonderful session.
Yeah, I think we just have, the timing was up for the presentation, and I think we have 5 minutes more. So I think the take-home messages are, as Dr. Phillips said and Dr. Gopal said, I think we need to individualize the risk-benefit ratio based on the requirement of an emergency surgery versus the neuraxial hematoma versus the infrastructure which you're working. And I think it's a combined decision if you want to go ahead with a surgical procedure, a neuraxial procedure for a patient who has received clopidogrel before 5 days. If you think the benefit to the patient is more, I think it would be a combined decision of the surgical team, the anesthesiologist, written informed consent from the patient attendant after explaining to them the pro and con of doing the procedure, and then to go ahead with that, because always we are worried about the litigation and the legal implications which would follow. I think this would be possibly a take-home message for us. And most importantly, I just would wanted to repeat again that when clopidogrel is stopped, unfortunately, many places, the surgical team asks for a cardiology opinion, and they don't send it for the anesthetist to evaluate. And this patient suddenly comes and gets admitted in the hospital for a procedure. By the end, they have already stopped clopidogrel for 5 days, and they have not put on any antiplatelet drug. And now we are confronted with the situation. Now, what do I do? Do I go ahead or not? And I wanted to confess, like we have also had a similar situation, and though not so common, this patient, when we decided to go ahead with the procedure, we have had perioperative ischemia and infarction. So I think a note of caution, when you deal with a patient who has been stopped on clopidogrel, not on put on any antiplatelets, known case of coronary artery disease, coming in for a procedure, it is such an important thing to consider whether you have to go, just because he got admitted, the surgeon is putting pressure on you, would you go ahead with the surgery, or would you want to again discuss with the team and the attendants to take a call? So I think we tried to navigate through various factors regarding antiplatelets, anticoagulation, regional anesthesia, and what emerges finally is the case by case you need to decide, and then it should be an inclusive and combined decision. Siva, you want to add something? So, yeah, Dr. Mutta.
One more thing, whenever you suppose you go ahead with this surgery, just keep single donor platelets ready. So in case there is 1.5 times the bleeding, you have to infuse that, and also watch for the neuraxial bleeding. One more thing about that cardiac patients were, you always assess them clinically if the effort tolerance is good, and the revised cardiac index is showing that the risk of doing a surgery or the risk of giving anesthesia is less, you can go ahead. Only few indications are there for pre-operative angiography. That is a suspicion of a left main disease, failure, and unstable angina. There are no other indication of pre-operative angiography in any of the patient if their effort tolerance is good.
One glorious exception is carotid endarterectomy. These patients are almost emergency procedures, and especially if it follows a minor stroke, these patients come on loading doses of antiplatelet agents, and they are also on a therapeutic dose of low molecular weight heparin. And you don't have time to wait in them. You should not also. So we have done at least 600 surgeries with blocks in patients with carotid endarterectomies. So that is one exception where it is accepted that we go ahead with the patient on antiplatelets.
Only cases where you definitely have to stop is the closed chamber surgery, that is intracranial, intraspinal, intraocular, and TURP. There are no other surgeries where you have to stop because of this.
So thank you so much for being a part of this session, and thanks for all the contributions from Dr. Gopal and from all the participants. And we would want you to read more about this, about the new emerging factors. When Dr. Mutta said about single donor platelet, it looks simple but very difficult. Number one, the cost involved, I think it is 14 to 16,000, number one. Number two, it takes time, and this facility is not available in all the blood banks. Only very few blood banks can give you a single donor platelet. And the time duration taken to get a single donor platelet out is about 3 hours to 4 hours sometimes. And then not all patients can get a single donor platelet because they will see the veins actually. If it's a thin vein, you can't take a single donor platelet. So these are few factors that we need to keep in mind, the practical issues of the theoretical solutions.
Yeah, and even with patients on anticoagulants, you don't have any objective analysis because your platelet count will be always normal. It is a qualitative defect. The quantity will be always normal. So how much SDP is enough? That is a question which we cannot answer. And second problem is we are giving and deciding to give platelets to patients who are at high risk for thromboembolism. So when we are subjecting to a certain quantity of SDP, are we subjecting them to a higher risk of thromboembolism? And are we ready to take responsibility for the consequences? That is another question which we need to ask. So unless there is a significant bleeding on table, I don't think a preoperative antiplatelet therapy for invasive procedure makes any sense if there is any risk-benefit analysis. So the studies which are there for platelet cover for neuraxial blocks are mainly by Society of Obstetric Society guidelines, and they have definitive dosing schedules based on patient's weight, 5 to 10 units of SDP. But they also are advising it more and more that unless the platelet count falls below 50,000, do not go ahead and do SDP infusions. And risk benefit is not enough. And one more thing about HELP syndrome patients is they come with leaky capillaries, which means the leaky capillaries are everywhere, including lungs. And SDP is one blood product which can land up in trolley. And that is another factor which you have to look into. So it is important that we take a responsible decision for SDPs as well.
So thank you so much for your patience here.
Okay.
Thank you, Dr. Philip. Thank you so much. Thank you so much. Thanks for the contribution. Thank you.
We will be having the Aora quiz right now, so I request everyone to stay back. It's going to be a very exciting quiz. We have 4 teams and some really nice questions in regional anesthesia. Can I please invite the moderator for this session, Dr. Neeta D'Souza, on stage? We'll also be announcing the 4 teams. So can we have on stage Dr. Sushmita, Dr. Aparna Jairaj, Dr. Manognya, Dr. Smriti Warrior, Dr. K.S. Tenmozi, Dr. Ahmed Nawaz Khan, please start proceeding towards the stage. Dr. Thomas Francis, Dr. Nidhi Sultana. So, is Dr. Sushmita here? Okay, Dr. Sushmita, can you sit for team A? Dr. Aparna Jairaj. Dr. Aparna Jairaj. Okay, Dr. Manognya. Yeah, we've told them to come here at 5:30. Okay. We are calling. Dr. Smriti Warrior. Okay, you're in team B, so take your seat. Dr. Tenmozi, KS Tenmozi. Okay, team C, please sit there. And Dr. Ahmed Nawaz Khan, you're also team C, so please have your seat. Dr. Thomas Francis. Dr. Thomas Francis, yeah, so you're team D. And Dr. Nidhi Sultana, team D. Okay, so we are just waiting for 5 minutes for 2 people to come in. We have Dr. Neeta here who will be moderating the session. Okay, so our score master for today is Dr. Bhageshri Soor. Thanks, Bhageshri, for joining us. And can you please explain about the scoring system?
Just a second, Anandya, but how do they see the screen? They're sitting in the wrong direction. They'll have to see the question on the screen. Pull yourselves to the front of the stage and look at the screen. Ashok, 4 mic. 4 mics to them.
You're all comfortable watching the screen, right?
Vijay, the mic கொடுத்துரு.
Better if you are sitting down, screen will be good. Na? This is very near. Yeah.
Do we happen to have Dr. David over here? Or Dr. Navya, Dr. Sahiti? Okay, so your name is? Navya, you'll be joining team B. Okay. And team A is Sushmita. So, Sushmita, can you sit here? A, B, C, and D.
Thank you, I wanted.
Navya will be joining team B. A, B, C, and D. We are waiting for Aparna. Is she coming? Aparna? Oh, Manognya has come. Sorry. I'm so sorry. Manognya has come. Okay. Your team B. And Aparna. All right. So we have all our teams here. Can we have a big round of applause? Edika and me made some really difficult questions in elimination and all of them scored above 20 out of 25. So I think they are all winners already. And this is going to be more of a pressure test for you all rather than knowledge, because I'm sure that all of you all know RA very well. So just keep calm and answer. Vedika will be now describing the 3 rounds, and after that Bhagyashree will be describing how we are going to score it, and we have a timekeeper from the Vama events. So thank you so much for that.
Thank you, Janvi, for introducing the quiz. Congratulations to the final 4 teams. This is a pure RA quiz. So starting with round 1, we're going to have sonoanatomy. The rules will be put up, they'll be self-explanatory, we'll take it from there. Follow the instructions that will be given. It's not going to be much, just one line prior to the start of every part of round 1. All right? Part 2 is going to be case scenarios and clinical situations. Round 3 is rapid fire. Round 3 is where you can really pull your weight. Teams that were in the last will slip forward, so be careful and listen to the questions. You will have 1 minute for 10 questions. Answer as many as possible. No negative marking. No questions are passed on to another team. Over to Bhagyashree.
Welcome and congratulations all. For round 1, it's image-based. On identification, you will get 10 marks, and sub-questions, 3 sub-questions will be there, 10 marks each. Means total 40 marks for 1 question. Okay. In round 2, which is a scenario-based, where there are 2 questions, 10 marks each. Means if you correctly answer both the questions, you will score 20 marks. Okay. That will be divided in 3 parts, like upper limb, lower limb, and truncal. So you will be getting 3 questions in a rotation. Okay. In round 3, that is a rapid fire round, which is the final round, where you have to answer as much answers as possible in 1 minute, where 10 marks for each question, and there is no negative marking. Okay. For initial first and second round, you have to answer within 30 seconds. Okay. So timer, please be on it. Okay, on the screen for first 2 rounds, only 30 seconds, and for the third, 1 minute.
We'll be telling you about the timers as the rounds go. Okay, so this is the first round where we will be having the images, sonoanatomy, and we'll be giving 30 seconds to answer per image. These questions cannot be passed, and the first answer that you give will be considered as the final answer. You cannot change your answer, as simple as that. All right? Okay, so can we just quickly introduce Team A?
I'm Dr. Sushmita K. I'm second year DNB resident from Pune Hospital and Research Center, Pune.
I'm Dr. Aparna. I'm doing my regional anesthesia fellowship in Ganga Hospital.
I'm Dr. Smriti. I'm doing my Aora fellowship from Kokila Bay in Mumbai.
I'm Dr. Manoknya. I'm JR1 from VMMC, Solapur.
I'm Dr. Nawaz. I'm doing my Aora fellowship from Bhubaneswar.
I'm Dr. Tain Marie. I'm third year resident from AIMS Rishikesh.
I'm Thomas Francis. I just finished my PG.
I'm Dr. Nidhi Sultania. I'm doing senior residency in PGIMS Rohtak, Haryana.
Okay, so over to Vedika for round 1. We'll be giving 30 seconds per image. We'll start off with Team A.
So round 1, sonoanatomy. Each team will be getting a question from upper limb, lower limb, and fascial plane blocks. We begin with upper limb. Every team gets 1 image. These are your instructions. So first image is always the image of the block being administered. Name the block. Okay? Following 3 images are all based on the first image. They will show you 1 highlighted structure. It could be a nerve, a muscle, or a bone, or even an artifact. Identify what is highlighted in the picture. When multiple structures are identified, each component has to be named separately in order for you to gain the full point. No passing of questions to the next team is allowed in this round. Good luck. So shall we begin, Team A? And your time starts now. What block is this?
This is an infraclavicular brachial plexus block.
Correct. Moving on. What have I highlighted in the image?
Medial cord.
Correct. Moving on.
Lateral cord.
Correct. What is the muscle on top, followed by the muscle below that?
It is pectoralis major above, pectoralis minor below.
Very good. Now, passing on to Team B. Hold the timer. Don't start the timer yet. Mic is on? Yeah. Okay. Team B starts.
Interscalene block.
Interscalene block is correct.
Vertebral artery.
Yes, vertebral artery and vein.
There are two. So these, be aware of these things. I have highlighted two structures on the image.
Is the
Transverse.
It's very simple, red and blue.
The red is the vertebral artery. The blue is.
Time is up. That's the vertebral artery and vein. You will get half the points. That's it. Next. Identify the highlighted structure. If we have a pointer, I can show.
Vertebra. C7.
This is for us, no?
You can see highlighted, right? No doubts? Okay. Yeah.
The C7
Into the mic, please.
C7 vertebra.
Correct. What are these structures?
This is the
Timer? Timer? Sorry, you can try again. What are these structures that we see?
the long thoracic nerve and the dorsal scapular nerve.
Yes, that's correct. Sorry? The timer has not been started. So when the timer resets, I'll change. Okay. No, can we reset the timer when we change the image? Yeah. Okay. Shall I go ahead for Team C? Okay. Time.
This is supraclavicular brachial plexus.
Correct. Next.
That is the lateral. It could be suprascapular nerve.
Correct.
That's the first rib.
Correct. Moving on, sorry. Moving on to Team D.
There's one more structure.
Oh, sorry. My bad. This is the next structure for Team C again.
It's the omohyoid muscle.
That is correct. So, can we reset the timer when I change the image? Okay. Team D, on the ready? Timer start.
Axillary.
Correct. Changing image? Identify the structure?
Musculocutaneous.
Correct.
Ulnar nerve.
Correct.
Coracobrachialis.
Correct. So, over to, this was round one. I'm handing over to Score Master. Can you please update us on the scores up till now?
So, A scored 40 marks, B 35, C 40, and D 40. Okay.
So this round is also 30 seconds?
Still, we're on the next part of round one. We're still going ahead. So same 30 seconds.
Talk into the mic, please. Yeah.
Same 30 seconds. We're on the second part of round one.
Okay.
All right. So we're moving on to the next stage of round one. Is Team A ready? Okay, so moving on to the next. Note, for every image change, we need 30 seconds. Each image, 30 seconds. Moving on to the next image, this will be the round for the lower limb. Team A. Begin.
Femoral nerve block.
Correct. Moving on to the next image. What are the structures highlighted?
The one above is fascia lata and the one below is fascia iliaca.
Correct. Next image.
Iliacus muscle.
Correct. Next image.
Pectineus.
Correct. Team B. Ready? All right. Moving on to the first image for you all. Identify the block.
Hip peng block.
Mike?
Hip peng block.
Correct. Moving on to next image.
Iliopectineal eminence.
Correct.
Femoral nerve.
Correct. Next image.
Iliacus muscle.
There are two structures.
Iliopsoas muscle.
All right. So team C, are we ready? Okay. Moving on to your image.
Adductor canal block.
I'm sorry, but that is incorrect. So I will give you this so that you can get the next questions. This is the lateral femoral cutaneous nerve block. If you can't see, you can get up and come see the image. Some pictures will have orientation. Please refer to the orientation. All right?
Yeah.
Next image. Identify the structure.
Sartorius.
Correct. Next image.
Adductor magnus.
Sorry, that's wrong. This is the tensor fascia lata. Next image.
That's the LFCN in the the adipose pocket.
What is the name of what you're referring to?
LFCN.
What is the name of the pocket you're referring to? An acronym will do. We don't need the full form. All right. Pause timer. Pause timer. This is a free-for-all question for the audience. Prizes later, we can decide. Audi? Free fat-filled tunnel. Does anyone else have an answer? Anyone else with a better answer? Closer? All right, so this is the fat-filled fascial tunnel, FFFT. Okay. Team D, are we ready? Okay, timer can start now. What is this block?
Adductor canal block.
Correct. Next image?
Sartorius muscle.
Correct.
Saphenous nerve.
Correct.
Vastus medialis.
So that is wrong. This is posteromedial. It is your adductor magnus. Okay, so we're down with round 2 of round 1. Now we're moving on to fascial plane blocks. So this round is all about fascial planes. Team A, are we ready? Okay. Timer begin.
Fascia transversalis plane block.
So no, the answer is rectus sheath. I could have also accepted subcostal tap, one or the other, right? So moving on to the images. Identify this structure.
Rectus femoris muscle.
Yes.
Rectus abdominis, sorry.
Yeah. Oh, Rectus abdominis. That's correct. Next image, timer starts again.
External anterior rectus sheath. External oblique aponeurosis.
So this is the linea semilunaris. That's wrong. That is incorrect. Moving on to the next. Identify.
Transversus abdominis.
That is correct. So clearly we've upped the ante with the fascial planes. Next team, are we ready? Okay. Starting with your block.
Serratus anterior plane block.
That is incorrect. You are able to see 3 muscles, so this becomes your pecs 2 block. All right? Moving on to the next question. Timer? What is the structure?
Pleura.
Correct. Identify all 3 muscles.
This is the lowermost is serratus anterior muscle, pec major, minor, and then pec major.
So if you're going from below up?
Below up.
Okay, that is correct. Next image.
Ribs.
I want the numbers.
4, 3 and 4.
So that is incorrect. It is 4 and 5, but you will still get part of the answer for 4. So next team. Team C. Okay, moving on to your image.
Quadratus lumborum block.
That is correct. What structure?
That is the erectus spinae.
What is highlighted?
It's a vessel. Is it a vessel?
I can't give you that.
Can you unshade it?
So I can give you that's yellow, it's a nerve, but you have 4 seconds.
Okay, nerve. That is.
Time's up. That was your lumbar plexus root. You don't get points for this. Okay, next. To go. Next.
That is the quadratus lumborum muscle.
Correct.
That is the transversus abdominis. No, that's from posterior end. So that.
Abdominis. So this is perinephric fat. I've highlighted it in 2 areas. So I've also mentioned artifacts or structures you shouldn't be blocking can be highlighted. Okay, team D, are we ready? Timer starts.
Tab block.
Be a little more specific.
Transverse abdominis plane.
There are many tap blocks, little more specific. Time's up, so we would have gone with either ilioinguinal iliohypogastric block or anterior tap, one or the other. Half points, you get half for tap. Moving on. Can you see the structure that is highlighted on the image? Can you see it? It's on the right. Okay, identify the structure. Time?
Anterior superior iliac spine.
Correct. Next image. Identify.
Ilioinguinal iliohypogastric nerves.
Correct.
Transverse abdominis muscle.
That is correct. So all 3 teams have answered all 3 rounds of part 1. Putting a little pressure on the score master here. Yes. These images were tough.
So we randomize
After round 1, Team A scored 100 points, Team B 90, Team C 70, and Team D 105. So Team C, you have 2 more rounds to score.
So we're starting off with round 2, grand rounds. We're going to be having case scenarios. You have to identify what is the situation, diagnose it, and then there are 2 questions, 2 subparts to it, so you have to answer those. And you will get 2.5 minutes to do the entire case scenario. Alright? Okay. So for team A, first question is this. Mrs. Chatterjee, a 68-year-old patient, undergoes an elective hip replacement surgery under combined spinal epidural anesthesia. However, during the administration of the epidural anesthesia, she starts experiencing severe hypotension, bradycardia, respiratory distress, and pupillary dilatation. Identify the situation and give 2 important immediate steps of management. You have 10 points to answer each question. 10 points for each question. Identify the situation and then give 2 important immediate steps of management. There's no passing, there's no prompting. You have 1.5 minutes left.
Is it a vasovagal attack during the procedure? Is it just one answer, single answer?
Just one answer. So I'll tell you the situation. It's a total spinal anesthesia. Pupillary dilatation was the main point that you had to pick up. Okay, we'll still give you a chance to make points. Give 2 important immediate steps of management.
We have,
1 minute left.
we have to airway breathing circulation, make the patient supine, take control of the airway, intubate the patient, and then give adequate fluids. And for bradycardia, symptomatically treated atropine.
So you give fluids for the hypotension and atropine for the bradycardia. So you bring that down.
Just one thing, if you have any doubt about the clinical scenario, you can ask your question. Like probably you thought during the procedure the patient had bradycardia and vasovagal, but the epidural anesthesia means whether the drug was given or not. I think you could have asked the question.
Moving on to our next case scenario. Can we have the timer at 1.5? Alright. So team B ready? Yes. Mr. Bhatia, a 62-year-old male presents to the clinic with a history of undergoing total knee replacement a few days ago under combined spinal epidural anesthesia. He complains of persistent back pain and a gradual onset of symptoms over the past few weeks, like fever, back pain, and weakness of legs. On investigation, there is raised WBC count in blood and increased proteins in CSF. Identify the condition, identify the most common causative agent associated. You have 2 minutes left to answer this question. Answer it carefully, read every line carefully. There are many hidden points.
So the symptoms started few weeks ago and the surgery was done just a few days ago.
Okay, the symptoms started a few days after the surgery.
So both started together. Okay. Meningitis.
Fever, back pain, and weakness of legs. It is epidural abscess.
Okay.
Okay, identify the most common causative agent associated with it.
Staph aureus.
Yes, absolutely right. Okay. So can we have the timer for the next question?
high spinal. Yeah, since the patient has numbness in the hands and shortness of breath, so it's thoracic level up. It should be up because it's since there is shortness of breath also. Okay. Cervical level. C2. Because phrenic nerve will be involved. Yeah.
Post-dural puncture headache. After 24 to 48 hours. Epidural blood patch.
Is it local anesthetic systemic toxicity? 20% intralipid at 1.5 ml per kg bolus followed by a 0.25 ml per kg per hour infusion.
Diaphragmatic palsy. Hemidiaphragmatic palsy. Phrenic nerve block during the interscalene block. The flattening of the dome of the diaphragm on the chest X-ray. Flattening and
It should be femoral nerve block. Because the buckling of the knees there, quadriceps weakness. The treatment will be conservative. We'll wait till the effects wear off and supportive treatment in the meantime.
Intraneural injection in sciatic nerve. Pressure monitoring while injecting drug, less than 25, and PSI, and we can inject drug outside in the paraneural sheath, in avoiding the intraneural injection.
By dual technique, using both the USG and the PNS together.
Avoiding intraneural injection. Thank you.
For team A, can you please repeat the dose of the intralipid in last?
1.5 ml per kg bolus, followed by 0.25 ml per kg per hour. Per minute, per hour only. Per hour only.
Is it per hour or per minute?
Per hour.
Checked it? Yeah, because I remember it as per minute. We'll just check one more time. Yeah, we'll just check it one more time. I think it is per minute. I remember it as per minute, so we can't give you the second half.
Treatment, intralipid they have told, but the dose is not so 5.
You have a
Can
question?
we circle back to the questions within that?
You may not.
You will not have
But you have 10 questions. They will have to be read out, and you have 1 minute. I doubt you'll have the time to come back to the question. Team A has the misfortune of going first. Prefixed, correct.
chronaxia. Piezoelectric principle.
Correct.
Anisotropy.
Correct.
Subclavian perivascular.
Correct.
Lateral cord.
Correct.
Femoral nerve block. False. Clonidine. Interscalene brachial plexus block.
Yes, okay. So just like Team A did, you can interrupt us if you know the answer. Time is more important. Moving on to Team B. Team B.
You want team D, right?
Team A, last slide. Team A, last slide, the image. Okay.
Serratus anterior.
Time.
Pass. Amplitude.
Post-acoustic enhancement.
Correct.
Interscalene. Posterior cord.
Correct.
Sciatic nerve. False.
False.
Ketamine.
You got 8 questions, that's good. Pass quicker if you don't know the answer. Anyone?
Posterior cord.
That's incorrect. In patients with diabetic neuropathy, what was the duration of pulse with B? Short, medium, or long?
Neuropathy. What duration of pulse?
Time.
Long.
Correct. What is the term used to describe the number of cycles per second?
Frequency.
Correct. Ultrasound artifact produced by the reflection of ultrasound waves after encountering a strong and smooth interface, creating a mirrored image is called?
Mirror artifact.
Correct.
Which block would you give for distal endocarditis surgery?
Supraclavicular or axillary.
Identify the cord from which this nerve originates, axillary nerve.
Posterior cord.
Identify the block from the rope-motor response, contraction of adductor muscles of the medial thigh.
Obturator nerve.
Ropivacaine is short-acting, true or false?
False.
Name any one drug used for treatment of neuropathic pain.
Haloperidol.
Time's up.
Haloperidol, we were looking for pregabalin or gabapentin, so that's incorrect and your time is up.
So
The posterior is the correct answer. Yeah. So we'll give you that.
This is an image for the audience. Can you identify? Okay, team B, are you ready? Team B is like, something. Okay, we start now. Timer ready?
Yes, ready.
Which nerve innervates the rhomboid muscles, major and minor, both?
Pass.
Simulating currents of less than dash to increase the
Point 3.
acceptable. What is the term for the distance between identical points in adjacent cycles of a waveform in ultrasound called?
Wavelength.
Correct. Artifact occurring when ultrasound beam encounters two strong parallel reflectors resulting in repeated.
Reverberation artifact.
What supplementation am I giving for my brachial plexus block if incision is over the
Intercostobrachial.
Identify the cord from which this nerve originates, ulnar nerve.
Medial.
Okay. What are the two deep nerves to be blocked in an ankle?
Deeperoneal nerve or
Tibial nerve.
Posteriority. False. Fentanyl.
congratulations to Team A, the only team that managed to complete all 10 questions in rapid fire. And all other teams, you managed to get at least 7 questions, which we weren't honestly expecting. So good job.
Yeah. Okay, so Bhagyashree is going to be giving the final scores, and it's quite interesting. Meanwhile, the prizes, let me just announce the prizes. So we have prizes for the first 2 teams, and that's going to be free Aora registration for the next Aora conference. And also the first prize is you get 1 PNS each. All right, so Bhagyashree will be announcing the final scores now.
Okay, congratulations everyone. It was an amazing round, and you all are really amazing in the way you answered the questions. We have an interesting situation here, and all have scored really, really close by. So we have the 4th place goes to Team C with 190 marks. 2nd place goes to Team B with 200 marks. And we have a tie between Team A and Team D. So you are making us work extra hard. So 225 marks each. So we'll come up with a tiebreaker question.
So can I have the tiebreaker teams come a little bit closer and the other teams can come down? Can we have a buzzer? 1 buzzer. 2 buzzers, 1 for each team. You don't have a buzzer? You don't have a buzzer. Okay, so since we don't have a buzzer, it'll be the fastest fingers first. So you have to raise your hand if you want to give the answer. And the person who will decide who has raised, like which team has raised the hands first, will be Bhagyashree. There will be no argument about it. She's going to be watching your hands, that's it. So if you all want to sit in such a way that your hands are visible, please do. Okay.
Should we face the screen, ma'am?
No, there's no need to face the screen. We have our experts here which will be asking you questions.
Give it the mic.
We give you a 5-minute breather time because this is worth a lot of money. 2 PNS to be given. So can you guys reintroduce yourselves because a lot of audience joined much later. We would like to know who you guys are.
I have a doubt. If we raise our hand and if we don't answer,
No. So, very good. So then, you don't get the point. Automatically, the second team can answer.
so if we are sure about the answer, then only we have to raise the hand, you mean?
Yes. Do we give them negative marking for that? That's a valid point. Okay, we've got a buzzer. Forget raising the hand. All right. So we have a few questions that the expert will decide here. Dr. Harshal, the first question that they have is, if they press the buzzer but they don't answer, what happens? We just pass it on to the next team. If the next team is also not able to answer, then the question is cancelled. All right.
Is there any negative
marking? Okay, fine. All right. Okay. Why don't you come? Okay. Yeah. Can you mic? You all have to press the buzzer and then we say which team and then you will answer. Don't give buzzer and answer, okay? That's not allowed. If you do that, it's cancelled. No, sir said we are not giving them, but it gets passed on. And no buzzer and answer together. That's not allowed, okay? First buzzer, we choose the
And
team.
we will pass the question, to the other team. So more points for the team that gets the right answer and it will be passed. Okay, the first question. Are we clear on the instructions?
You press the buzzer, we'll tell you which team was first and then you give the answer. So team apple and team dog on the stage. Okay, let's not make it dog. Team delicious. No, they are team D, so that's why I named it. You've not finished. You have to wait.
Otherwise you answer at this time.
Okay, answer. Team delicious, answer.
B.
Okay, that is correct.
The superficial peroneal, the deep peroneal, the tibial,
Syphilis,
and the sural.
Perfect. 1 second. How many questions are there? There are 5 questions.
2 hertz.
1 second. Who was first? This team. Vama Events has decided it's this team. Okay. So you're first. Answer.
Okay. The current would be 1.5 to 2 milliamperes. And starting current is
okay. Continue.
2 hertz frequency.
Okay.
And 0.1 millisecond pulse width.
Okay, so right now, you all have got 2 points and they have got 1 point. And we have how many questions more left? 2 questions. First team.
QL 1, 2, and 3.
Pass it on.
4.
QL1, lateral QL, QL1, QL2.
You have to. So cancel. Both of you all get it wrong. There's only 1 question left. You are, so let's see who gets it. 2 points and 1 point. Last question.
Pectointercostal, it targets the anterior cutaneous nerves in the thoracic segment. And it is between the internal intercostal muscle and the
She said anterior cutaneous nerves between internal intercostal and completed.
Pectoralis.
Pectoralis what?
Major. It is wrong.
So this is between the transversus thoracis muscle and the innermost intercostals, and the pectoralis major. That won't be given. And for QL, the new Delphi nomenclature has come out. It is no longer 1, 2, 3. It is anterior, lateral, and that's what we were expecting.
All right. Thank you. Okay, so all of you all get a free Aora registration for next year, and also the winning team gets 2 PNSs. Thank you. Please give your details. All of you all give your details to us so that we can forward it to the event manager for the prizes.
फक्त एकच काय per question.
What?
Let him look it up and then we'll start. So again, I think the AORA convocation will be difficult. I'd like to invite our esteemed mentors and AORA core committee to the dais, because I think it's more than just the core committee. All the mentors will not have the core committee. I don't think the mentors have to come to the stage. So they're only core committee. Really? Are you sure? Because I think everyone comes on stage because they all have their fellows. I don't know. I'll ask.
Welcome to the convocation of AORA India Fellowship 2022 batch.
I would congratulate all the fellows graduating today. Can the AORA core committee and mentors please come to the dais? Can we have
the drum roll, please?
अरे हो सगळं रेडी आहे पण जरा वेळ तर मिळाला पाहिजे मला साऊंड चेकला यांना सगळं रेडी आहे
हो रेडी आहे सगळं. Hey.
Very good evening to one and all, and welcome to our evening program. It's a beautiful evening right here in Pune, and I welcome you all to this Aora 2023 convocation ceremony. So, before we get started, we have a little official business to take care of and get out of the way. I kindly invite our Secretary, Dr. Shivashanmugam, to kindly deliver the annual report.
Very good evening to the respected mentors, core committee members, Aora Exocom, fellows, delegates, ladies and gentlemen. So I welcome you all for this second Aora convocation for Aora Fellowship. So G.K. Crichton has rightly said that education is simply the soul of any society as it passes from one generation to other. Since the Aora Core Committee realized about this, it established the BOS in 2019 with a specific assignment to get completed. That is to develop a structured curriculum for an one-year regional anesthesia fellowship program, to develop and describe the method, how this curriculum can be delivered in a uniform manner across the country, and to develop the minimum standards that an institution and the mentor should possess to start the fellowship, and finally to create a monitoring system in place that monitor all these processes so that the educational program outcome can be met at the end. So with these things at us, we developed a structured curriculum which is available in our website in a downloadable manner for all the mentors and the fellows. And then the roles and responsibilities of the mentors have been clearly described in terms of curricular delivery. And then the Aora set about 500 regional anesthesia encounters in a year for our fellows so that they can become competent in terms of skill, knowledge, and in attitude. This is the highest number across the globe set for a fellow to get trained. So with these infrastructure, as of now, we have 18 centers have been accredited across India, offering the fellowship. And then this is our journey. Through this, we have traveled. As on today, 47 fellows have been graduated and 24 fellows are in transition to become a competent regional anesthesiologist. So our challenges are how to maintain an uniform curricular delivery across varying practices to ensure the quality of the end product is on par across India. So we have certain solutions for it. We have an online Zoom class across India for all the fellows. Individual fellow will present in front of all the mentors so that we have a structured way of assessing, analyzing a particular case so that at least in a theoretical ground, we are all on the same page. Then the Aora dossier form as well as the Aora app. These will be available with the students at hand while they are doing the block itself. It will help them to train their mind to think in the right direction. And then we are trying to create a feedback system which is an independent third-party feedback system which is going to analyze all the stakeholders of this curricular delivery and report to us so that the BOS can take a necessary action. So with these challenges, our future goals are to develop and to establish an unbiased, objectivized common exit exam, to implement this tier system so that we know the deficiencies before itself so that we will not pass on judgment at the end. And we are evolving the existing curriculum into a common competency-based curriculum. And we are creating a student exchange program so that the student can go from one institute to the other in case if they have any deficiencies. So with all these efforts, BOS is trying to establish a structured curriculum being delivered across India so that we can create a on-par fellows across the country. So whenever I talk about educations, the words of George Gregory, the legendary pediatric anesthesiologist, come into mind. He said that my goal has always been to make the resident and fellows better than I am. I have thought that if the residents and fellows finish the program and are not better than I am, I have failed. It doesn't always work, but many a time people turn to as good or better than I am, which is enormously satisfying. Without that as a goal, you are wasting your time as an educator. With these words in our mind, even our BOS try to do that. So with this kind note, let me congratulate all the passing out fellows and best of luck for their bright future. Thank you very much for your kind attention.
Thank you very much, sir. All right, time to get the party started. Okay, so now we'll have the official BOS procession. First up, this is our BOS, already we've been introduced to you. So first I request our President of Aora India to kindly grace us on it. Sir. Next we have Dr. Vrishali Pandey, who is the Chairman of the Board. Ma'am.
Hey.
Our Secretary, Dr. Shiva Shinmugam. Dr. Amit Dikshit. Dr. Vandana Mangal. And Dr. Murli Thondebavi. And Dr. Subramanya Mahankali. And including me, that's the Board of Studies. Next, we'll have the mentors procession, where all the mentors who have been and taken this journey along with our fellows. I kindly request you one by one, as your name is called, to please come and join the BOS. So first we have Dr. Bala Venkat from Ganga Hospitals in Coimbatore. Next we have Dr. TVS Gopal from Care Hospitals in Hyderabad. Dr. Azam Danish from Bhagaveen Mahavir Jain Hospitals in Bangalore. Dr. Ritesh Roy from Care Hospitals, Bhubaneswar. Dr. Rupinder from Dayanand Medical College, Ludhiana. Dr. Harshal from Kokilaben Ambani Hospitals. Dr. Hetal from Sterling Hospitals, Rajkot. Dr. Ramkumar Mirle from Manipal Hospitals in Bengaluru. Dr. Divesh Arora from Asian Institute of Medical Sciences in Faridabad, Haryana. Dr. Arun from Aster RV Hospitals in Bengaluru. Dr. Shishir Agarwal from Apollo Medics Super Specialty, Lucknow. Dr. Gajanan from Yashoda Hospitals, Hyderabad. And Dr. Sunil Pandya from AIG Hospitals, Hyderabad. Welcome to all of you. And now, to the fellows, our beloved fellows who have taken this year-long journey with all of us and finally reached the pinnacle. So let's get started. First, we have Dr. Megha. She has completed her Regional Anesthesia Fellowship from Apollo Hospitals, Bangalore. I request Dr. Murli Thondebavi, her mentor, and Dr. Sutish Kulkarni to kindly hand over their certificate. Dr. Renuka. She's completed her fellowship from Astra CMI hospitals in Bengaluru. And I request that Dr. Arun and Dr. Vrushali Pandit to kindly hand over the certificate to Dr. Renuka. Next we have Dr. Himashweta, who has completed her fellowship from Ruby Hall Clinic. I kindly request Dr. Amit Dikshit and Professor Vandana Mangal to kindly hand over the certificate to Dr. Himashweta. Next we have Dr. Poonam, who has completed her fellowship from Care Institute of Medical Sciences. I request Dr. TVS Gopal and Dr. Subramanya Mankali to kindly hand over the certificate to Dr. Poonam. Next up, we have Dr. Deepali. Dr. Deepali has also completed from Care Institute in Hyderabad. I request Dr. TVS Gopal and Dr. Satish Kulkarni to kindly hand over the certificate to Dr. Deepali. Next, I call upon Dr. Navya. She has completed her fellowship from Ganga Medical Center in Coimbatore. I kindly request Dr. Bala Venkat sir and Dr. Shiva Shanmugam to kindly hand over the certificate to Dr. Navya. And last but not least, we have Dr. Pradnya, who has also completed a fellowship from Ganga Medical Center in Coimbatore. I kindly request Dr. Vrushali Pandey and Dr. Bala Venkat to kindly hand over the certificate. And that completes our ceremony, ladies and gentlemen. I request all our fellows to come and line up with the mentors and the BOS for a final picture. I would also like to invite Dr. Sandeep Diwan, our academic director, to please be with us in the closing. Ladies and gentlemen, the 22 batch of Aora India Fellowship. And that concludes our session, ladies and gentlemen. Thank you very much for your kind patience.
I would, on behalf of the Executive Committee of Academy of Regional Anesthesia of India, would like to thank all the members of the Board of Studies for doing an excellent job. It involves when an institution applies that they wanted to do the fellowship program, then the Board of Studies sends one inspector to inspect that particular institution. There is a form that need to be submitted, and they would see there are basic minimum criteria is met by that institute. They have mentors, they have infrastructure, including the ultrasound peripheral nerve stimulator. They have adequate patient load, which will be very important to give hands-on skills to the student. So I think we would really like to congratulate the Board of Studies, headed by Dr. Sivashanmugam, Dr. Amit Dikshit, Dr. Subramaniam Ankali, Murli Tondebavi, Vandana Mangal Madam, Archana Areti, and Dr. Vrishali, for doing this in such a systematic manner. I think the exit exam also is, once they complete their one-year program, they need to maintain the logbook. And at the end of 1 year, the exit exam, they have an external examiner going and inspecting them the way they are good in regional anesthesia, which involves a theory paper, a practical exam where there's a viva voce, and many centers have moved on to giving a clinical case that is posted for surgery on that day, and they would ask the fellow to go and perform the block in the presence of the examiner. I think this is the purest form of assessing a super specialist, to know how well he can deal with the patient, how he stands, what's the ergonomics, what is the sterility, what kind of approach they use. So it's the purest form of probably analyzing a patient in regional anesthesia. And I think we heartily thank the Board of Studies. And we are also very happy that this has caught up, and several institutions have applied for this fellowship program. And I'm sure that in the days to come, we need to have more than an hour to do the convocation ceremony with more young brigade. But the eventual and the ultimate aim is to make sure that safe regional anesthesia and analgesia are provided for every single patient. And the aim of Aora is to make the entire nation literate in regional anesthesia. So apart from this fellowship programs, we also do several outreach programs where we go to smaller cities and do hands-on workshop, and the executive committee members have been doing it ardently across this country to increase the awareness. So I hand over to Dr. TVS Gopal to share a few of his thoughts. And if we look back, as I told in the morning, just started with 6 of us in 2011, and we see, and so happy and really privileged to see that the way we have grown up. And I'm very happy these youngsters were joining, the young brigade was joining us after completing their fellowship, will make sure that Aora will go strength to strength, more in terms of offering the best services to our patient. And we look forward for yet another excellent academic extravaganza in Hyderabad. And here we have Dr. TVS Gopal, who is going to spearhead the next year, the program of Academy of Regional Anesthesia in Hyderabad. Over to Dr. TVS Gopal.
Thank you, Bala. One of the biggest challenges we've faced in the journey of Aora is getting Sandeep Diwan to put on a suit and a tie. And though we are in Pune, and he is the organizing chair for this conference, he is in a t-shirt. So that is Sandeep Diwan, quintessentially for you, always down to earth, always smiling. First and foremost, I would request an ovation from the audience for Sandeep. Sandeep and Sandeep. I cannot forget Mutta. They are just like twins when it comes to conducting events. And kudos to your entire team, Sandeep, for putting up such a good show. I still remember in 2011 when we had the first AORA meeting in the Tata Memorial Hospital auditorium in Mumbai. And that evening we had the inauguration of AORA India in the ITC Parel Mumbai Hotel. I mean, it is now what, 13 years? And we've conducted 13 annual conferences, which is no mean feat for such a young organization. And the credit for all of this goes to each and every of our executive committee members who've been selfless, who've been extremely honest, and very, very forthcoming in their contributions for propagating the mission and the vision of AORA India. So going forward, we hope that we grow from strength to strength. It's been a long day. Now, I've been with this guy before at a personal dinner, and for the next 1.5 hours, your hands are going to go red. Tomorrow, you will get up requiring a Dolo 650, and I'm sure you will all be sweating profusely by the time he's put you through the paces. But that's a good way to build up your appetite for the drinks and dinner to follow. Sandeep, there are drinks, right? Yeah. Look at that, Ritesh is so happy. All right, thank you so much. Have a wonderful evening. I hope tomorrow will be as good as it is today, and hearty congratulations to everybody, and hope the workshops go as well. Thank you so much.
Just one more announcement. I think it's important to do good work, but more important to let this good work known globally. So I take this opportunity to welcome and invite as many of you as possible to the World Congress of Regional Anesthesia, which happens once in 4 years. This year in the month of September, it is in Paris. So I look forward for a large Indian delegation. I look forward for several of the fellows presenting their work in Singapore. Actually, this is the World Congress of Anesthesia. This is happening in the month of March 2024, another meeting which happens once in 4 years. So I request all the youngsters present here to target to be a part of the World Congress of Regional Anesthesia in Paris or the World Congress of Anesthesia in Singapore, present their work there in a global platform, and also see what the world is doing. And it will be very, very satisfying to see that the networking that you create and the aftermath of attending an international meeting will make you a better person and a greater anesthesiologist. So thank you so much. Look forward to seeing you in Paris and then later in Singapore.
I request everybody to be seated and get charged. There is something under your seats. Just take it out, and we'll start with the entertainment program. Everybody has to contribute to this entertainment program to make it very successful. Over to you.
different voices and keep drumming. Hey, 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 all of you. With the drums and the sound. Come on, up, left, down. So how you all feeling? Yeah, good. So keep the drums down for half a minute and do this. There you go. How many of your hands are hurting? And how many of your hands are red? Yeah, you need the ice at the bar, but not now. Okay, don't rush to the bar right away. Okay, do this. All right, so yeah. The bar is not open yet. So all of you have become wonderful drummers. Now let's all become wonderful singers. Yeah, how many of you sing? Okay, how many of you don't sing? Oh, bathroom singers, yeah. That's always the prompted third option whenever I ask this question, that how many of you don't sing? And then people are like, no, we are bathroom singers. So this is for all the singers, non-singers, and bathroom singers. Right? And the song is African. Okay? It goes something like this. As the drum comes from Africa, the song also comes from Africa. Okay? It goes, Kilele, Kilele, Abo, Abo, Kilele. No, but they sing it very strong in Africa. So it means coming together and celebrating. Right? Kilele, Kilele, Abo, Abo, Kilele. And now fill up for all the vacant chairs as well. Kilele, Kilele, Abo, Abo, Kilele. There you go. Abo, Abo, Kilele. Abo, Abo, Kilele. Abo, Abo, Kilele. Abo, Abo, Kilele. Kilele, Kilele, Abo, Abo, Kilele. With the drums. Kilele, Kilele, Abo, Abo, Kilele. Abo, Abo, Let's have a round of applause for each and every one of you out there. All right, so what am I going to do is, I'm going to just disrupt the way we are sitting. As we are less in number, we can do that, right? Yeah? What do you think? Because the real fun in a drum circle is making a circle out there, right? So I'm going to request you to keep the drums down, and I am the center, so turn your chairs towards me. All of you here are good. All of you just stay there. All of you just turn your chairs. You just have to turn your own chairs, don't worry. I'm going to make you turn all the chairs by yourself. All right. Fantastic. Sorry. All right. Ready, all of you? You can see me? Yeah? You can see me and hear me. All of you here. All of you are awake? Right. Perfect. Yeah, you can just turn the chairs towards me. There you go. Sorry to make you the chair turn, but I'm sure you'll enjoy this much, much better. Oh yeah, just let them be. Fantastic. All right, now this is like a drum circle. All right, let me hear the drum in the center, all of you. Sound better? Yeah? All right, so after me, I'm going to play something onto my drum and all of you will play it back to me. Oh. And smile to. So you have more reason to smile, right? 1, 2, back to the group, go! Drumming is about the unique rhythm that you bring in, right? So for example, my friend Avdut is playing something onto his drum, right? Can you please continue to play, right? So that's the groove. Shubham will add something to it, something else.